A very good morning to all and a warm welcome to Untangle the World of Ultrasound with Global Experts, an educational initiative by Life Mankind under the guidance of International Society of Ultrasound in Obstetrics and Gynecology. Today's webinar is dedicated to obstetrics ultrasound, the recent advances in 2023. The content is designed by renowned gynecologists and fetal medicine experts across the globe in collaboration with ICOG. Ultrasound is widely used in obstetric practice to detect fetal abnormalities with a view to providing prenatal opportunities for further investigations, including genetic testing and discussion of management options. Over the years, there have been several improvements in ultrasound technologies, including high-resolution ultrasonography, linear transducer, radiant flow, 3 to 4 dimensional ultrasound, spectral tackling of fetal heart and artificial intelligence, and many more. We are hopeful that today's session will help you to achieve a higher degree of proficiency in obstetrics sonography. Let me have the privilege and honor to introduce our Honorable Course Director, Dr. Prashant Acharya. Dr. Prashant Acharya is a Medical Director and Chief Consultant, Pius Advanced Center of Fetal Medicine, Ahmedabad, Honorary Fetal Medicine Consultant at SPVP Hospital, Gujarati University, Ahmedabad, ICOG Fellow in 2019, first Indian to be honored, ICOG Board Member and Trustee 2050 to 2019, ICOG Ambassador to Asian Pacific Region 2014 to 2020, ICOG International Faculty of Speakers, ICOG BIDS Committee, Founder Trustee Indian Society for Ultrasound and Obstetrics and Gynecology, Foxy Vice President 2012. With these words, I hand over the session to Dr. Prashant Acharya for introducing our faculty members. Over to you, sir.
Thank you very much, Dr. Ashutosh. It's all about making everyone understand what the obstetric ultrasound is and where you can utilize in your day-to-day practice. We have international renowned, the one of the best ever in the world today is Ravi Chavi, who is MD PhD with a professor of gynecology and obstetrics with the Center of Prenatal Diagnosis and Human Genetics in Germany. He was chair in ISWAG World Congress 2019. I know these gentlemen since years together now, more than a decade now. Since I think it was 2011, I first met him. He is one of the best ever teacher I have met in my life. There are many books he has written, but especially with one Bible kind of a book he has written on the fetal heart. And there are many scientific papers, monographs, and the articles which he writes, always accepted worldwide. And that's what the power of Ravi Chavi. He's with us to discuss in detail for 1 hour each with the two brilliant talks of him. We have another faculty is Dr. Ashok Khurana, who is a chairman and consultant at reproductive ultrasound at the ultrasound lab in Delhi. He used to be an ISWAG ambassador for South Asia and India, currently Secretary of Society of Fetal Medicine. And also he is one of the brilliant academicians across India. And the third faculty today is Dr. Naren Malhotra. He is from city of Agra. He's a managing director of Global Rainbow Healthcare. And he is basically interested in, he has got a multifaceted personality. He is one of the first one to brought 3D ultrasound in India, and way back in 1991, he bought the first ultrasound 3D machine in India, and he is professor at Croatia, honorary visiting professor. He was a president of India. Foxy, ISPAT, IFMB. He has got lot many feathers to his cap. So published more than 125 chapters, papers, presented 500 papers, and I know he is a brilliant orator too. So over to Naren for his talk on early pregnancy scan evaluation.
A very good day to all of you who are listening to this wonderful ISWAG webinar on by experts. So today I am Dr. Naren Malhotra from the city of Agra, the Taj in India, and I'm going to tell you something about early pregnancy evaluation and how to predict early pregnancy outcomes. So I bring you greetings from our institution and from the city of Agra. When we do first trimester ultrasound, the indications are confirmation of pregnancy, estimation of gestational age. You have to date the pregnancy, evaluate all the causes of first trimester bleeding, that is abortions, to evaluate cases of disproportionate uterine size, uterus larger than gestation or lesser than gestation, suspected multiple pregnancies, suspected ectopic, and of course, early anomalies. Before we go ahead and put in a probe and see the things, we should understand the fundamentals of sonoembryology. Now, embryonic period is from 4 weeks to 10 weeks. Day 17 or 18 of the menstrual cycle, if pregnancy occurs, it's a morula 0.1 millimeter diameter, and it enters into the uterine cavity as a blastocyst. Day 19 to 20, this blastocyst attaches to the endometrium, which is called as implantation. And there might be a slight few drops of implantation bleed. At this time, the blastocyst is 0.2 to 0.3, so still cannot be seen. Day 20, 24, 25, the implantation is complete and near the fundus laterally. Sometimes you can see this very hot area by power Doppler. So this is known as hot area, or a lot of blood going into that area. And day 29 to 30, that is 4 weeks, you see the chorionic cavity 1 to 2 millimeters. The smallest speck can be seen sometime. So sonoembryology, we see the gestational sac at 4 weeks, 1 week later by transabdominal. This is, I'm talking about transvaginal. Yolk sac at 5 weeks, fetal heart beating at 6 weeks, fetal movements at 7, fetal head and limbs at 8 weeks, cord insertion at 9 weeks, and you start seeing the FARCs and all 10 weeks onwards. And you can start measuring the BPD also 10 to 11 weeks onwards. So here you see the gestational sac, here you see the embryo, there is a subchorionic bleed here. Then when you put the color, you can see the color in the cardiac activity and on the trophoblast. And if you have Schillert imaging 3D, then you can see pictures as good as this from 8-9 weeks onwards. So let's take one by one of these structures. Gestational sac. Empty gestational sac can be due to normal intrauterine pregnancy, still it has to come. Otherwise, it is seen as uniform oval double bleb sign. So double bleb sign. And it could be blighted ovum, could be a pseudosac or an embryonic demise, pseudosac of ectopic, could be missed abortion, sac is distorted, angulated, irregular, like this, empty sacs. The yolk sac is the next structure, and it provides nutritive, metabolic, endocrine, and immunological hematopoietic functions. And it is seen by the end of 5 weeks and the beginning of 6th week. So that is the yolk sac in the chorionic sac. And in the very small ones also, the first identifiable intra-sac structure is the yolk sac, as you can see. More than 8 millimeter of gestational sac should have a yolk sac. So this could be predictive of pregnancy, continuation of viability. Now, 16% of non-viable pregnancies still show a yolk sac. So just seeing the yolk sac does not say that pregnancy is 100% viable. You have to wait for the fetal heart and the yolk sac grows at the rate of 0.1 millimeter, and that is of the mean sac diameter. Now, the yolk sac may not appear. It may be too big, more than 6. It may be of abdominal shape, as you can see, triangular or oblique, or it may be double. It may be freely floating. It may be fully calcified. It may be fragmented material inside, and it may be echogenic. So there are abnormalities of the yolk sac, and these abnormalities of the yolk sac indicate genetic chromosomal defects, but not confirmed. So you start suspecting them. Then we start seeing the fetal pole, And the fetal pole is close to the yolk sac, as you can see here. 20% can be seen by 6 weeks, and 75% should be seen by 7th week onwards. 100% by 8th week, and 100% when the gestational sac diameter is 16 millimeters. So if it is not like that, then again, you start suspecting it is a missed abortion or abnormal pregnancy. And then you can measure the crown rump length when you see the yolk sac, when you see this fetal, from 8 weeks onward, we can start measuring the crown rump length. And this is the most accurate time to date the fetus. So that's it. So embryo is a small focal area eccentric to the gestational sac on the margin of the yolk sac, and you can start measuring it from toe to rump. Then the other embryonic events are 5.5 to 6 weeks. You see the dots of limb buds. 7.5 to 8 weeks, you can identify the upper limb buds. 8 weeks, the ossification center of the clavicle. And 9 weeks, the ossification center of the mandible. And 10 weeks to 12 weeks, the ossification of the frontal bones here, as you can see here. So this is what the embryonic. Now here are some pictures of every week. 6 weeks by 2D grayscale, 6 weeks by chroma, and 6 weeks by doing a Shillot imaging. 7 weeks Shillot imaging, yolk sac, gestational sac, and when you put the color, you see that the color is all around. Crown rump length measurements is the head to body ratio to 2:3 by 7 to 8 weeks. So it is important to exclude the yolk sac from the measurement. At 7 to 8 weeks, there is a marginal difference between the width and the length. So you don't measure at 7 weeks. Start measuring at 8. A measured fetus, in the fetus having a normal curvature. So it should not be extended or too straight. Acute flexation is seen when there's a bladder pressing it, and then you take 2 or 3 readings to get the correct one. So accuracy of a CRL for dating is plus minus 5 to 7 days. That you have to remember. The margin of error in measurement of crown rump length is plus minus 1.2 millimeters. That is 2 standard deviation. Now, a rule of thumb is gestational sac. You add 6 to it and you get the gestation in weeks. So gestational age is crown rump. Supposing crown rump is 1, add 6.5, so it becomes 7.5 weeks of pregnancy. Now, this is not used. This thumb rule is not used after 12 weeks because then the fetal curvature is there. So 8 weeks onwards, we start seeing the fetus like this: 2D, 3D, 3D Shillot, 3D Shillot color Doppler imaging. And then comes the limb buds, paddle-shaped limb buds, as you can see in this lower picture, by mid 7-8 weeks. And then these limb buds the fetus start showing some movements at about 8 weeks. So fetal movements will appear at 8 weeks. At this time, you can measure the thoracic trunk diameter, which is 11 millimeters at about 10 weeks. So about 9 to 10 weeks, you start measuring the trunk diameter, earlier also, but these are not taken for gestation. They're just that you can measure. 9 weeks, 3D Shillot imaging, 3D Shillot with color Doppler. 10 weeks, 3D imaging, 3D Shillot imaging like a glass, and 3D power Doppler Shillot imaging show the complete vascularity of the fetus. And that's how a fetus looks at 9 weeks, when you can see practically everything. So once you can get good pictures like this, then almost everything can be diagnosed in the first trimester. We can start measuring the BPD 8-9 weeks onwards, but not very accurate, only after 10 weeks when the FARCs have formed properly and the choroid plexus is formed and cavum septum pellucidum is formed, then we start measuring or taking BPD. Amniotic cavity. The fetus lives in an amniotic cavity, and the whole thing is a chorionic cavity. The chorionic cavity or the gestational sac and the amnion inside. So inside is the amnion, in which is the fetus, and the yolk sac is outside the amnion, in between the chorion and the amniotic fluid. Now this has to be identified because you can make mistakes here. You can make mistakes by if it is too less fluid, too less amnion, big chorionic cavity. Amnion is too less here. Amnion there is extracelomic. Then there could be a hydrops which would appear as amnion. So be careful of that. Very early small amniotic sac or very early oligohydramnios. Bad prognosis here. Bad prognosis of these babies, and this is generalized edema, which is misinterpreted by like amnion. So be careful of these signs. So generalized edema in fetus will be misinterpreted. And sometimes the amniotic membrane is lying posteriorly, and then this cystic hygroma can mimic this. Also, the nuchal translucency you might measure wrongly if the amniotic membrane is posteriorly and the fetus is back down. Then what else can we see? We can see the umbilical cord and the placentation. Bright echogenic linear structure is the umbilical cord, and by color you can see the pulsations, and you can see where the implantation of the placenta is going to be. The cardiovascular system at 6 weeks, the blood flow is unidirectional. 8 weeks, the heart has got a definitive here. like here you see here, 2 chambers. And then by 10 weeks, the peripheral vascular system develops. Here is a 10 weeks peripheral vascular system, as you can see in these two in the center pictures. The cardiac activity, if there is bradycardia or if there's tachycardia, both are problematic. So at 6 weeks, the fetal heart should be 85 to 100. At 9 weeks, not more than 160. Early fetal bradycardia is an indicator for triploides and for bad prognosis. So that you can be there. The GI system, the primitive gut is there at 6. It is all outside. Then it undergoes the rotation and goes inside, and inside it closes. So sometimes up to 12 weeks, you can see the physiological herniation of the gut outside in the umbilical cord. But as soon as the posterior mesentery forms, this will go in. 8 weeks, you can start seeing the rectum, and 10 weeks, then the anal canal will perforate. So that is what the embryonic events are. So what about the first trimester problems? The first trimester problems which you can, and you should be diagnosing yourself or getting a report, is early pregnancy failures, threatened and missed abortions, and some anomalies. So definitive signs of early pregnancy failure is there is an absence of cardiac activity in an embryo. So you see the embryo and no heartbeat. Definitely it is a missed abortion or an embryonic demise. Absence of yolk sac or embryo in a very large gestational sac. The cutoff will just tell you. So that is blighted ovum. So these are diagnosed as failed pregnancies, or early pregnancy failure is your report going to be. Now, what is the discriminatory size to make a safe diagnosis? You depend on the sac diameter and you depend on the CRL. Because sometimes you see a small fetal pole and you don't see a cardiac activity because of the machine settings, and you label it as missed abortion, and it keeps growing and someone else sees the cardiac activity. So you need to have some guidelines. So the guidelines for discriminatory are by transabdominal or by transvaginal, a gestational sac of 20 millimeters or more without a yolk sac, or an embryo of 25 millimeters or a sac of 25 millimeters without a cardiac. By transvaginal, it is less. 8 millimeters without yolk sac, 16 millimeters without embryo cardiac activity. When you see the embryo, 8 millimeters by transabdominal, no cardiac activity, missed abortion. By transvaginal, you start seeing the cardiac activity at 4 to 5 millimeters. So the cutoff can be taken as 4, or to be safer, take it at 5. Now, different societies have different cutoffs. And the cutoffs given by the Royal College RCOG is 6 millimeters crown rump length and 20 mean sac diameter. The given by Canadian Society is 5 millimeters crown rump length and no cardiac activity, and by abdominal 9, and mean sac diameter 8 millimeters or 20 by abdomen. The American College gives 5 and 16. The Hong Kong College gives 5 and 20. The Australian College gives 6 and 20, 6 CRL and 20 without a yolk sac, gestational sac. The Philippines practice at 5 and 18. A few years back, we in India, from our Federation of OBGYN Societies of India, FOXY, we gave that it is safest to label as missed abortion when you have a mean sac diameter of 20 without a yolk sac or an embryo, or a CRL of more than 6 without a cardiac activity. And this was endorsed by the Indian Federation of Ultrasound, the Indian College of Medical Ultrasound, and the Indian College of OBGYN. So we have our cutoff in India like that. So the best criteria would, of course, be 25 or 20. Now, up to 4 in every 100 diagnoses may be false positive if you take a smaller sac. And that is what literature says. So there are still a number of cases at or around this critical level, which is known as the discriminatory level, to define miscarriage. So there is a need to increase the cutoff. If you increase the cutoff, you might miss a missed abortion, or you might be a missed abortion may carry on for 1 more week, which might be harmful. So the final recommendation is that an empty sac with a mean sac diameter of 25 without a yolk sac or an embryo and an embryonic demise is diagnosed as a CRL of 7 millimeters without cardiac activity. And if it is lesser than this, wait for 7 days and then repeat the scan. If it is below this, discriminatory limit. So 7 and 25 is very safe. So for early pregnancy failure, the current criteria is being used, and a new cutoff of 25 and 7 should be taken. So we from Foxy will also modify from 26 to now 25 and 7 millimeters. So this is going to be 100% specific, and there is not going to be a misdiagnosis. Now, based on this, you will label that pregnancy as a threatened abortion, normal pregnancy, inevitable abortion, where it is the os is open and it's coming out, incomplete, where you see some retained products, missed abortion, as I told you, 7 and 20, recurrent pregnancy losses, you have to evaluate, medical termination, pregnancy pre and post, embryo reduction of high order multiple pregnancy, and needling of the treatment for ectopic. This is what we will do for the abortions by ultrasound. Then there is color Doppler and there is Schildt imaging. Now this Schildt imaging gives you lovely pictures. It's like a look through the volume to see the inner structures, just like the body was made of glass. And this can be applied to our daily ultrasound in the first trimester. So monochorionic twins, monoamniotic twins, dichorionic, diamniotic twins, new technology, diamniotic, dichorionic twins, and to make out the problems. And these images have been given to me by GE Apollo, thanks to them. Abnormal fetuses or heads, and the whole vascularity of the fetus at 9 to 10 weeks. The pulmonary artery and the vein can be identified by these. The diamniotic, dichorionic, the amniotic membrane and the growth and the fetus details. Only the vasculature of the fetus, the cerebral and 13 weeks, the brain vasculature, you can see the brain vasculature. You can see the cardiac vasculature, the normal heart at 12 weeks, and that if you can identify the cardiac normal heart at 12 weeks, the normal heart at 12 weeks, and various images. And again, at 13 weeks, the normal heart to be identified. So very early fetal echocardiography can be done. Abnormally, ventromegaly at 13, 14 weeks, ventromegaly at 13, 14, up to 16 weeks can be to see the lateral ventricles enlarged, and the third ventricle, and an enlarged fourth ventricle also. So we wait till 16 weeks when we suspect all these. Holoprosencephaly, semi-lobar holoprosencephaly, the spine and the vertebrae at 13, 14 weeks. Skeletal dysplasias, we do not diagnose them for early. We just wait, but you can start suspecting skeletal by if you get pictures as good as this. The whole vasculature of the fetus and the umbilical cord and power Doppler Schildt vasculature, the whole cardiac and the aorta and the upper vasculatures. Then a few words about the early fetal anomalies we can detect. So we can detect a lot. And we know, according to Nicolaides, the 11 to 13 week scan is the most important, and it will be spoken in details. I'm just going to give you an overview of it. And so we use for prenatal screening, we use ultrasound, biochemistry, cell-free DNA in the first and second trimester. For aneuploidies, for anomalies, we use high resolution transvaginal 3D and Schildt imaging in the first trimester. And for prediction of preeclampsia, again, we use the first trimester by uterine artery Doppler. And now we are coming to first trimester cervical length measurement also for prediction of preterm labors. So early anomaly scan is done by transvaginal 3D. And look at this, 6 weeks abnormalities, 8 weeks abnormalities, 10 weeks, 9 weeks. So if you have a good ultrasound, and if you have good 3D and Schildt imaging, you can start suspecting all these anomalies. You can start suspecting structural defects, and you can get a good favorable diagnosis. You can start suspecting acrania, holoprosencephaly, exomphalos, body stock abnormalities, gastroschisis, megacystitis in first trimester. These are always detected, 30% always. First trimester screening, spine, the major defect of spines can be picked up by looking at the spine here in the lower picture, and by looking at the signs in the fourth ventricle. So that signs. Major defects, undetectable defects, some undetectable defects in first trimester are there. So we do need the second trimester scan also for anomalies. corpus callosum agenesis, cerebellum hypoplasia, sequestration of esophageal atresia, bowel obstruction, hydronephrosis, diabetes. Now, these are major defects which can be seen in the first trimester. So, acrania anencephaly, very easy to diagnose. By 13 weeks, all of us should be able to diagnose. Holoprosencephaly, again, we should be able to diagnose, all of us. Normal bladder megacystitis can be suspected at 13 weeks in the first trimester. Exomphalos and early detection of fetal defects, like here we did with this baby. Fetal skull ossification centers, gastroschisis, and you can see this gastroschisis here, or exomphalos. First trimester, encephalocele behind the nape of the neck, in the occipital region, and at the spine. So you have to look for it, and you have to know. Facial clefts also have been diagnosed by reverse 3D and even by 2D examination. Diaphragmatic hernia, you suspect, you don't diagnose at it. And if you suspect, then they can undergo or can be sent for an intrauterine fetal therapy for blocking the esophagus. And that balloon is taken out just after delivery. Body stock abnormalities, especially if the patient undergoes CVS and limb reduction syndromes and all that. Then molar placenta, molar changes in the placenta. Again, by 13, 14 weeks, we should be looking at molar changes. Holoprosencephaly, abnormal fingers, abnormal hand, abnormal fingers, spinal defects, screening for spinal defects, as I told you. Signs of open neural tube defects, open spinal, lemon sign, and all 13. Looking at the fourth ventricle, the normal and the abnormal. Thank you for Professor Robicha for letting us use these pictures. He's there with us in this webinar, and you'll be hearing and seeing some very, very good pictures for this. So, ladies and gentlemen, the first trimester is a good window for both structural anomalies, screening of chromosomal anomalies. With the 3D and the 4D Shelot imaging, the detection rate have increased. Let's look at the anomalies. 5% environmental, 25% chromosomal etiology, 20% single gene disorders, 50% complex. And your NIPS picks up 75% of chromosomal anomalies. Your CVS, amniocentesis, whole genome sequencing, and others will pick up single gene disorders and chromosomal. But it is the ultrasound which will suspect any etiology of anomalies. So ultrasound clinical information is much more than molecular technology. And the ultrasound technology is now improved. So it is ultrasound it was, ultrasound it is, and ultrasound it will be forever. For all of us, and all of us should be aiming at fetus first. And look at the fetus at the first trimester to make complete diagnosis of viability, dating, abortions, anomalies. That's it. Thank you very much for giving me this opportunity to express some of my views on first trimester ultrasound screening and scanning. Thank you.
Thank you very much, Naren, for giving us a highlight about how to look for the first trimester, early first trimester ultrasound. And now I think it's my turn to let you know how the things you should be looking at your first trimester aneuploidy assessment of the fetus. So whenever you are looking at an early first trimester scan, the best thing is you should be looking for a couple of things. From up to 10 weeks, then you start moving further. You continue till for first trimester till 14 week. Then it's about aneuploidy assessment. Then it's also about the fetal assessment, about the malformation. Malformation Ravi Chavi is going to take. I'll take you through how you should be doing a fetal aneuploidy assessment during first trimester of the pregnancy. The same thing you do it for the second trimester aneuploidy assessment, anomaly assessment, fetal echocardiography, and fetal neurosonogram, and so and so forth. And in the last trimester, it's all about the fetal growth and the Doppler, which we are going to take you through first trimester, second trimester, as well as the third trimester during today's morning session. So moving further, thank you very much again, Mankind Pharma and Shambhu, for organizing such events so that we all can have an ESWOG approved course with the international faculties. And I'm thankful to you especially for the success of Scan.Academy, because we could organize more than 35,000 people attending those Scan.Academy programs with me, Aris Papa Giorgio, and Simon Mark, in especially during COVID times and since last 2 years line. So in 2023, our expectations are really very high from ultrasound machine, because there is a definite improve in the technology, there is a definite improve in the resolution, and because there is improvement in the resolution, you can see the fetus through and through. So you're and much earlier, so your expectations are always going to be high for the diagnosis. The moment you end up doing some of the diagnosis, then you also end up in investigate and also then treating. So it's about the complete fetal medicine practice, or fetal ultrasound practice, or obstetric ultrasound practice has gone to a different level since last a decade, because of the improvement in the technology, and thanks to the companies like all ultrasound companies like GE, and they have taken up the challenge to make people aware. We still, there are a lot many parts of the world will pyramid kind of practice. One visit in first 3 months, then every month, then every 15 days. In the last month, we asked them to come every week. But then there was a gentleman called Kypros Nicolaides, who he said one examination 12 week, one examination 20, then straight ask her, that lady, to come at 9 months and see for the problems. But there were lot many lacunae in this evaluation. So turning pyramid was not helpful in India's practice, especially in the developing world, because there are and recent development of lot many other issues. So what we thought at our center in Paris, and we have published what we call as a tube of pregnancy care. And that tube of pregnancy care, what is this tube of pregnancy care? Is the first scan at 3 months, second scan at 5 months. In 3 months, we do first trimester aneuploidy assessment. Then we do early anomaly detection, pre-eclampsia and preterm risk prediction with or without NIPT, the cell-free field DNA. At 5th month, we ask for 20 to 23 weeks for anomaly scan as per ESWOG guideline, or rule of which Paris we have published. A neurosonogram, basic echo, soft marker, cervical length for preterm birth prediction, uterine artery for PET risk prediction. That's what we are doing at 5 months. That's what common practice. But we have added a 7-month scan. Now there are few reasons why we call it a 7-month scan, because there are few late developing anomalies. If I don't perform any scan, and when I ask that lady to come at 37 week, I'm going to miss this late developing anomalies. Second important point, I'll give you a few of the examples. So some of the skull dysplasias which are going to develop late, lung malformations, thoracic malformations which may develop late in the pregnancy. So we are going to miss those malformations. Some of the cardiac malformation also will be appreciated late. They will be there, but the appreciation would be relatively better at 28 week of gestation. One of the most important point is going to be the identification of the fetal growth fetuses, what we call them as an early growth restricted babies. And why it is important, we are going to discuss today late in the afternoon, why it is important to diagnose early growth restricted babies. And one of the nightmares for the obstetrician is to find out a placenta accreta spectrum when they open the abdomen at a 9 month of pregnancy straight away. So we identify early growth restrictions, we identify placental pathologies, and also add on identification of the late developing anomalies. And is one of the reason why we have added a 7-month scan. And of course, at a 9 month, we identify the late developing anomalies. We also identify the late growth restricted fetus, those who develop growth restriction after 32 weeks, because the management is totally when you identify a baby who develop growth restriction before 32 weeks and who develop a growth restriction after 32 weeks of gestation. And of course, identifying the placental pathologies, identifying the cardiac anomalies, and whenever necessary, you shift that in utero to an appropriate center to take care of them, like a total anomalous return or a complete transposition of great arteries. They are the ones who need a real care. And duct dependent lesions where you may have to start the prostaglandins. So that's the reason, like 3, 5, 7, and 9, easy to remember. the moment you ask patient, every 2 months, 3, 5, 7, and 9 go under scanning, and we will be able to identify. Because nowadays, patients also expect that every anomaly has to be identified as soon as they are diagnosed, or what they expect is you should be telling them everything at 3 months or a 5 month. So that is one of the reasons why we have come out with a tube of pregnancy care, and that is 3, 5, 7, and 9 months of the pregnancy. So at the end, we achieve 12% better diagnosis of growth restriction related issues, and also 2% increase in the fetal malformation related problems. As I told you, early and late growth restricted management is different, and placental pathology better managed. So we survive, we give a better outcome for the fetus as well as to the mother. And that is one of the reasons. And here, what I want you to I want you to understand that 3 month first trimester aneuploidy assessment, that is where I'll be interested and taking you through the journey of that. The recent ISO guidelines, they have come out with the recent guidelines of 11 to 14 week scan, which is going to be a very different. You have got 3 major segment: aneuploidy assessment, then anatomy assessment, and other assessment. There's a list. Now it's not about the measuring CRL, or it's not about the measurement of nuchal translucency or nasal bone. It's a huge spectrum. It has gone to 11 to 14 week scan. I'm going to discuss the blue segment of aneuploidy assessment, the anatomy assessment. Professor Ravi Chavi is going to discuss what these anatomy assessment, and of course the other assessment, preterm birth, PET, fetal growth restricted, restriction prediction, multifetal pregnancy, genetic conditions, and Rh negative mother. Everyone has got a special thing for them in 11 to 14 week scan. So let us I'm going to take through. Apart from that, we have got a rule of 2. Easy. You can take a printout of this and put it in front of your ultrasound machine, so that this is a checklist kind of thing. Okay, have I taken fetal biometry for 5 things: CRL, BPD, HC, AC, and FL? Yeah, you are done. Have you looked for the soft marker, that is a nuchal aneuploidy assessment, nuchal translucency, nasal bone, plus FMF angle? Now nobody take the FMF angle and looking for a tricuspid agitation, and that is what the things are. But all in all, if you want to how to carry it out, just 1, 2, 3, 4, 5. So just remember 1, 2, 3, 4, 5, and 10. If you know this figure, then your first time assessment is complete. Biometry, as I told you, 5 things: CRL, BPD, HC, AC, and FL. 4 things for aneuploidy: nasal bone, nuchal translucency, ductus venosus or tricuspid agitation, fetal heart rate. These are the 4 things. Then basic cardiovascular system examination, that is situs, 4-chamber view plane, and the 3-vessel trachea view. Even if you can identify these 3 things, as position of stomach, 4-chamber, 3-vessel trachea view, you are done with 80% of the cardiac malformations you will be able to identify, or at least you will be suspecting there's something wrong in the fetal heart. Prediction, you measure one thing is a cervical length, and when you are interested at the major FGR prediction, there are 2 uterines you should be measuring, and that is a uterine artery Doppler. But whenever you are interested in anomaly, apart from Leica and placenta, the fetal evaluation is anomaly scan. There are a list of 10 things which you should be identifying, and that's Professor Chavi is going to take through this. What I'm going to take you through this is aneuploidy assessment of the screening. Brilliant new thing has come up with ISO guidelines in 23. So they are the recent one. What they ask you to take a CRL, BPD, HC, then abdominal circumference. Also look for the femur length. Take a mid-sagittal section of the brain, that is a nuchal scan image. You look for the nasal bone, nuchal translucency. Look for the intracranial lucency. Take the ductus venosus. Take the tricuspid agitation, and take the uterine artery Doppler, and then look for the anomaly scanning. And that is what, as per the ISO guideline, you should be looking for. But I'm going to take you through the journey of these 3 sections, E, F, and G section. That's what my job is to do today, to make you understand every little thing about the thing. Now, look, let us move as per the list. Fetal aneuploidy assessment, there is a general aspect that every lady has got chance to to have a trisomy 21 baby. Now, are these Down syndrome babies are enemy? Probably it's about how you think about it. The moment you are after diagnosis, after diagnosing all trisomy 21, and when at end of the pregnancy, when you find your obstetrician says that, oh, the baby which has come out having Down syndrome, I mean, what is your feeling? Tell me very honestly, what you are thinking. Is it your defeat? Are you defeated by nature, that okay, you tried everything, but still that baby has come out with a Down syndrome? And if you could identify a Down syndrome baby during a 3-month scan with the absent nasal bone or increased nupple, doing a CBS, and you could say that it's trisomy 21, that couple decides to abort, is it your win? It's matter of it. So whatever you feel, it's correct. I don't say that it's win or defeat, but as your job is to let the couple know that what is there inside her womb. Is it trisomy 21? If they want to continue, it's their decision. It's none of my decision or none of our decision. But the problem is, whenever you don't diagnose Down syndrome, or you don't keep put in your efforts to diagnose Down syndrome, and when baby comes out, you may end up in having a litigation for not letting them know the situation of the baby inside. So it is our duty, rather than thinking like win defeat enemy, it is our duty to identify whatever is there inside the inside the uterus baby, whether it is having Down syndrome, or whether it is having any other aneuploidy, other genetic disease. In a broader term, it's any genetic disease, whether it is there or not. That's what our job is as a specialist. My job definitely is to identify a possible genetic syndrome, those who come with a history of some genetic syndrome, and when we diagnose, it's a great thing. Yeah, of course it is good thing, but it's not a great thing. But when they are not suspecting, and when you identify, look, there are some signs, and you could pinpoint some of these genetic conditions, is something really good about your knowledge, and about your expertise. Now, why? Because the review of literature says that overall incidence of fetal malformation is almost about 1 to 2%, and half of them are because of the structural anomalies, and almost half are because of the chromosomal anomalies. And out of this, 66%, more than half are going to be because of the trisomy 21. So it's about lot many things about trisomy 21, because the incidences are relatively higher. There are some issues with the trisomy 21, is because they can survive, they can live throughout the life, whatever life they have. So the family will have an additional burden, or even as a society will have additional burden. Whereas trisomy 13 and 18, of course, there are very, very, very rare. I haven't heard of anyone who is alive with 13 and 18 after birth. So family will curse you once they find a trisomy 13 or 18 with a malformed baby when it delivers. But it is not creating burden on that particular family for a long time. Of course, there is going to be a mental harassment, but no long-term harassment for family or for the society. Whereas trisomy 21, yes, they will have lifetime mental harassment. Also, a society will also have a lifetime burden from them. So I wish that put in all your efforts, try to identify all genetic conditions, because you must have seen so many metabolic disorders where the couple comes to you with the all delayed milestones in the baby. They bring the baby in such a bad shape. Their entire life is miserable. So we don't want to give such kind of life to couple especially. So that's the reason I request you to go through the thorough investigation of the baby as far as the findings are concerned. Sonographic finding of fetal aneuploidy you can identify during the first trimester marker. You can also identify during the second trimester marker. You may of the structural defect which may suggest a possibility of aneuploidies. And there are some soft markers. Say, for example, you have got atrioventricular septal defect or exomphalos. They may suggest that, okay, there are very high chances of trisomy 21. Soft marker, of course, in nuchal, nasal bone, and ductus, and so on and so forth, can give you some kind of idea about the fetal aneuploidy assessment. What I'm going to discuss today is about the first markers. There are three special modalities. Like you may go for the combined screening, that is typically Kipros. You do only nuchal transfusioncy, and then you go for a double marker test. There are some problems with the double marker test, especially in India. We will discuss that during the later part of my talk right now. Ultrasound alone definitely has got some kind of advantages, but you need some expertise. And the moment you develop that expertise once in a lifetime, you will continue using that expertise for the life. That's what the end advantage for the developing countries, or like India, or a hot climate India, where ultrasound, which is not going to create alteration in your reporting, that is going to be definitely helpful. Cell-free DNA has completely changed the prospect of the aneuploidy assessment during the first trimester of the pregnancy. Now the moment you use the cell-free DNA, you will have a lot many things. Now, as you know that every soft marker like nasal bone, ductus, tricuspid regurgitation, or in the first trimester or in second trimester, they all has got their own positive likelihood ratio and their negative likelihood ratio. That is also applied to all biochemical markers like PAPE, free beta, HCG, alpha feto, protein, E3, inhibin A. The importance of positive likelihood ratio is that if that soft marker, or if that factor, or if that biochemical marker is abnormal, this is going to increase for Down syndrome. And it's other way around also. If that factor is normal, that is going to reduce the chances of Down syndrome. That is what we typically call it as a negative likelihood ratio. So all in all of these markers, the strongest marker is defined when a marker has got a highest likelihood ratio. And the highest likelihood ratio, the highest is having nuchal translucency, then comes the nasal bone. So these are the two markers which has got real very high sensitive or likelihood ratio for identifying the trisomy 21 as far as first trimester is concerned. In the second trimester, it is about the nuchal fold. Again, the absent nasal bone has got the highest positive likelihood ratio, but then comes the lateral ventriculomegaly, ARSA, and nuchal fold. All has got around 3.8 or 4 times. So it increases the risk for Down syndrome by 4 times. So it's like that. So a biochemical markers which has got that kind of bad abnormal thing, it has got a positive likelihood ratio as well as negative likelihood ratio. So all in all, when we evaluate, it has to be both ways. So in general, this is like playing a dart. My target is a screening, identifying aneuploidy, and my real target is to identify, to give any detection which gives me more than 95% detection rate or 1% false positive rate. That's an ideal test. But when you are looking for ideal thing, you may end up in paying a little bit more. So whenever you are asking about, or you are discussing a screening test, it gives, for me, it is any test which is 90% having detection rate with a 3% false positive rate. For me, that's an okay test. So you can identify, you can go through the testing, you can go through the group of tests which are available, which has got more than 90% of the detection rate with a standard accepted 3% false positive rate. That means if you evaluate 100 patients, 3% are going to give you positive result for screening, which may not eventually turn out to be disease. Say you may have screen positive Down syndrome, but eventually they may be normal for your Down syndrome screening. So that's what a 3% false positive, that should be acceptable, not 5%, that is too high. So accept 3% false positive, but it has to have more than 90% detection rate. And aneuploidy or a Down syndrome has got a two different set of expression. One is phenotypic expression, that is by look. So a nuchal translucency, absent nasal bone, they are phenotypic expression of aneuploidy. A genotypic expression is protein synthesis, because PAPA, free beta, SCG, they all are proteins, and they will be developed badly by the placenta or genetic expression. So I put it as a genotypic expression or phenotypic expression. Utilize anywhere, anything which you want, but your aim has to be identifying more than 90%. There are few factors, of course, which test to be done. Is it a combined test, first trimester, second trimester, or NIPT? Lot many factors, especially in India. When you read a reference like Fetal Medicine Foundation, there is an ideal system, because it's all same. All patients are same. Everything goes to NHS. Patient comes to you, do a scan. When you feel like she should undergo NIPT, without any doubt, they go for it. They don't have to pay from their pocket. If at all, then the insurance company is going to take care of those expenses whenever they are covered. In India, the thing, it's an absolutely different game. There are protocols driven in UK or US that you have to follow strict protocols set by the institution. Here, there are a lot many factors. Unfortunately, I have to put in one knowledge of consultant. If they have got whatever factor they do not understand, they are not going to utilize that part of the aneuploidy screening. So for me, that is also one of the factors. The next factor is knowledge of sonologists. If I know how to perform, if I don't know how to do the nuchal translucency or a nasal bone or a ductus venosus, how am I going to give that benefit to that patient? So it is not possible to give the benefit to the patient. So my knowledge, if I'm performing that scan, my knowledge has to be up to date. If I'm to perform a nuchal translucency, if I do only nuchal, I'm not going to give the advantage of the nasal bone or a ductus venosus to that couple, to that patient. So it's a knowledge of sonologist who is performing the scan that is also at least most important. Third thing is the financial condition of couple. If patient is really well to do, absolutely well to do, you are going to offer them NIPT, because anyway it is going to give you 99%, 99.12% diagnostic accuracy for Down syndrome. You are going to offer them NIPT irrespective of whatever your is, because tomorrow patient is going to come and say, well, I could have afforded, why you have not offered it to me? So offer them if they want, nothing like that. So a financial condition, if you are in a circumstances, nuchal is 2.7, rest of the things are fine, you know that an NIPT is going to couple better. But when couple doesn't have that money to pay for NIPT, you are really stuck in that condition. So there are a few things which are special for India. Available setup. If you are working in a very small machine, if you don't have a real good ultrasound machine, will you be able to offer them first time as a screening or a nuchal or nasal bone? So it's available setup in where you are working. In a few of this government setup where they still kind of machines are not to that great extent. So you have got, there are a few limitations of available setup and available resources who can perform the scan. And most important, the last one is relative important. I understand every pregnancy is really very important, but to a lady who has got already 4 kids playing at home, and when you say the nuchal is 4 millimeter and nasal bone is absent, and you need to undergo a CVS examination with the limited resources of their income, what do you think they are going to do? There are very high chances that they termination of pregnancy. Other spectrum is a couple who has undergone IVF at the age of 35, 36, and they have got a similar situation. They will definitely undergo investigation, and they will look for to survive the fetus to their maximum efforts. So there are lot many things, factors which are affecting in India. Let us go to next point is a risk a priori. Every woman has got to deliver a Down syndrome, and we know that advanced age, when the age is more than 35, we call it as an advanced age in the gestation. Why? Because arbitrarily it creates a risk 1 in 250 lady to deliver a Down's baby at 35. That's the reason why we call it as an advanced age, and we consider 1 in 250 as a high risk for a Down syndrome. Now, there is a very typical, on your left side of the screen, where you see a typical table, which is by Fetal Medicine Foundation.org. But we could really, I would say, we could go inside the table and look what actually the relationship of this is with advanced age. What we could find out, that if you remember, at 20 years, a lady has 1100, one lady out of 1100 will deliver a Down syndrome. And this is because of the aging of ova. And you need to understand the basic difference between the spermatogenesis and oogenesis. A sperm which are ejaculated on any given day, all this, whether it's an 18-year-old boy or 70-year-old gentleman, those sperms are going to be formed in last 90 to 120 days. Whereas the ova, which are, that lady is going to ovulate during that cycle, because all ova, primary oocytes, are formed when she was in her mother's womb. So at 20 years, the ova is already 21 years old cell. So because as the cell becomes older and older, there are more chances that it will end up in a malfunction, or what we call as a non-disjunctioning, or a cell division, which will be at fault. So the risk from 20, 1100, from 21 to 25, risk increases 2% per year. 26 to 30, it is going to increase 8% per year. 31 to 35, this is going to increase 16% per year. And 36 to 40, this is going to increase 24% per year. So 2, 8, 16, and 24, that's how every year the risk increases for having Down syndrome baby. So that's about what we call as a risk a priori. And to this risk a priori, which is an age related, to that we add on positive likelihood ratio of all soft marker or negative likelihood ratio of all soft marker, and we come to a final risk, that is adjusted risk, what we are looking at. Of course, looking at a biometry, because why it is important, looking for the CRL, BPD, HC, abdominal circumference, and femur length. Why it is important? Because when the baby during the first trimester, you cannot have a macrosomia. You may have early severe growth restriction, and that may suggest you some of the fetal aneuploidies. That's where you have got importance of fetal biometry. And one of the key thing about fetal biometry is only one section. This is what earlier you look at the size of the relative size of the head and relative size of the entire body. Head is much bigger. You also have a micrognathia, but all in all, you have got a thin lean body, and this came out to be trisomy 18, and that is what is important for looking a biometry as far as aneuploidy is concerned. Coming to the one of most important point is about the nuchal translucency. When you look at this video, okay, look at this. The nose is fine, lips are fine, chin is fine, but look at this region. This region, it looks, which is not like a normal neck, and I still feel that fluid, that excess in this fluid, this collection of the fluid, which is what we call as a nuchal translucency, excessive fluid in the subcutaneous tissue behind the neck, we call it as a nuchal translucency. So looking at the CRL, and this is one of the most important screenshot or the image on your screen to take, not only to measure the CRL, but it gives you loads of information: nasal bone, nuchal, height, intracranial translucency, and whatnot. So what is this? This is exactly what I'm trying to put it across, that excess fluid, which is known as nuchal translucency. There are few criteria you need to follow. It has to be magnified to include only head and the thorax of the fetus, and that zooming has to that much that when you freeze and when you scroll your measurement bar, it has to move only 0.1. So increment has to be only 0.1, not 2.2 or 0.3. The moment you are scrolling of the caliper it is of not 0.1 increment, that means your zooming is not appropriate. You should zoom it till it has got only 0.1 millimeter increment of the calipers. Allow the assessment of the entire length of the nuchal region and measurement to its maximum thickness. So you may have these thickness measurement by auto measurement, like in G they call it as an auto NT. Every other machine will have some or different other name. The fetus has to be neutral position, where there has to be a pouch of Liker seen in the neck. The demonstration of a fetus separate from amnion, so that you don't mistake the skin with the amnion. So that is one of the criteria. And auto measurement is preferred to avoid inter-observer variation. Let us see how the things are. So here you go. This is what you have got: nuchal translucency measured, and in nuchal translucency is primarily it is from in to in measurement. Here this is from in to in measurement. Here it is from this is in to in measurement. Basically, this for look for the pouch in the neck. You should have, preferably you should be looking at the falx cerebri of the brain. You see the thalamus, you see the new intracranial lucency. Look for the nuchal translucency. Look for the palate. There are so much of information there with your one apart from NT, but that's the section you should be looking at. Let me show you a good CRL, simple good CRL. I've got lot many things. Let me freeze it at this point and look at the nasal bone, look at the skull intactness, look at the amnion, which is different, look at the skin, subcutaneous plane, cord insertion, pal, you have got thalamus, you have got umbilical cord insertion, and so many things you will be able to identify. Now zoom it and let me show it to the same part. I have zoomed only the upper part of the thorax and the fetal head. Here also let me freeze, and with the same fetus you have got the information, like you have got the nasal bone, frontomaxillary facial angle, the thalamus, the complete falx cerebri, nuchal translucency, and all of these evaluation will give you so much of information about the fetal aneuploidy assessment. At 12 week, I know that this assessment is absolutely normal. Even if I don't have the risk assessment software with me to identify the risk, I know that this is falling in a very low risk category for as far as aneuploidy is concerned. So it's taking a good CRL. Taking a good CRL is a crux of the first trimester aneuploidy screening or scanning, and that is what is going to be important as far as this is concerned. Whenever you have got 9L probe, high resolution probe available, you can utilize. See the amnion, which is different. You will have much different kind of assessment of the evaluation. Look at this image of the picture, which is really giving me a real brilliant in measurement. Look, nuchal, nasal bone, palate, and everything. A 9L probe will give you idea. 3D NT, there is a controversy about it, but it's easy when you are you having problem in getting 3D. I mean NT. Simple thing. Take a axial section plane, and then which should incorporate neck, and then just rotate the image. Again, rotate it to 90 degree. You will have one kind of that. That's where you rotate, and you have got a nuchal translucency. You have got nasal. So a 3D NT, it will have much, I mean, few more or less measurement about the nuchal in 0.1 or 0.2 millimeter, but it will give you idea about it. A nuchal, increased nuchal before 10 weeks or before 11 weeks also has got some of the importance, because this is at 9 weeks, 6 days. There are many chromosomal or cardiac problems associated with this. At 12 weeks, make the CVS. Although nuchal translucency has resolved, it has come to a normal nuchal measurement. Still, you need to assess these fetuses for microarray and look for the fetal aneuploidies. Now, auto NT or manual NT, it is going to be auto NT, which is going to be far more accurate. But whenever you have got auto NT measurement, which is going to be far more accurate, as inter-observer variation will not be there, and it's easy faster. Now, once you have got now this nuclear transparency, at the end, what you are going to do is, if increased NT, which is there, say for example, you may have abnormal karyotype, your problems is solved. But when you have got increased nuchal with a normal karyotype, your problem still persists. And how to counsel whenever you have got only nuchal transfusions report? This is one important slide that, say for example, you have got nuchal which is 5 millimeter. Technically, in a simple language, 5 millimeter nuchal is really very high, but it falls into this group, 4.5 to 5.4. It gives you an idea that, okay, you have got 33% chances of chromosomal defect, which you will be able to rule out by doing microarray, or of course, when you have got these, I will also look for next generation sequencing for looking for, especially for the Noonan syndrome. Once it is normal, then my concern is going to be major fetal defect, which I'll be able to look for early anomaly scan at 16 to 18 week or by 20-22 week, looking for major anomalies. If they are not there, then there are almost around 88% chances that that baby may come out to be normal after birth. So increase in a nuchal with a normal karyotype does not need a termination. They need further evaluation and further assessment by looking for the chromosomal assessment and other major fetal defect. So that is what importance of the nuchal translucency. This is how much CRL, how much nuchal is normal. So the fetal medication has given a graph how much CRL this is, but we have at Paras we have developed one thumb rule. It's easiest thumb rule. Prefix 1 to CRL. Say for example, if you have got CRL 75 millimeter, then 1.5 is NT is normal mean. Okay, so but if you have got 50, 1.5 is normal. If you have got 80, 1.8 NT is normal. So a thumb rule, we have published a book called 100 Thumb Rules of Ultrasound and Fetal Nomograms Made Easy. Professor Ravi Chavi and Alfred, they have written the forward for us, and thank you, Ravi, for doing that. And in that, we have all given thumb rule as rule number 2, prefix 1 to CRL, and that is going to be your median NT. Now, how much risk is increased? That is, if you have got CRL, say for example, 60, 1.6 is normal. Instead of the moment it becomes 2.6, the risk increases by 5 times. And when it becomes 3.6, the risk increases by 25 times. So there are simple rules. If you remember, you will have a kind of thing how to organize. If it is 1 in front of CRL, that's median. If it is 2 in front of CRL, the prefix 2 to the CRL, that is where you need NIPT. The moment you have got 3 prefix to CRL, you need invasive testing. The simplest of remembering the thing, it is a thumb rule, may not be as accurate as your software, but it is going to give you a precise kind of information that you need that kind of invasive testing. So 1 is NT, 2.55 time increases, 3.75, 25 increases. So you need NIPT or invasive testing, depending upon if you are dealing with thing is. So all major chromosomal defect will have increased nuchal translucency. Coming to next is a nasal bone, and the nasal bone, you have same criteria are to be followed by like nuchal translucency, but it has to have a parallel. The nasal bone has to be parallel to your beam. Measure it, and once you have got the measurement is that, then you think about, is it normal or is it hypoplastic, or occasionally what we call it as echogenic, then less echogenic bone. How to differentiate between all of them? Normal length, when you have measured a BPD, when the nasal bone is 10 times, the BPD is 10 times the nasal bone, you are happy with that. This nasal bone measurement is all right, but it should be more echogenic than the skin normally. But when you find, look at this image, this nasal bone is far more echogenic than this tip. That is a normal echogenicity. When you find this less echogenic or a smaller than 1/10 of your BPD, they are the one which is hypoplastic. Look at this. This is absent nasal bone, and in a premaxillary triangle, you may not be able to see the tip which is formed by the nasal bone. So that is one way of looking at absent bone. The or absent or hypoplastic. Look at this nasal bone. You have got this tip is far more echogenic than this nasal bone. So they are less echogenic or hypoplastic nasal bone. So hypoplastic nasal bone and absent nasal bone, they are equal and they need further investigation. Look at a 3D picture. I'm on nasal bone. You can see these premaxillary triangle. It has got two nasal bone which are seen. So it has to be done by this. So identifying a hypoplastic or absent nasal bone adds on the risk for trisomy 21. Coming to ductus venosus, it is one of the book is from Practical Guide to Fetal Echocardiography. We have a little bit more into it. We have added the hepatic veins and the ductus venosus. This is the image of the ductus venosus. And when you when you interrogate and you evaluate the ductus venosus, you will have some kind of, there are again few criteria how to look for a gate has to be 1.5 to 1 millimeter. This is where you have got ductus venosus. It has to be parallel, practically less than 30-degree angle of isonation, and the gate or the measurement should be 0.5 to 1 millimeter, because the smaller the gate, it will not have any other extra vessels which are going to add to the value of that vessel, because you are dealing with such a small vessel, the size may be less than 2. So if you keep your gate more than 2 millimeter, you will have a wave from hepatic artery or hepatic veins. It is going to add to your wrong diagnosis. The filter rate has to be between 30 to 60 megahertz and sweep speed high, maybe 2 to 3 centimeter per second, and you should have only 5 to 6 beat per on the screen. So look, moving further, so I have added a gate which is practically like 0.7 millimeter gate. If you see on the screen, just put it on the wave Doppler that which is like having aliasing. Get the screen, get the power Doppler on, and you will have these waveform, and eventually you measure it. The moment you measure it, is going to be PI 0.96, and that you need to measure. I'll show the video again. Let us see the video again. See, I'm just on the parasagittal right side, paramedian, so parasagittal. Put a gate 0.7 mm. Just take a waveform, and your job is done. So this is as simple as that. It should not cross the midline, and your measurement is over. Now, once you are done with this, look for the reversal. Not only reversal, this is an old thing, but now FMF Foundation asks you to measure the PI, because increasing PI, it has got increased chances of not only Down syndrome, but also associated with fetal cardiac defect, and that is going to add on the value. Remember one thumb rule thumb rule from thumb rule book. Any PI around 0.1 plus or minus 0.1, that is normal. Anything more than 1.3 PI, anything more than 1.3 PI, which is abnormal. So PI above 1.3, always consider as an abnormal PI. 1 plus or minus 0.1. So 0.9 to 1.1, that's a normal PI for ductus venosus, and for this is going to be 1.3 is abnormal. Regarding tricuspid regurgitation, again protocols are same, but you have to have apical four chamber view and place the gate across the tricuspid valve, and that is how you look for the waveform. Most important is going to be your interpretation. It's like when there is no regurgitation, this is normal, but the regurgitation has to be pan-systolic. It has to throughout the cardiac cycle. It has to have the regurgitant flow, and of course you have to have the regurgitant. It has to be more than 60 centimeter per second velocity. This is one pulmonary artery flow, which if you are not right, and or a closure of valve can produce this kind of spike. So it may be a little bit difficult, but I would put it across whenever you suspect cardiac defect along with first trimester screening, please look at a regurgitation, because it adds value. It adds definite value to along with the ductus venosus screening when you have got a tricuspid NT and cardiac defect. Because look at the increase. The NT is less than 3.5. Tricuspid is only with a cardiac defect, only 25% will have a positive tricuspid regurgitation. But when NT is more than 4.5, 45% will have a tricuspid regurgitation in association. So it also increases the detection, and it also gives you a sense of what actually going on inside the fetal heart. So that will add on the value to your assessment of fetal aneuploidy. Biochemical markers, whenever you are asking for double marker test or a PAPE free beta H or pentamarker test, make sure that you have given precise LMP, you have given your CRL report, you have given height and the weight, and whether there is a history of trisomy 21 or not. A lab which does not ask you about getting these height, weight, or they don't care about the trisomy, the past history of trisomy 21, never send to that lab, because they don't have the concept. I would put it that way. So make sure that you do it that way. About two things we are doing in a dual marker is measuring a pregnancy associated plasma protein. They are produced by the placental sensitive trophoblasts and deciduous. Basically these PAPE or the PAPE levels are going to be reduced. The placenta does not produce the PAPE, and we'll have a less PAPE information in Down syndrome. Now, how much less is less for Down syndrome? So what we call it, we usually calculate in multiple of median. One multiple is normal. If it reduces to half the PAPE, gives you information that this pregnancy or this lady has got more chances of fetal growth restriction or PET. When it reduces to 0.2 or 0.3 mom, that means reduction in 70 to 80%. They are the one who will have association with Down syndrome. So make sure that you not only look for the less PAPE, only a factor, but look for what exactly how much low is low. High PAPE has got no value. The again thing is the free beta again which are developed by syncytial trophoblasts, and which will throw free beta HCG into your the metal circulation. Total HCG has got no value in first trimester of the screening for Down syndrome. Second trimester they do the total, not only free but a combined HCG values. But again here you are the production of beta HCG is going to go up, double up, 2 times 2 mom. That is what is important. High elevated in Down syndrome, that is 2 mom, double the normal range you will have, or a paternally derived triploidy or placental insufficiency. Both will give you idea about high beta HCG and low PAPE, will give you some idea about poor placental functions, whether it is going to lead to a fetal growth restriction or PET or Down syndrome. You think in that line and go for some kind of thing. The problem in India is when you are dealing with PAPE, and usually we send the whole blood. If you are working in a small setup, you may not have the availability of PAPE in your clinic or in nearby center. They are transport that sample. It may take a day or two. When it takes more than 5 or 7 days, you have got chances of derangement of PAPE almost around 10 times. Separated serum, they are going to be stable. But when you are dealing with free beta HCG, that's what the major problem is. When you have got it is stored at 5 degree, it is going to remain stable till 7 or 8 days. Temperature just 20 degree, it is going to altered in just 2 or 3 days. But when in a hot climate like India, like Ahmedabad, or in major part of North India, within a day or two, you will have a great variation in the value, and that will add on the false positive diagnosis. So that we utilize the biochemical markers as and when required. I wish you to utilize the either NIPT or only ultrasound to their best, and because that is what my idea is to let you know. This is one slide from Howard Kuckel, but it has two aneuploidy. It has got everything which is haywire. Alpha fetoprotein here or here, because this is one mom is going to be increase in Patau syndrome, but only there are two rules which are following. Nuchal is always increased and Pape is always reduced in all chromosomal anomalies. So think in that line, and that a cell-free fetal DNA, a cell-free fetal DNA is basically a DNA derived from the placental trophoblast, and we consider that as a part of the morula, and that's exactly why we look for the cell-free fetal DNA. And these DNAs which are in maternal blood, they have got a different kind of fragmentation than maternal DNA. So the lab try to segregate those things by doing a targeted sequencing, and they try to identify what exactly the syncytiotrophoblasts. If that target shows a parallel sequencing shows that there are 3 copy number variation of this Down syndrome or any chromosomes or any small gene deletion or duplication, they will let you know, and and it will give you the advantage of 99% detection. Now the cost is also not prohibitive. You can get it done in 6,000 Indian rupees, practically 60 pounds, or I call it as 70 euro. We get it done, the NIPT. So it is about adding the NIPT to your prenatal screening, adds on a great value for your positive prediction of aneuploidy, 99.12%. So where we recommend, I'm going to discuss that part, how we are recommending when to get your screening done to your things. Maternal age and TV. So that is when the things are fine, look for the tricuspid. Invasive testing has to be offered when you have got 1 or 50 or 1:100 risk. If the risk is less than 1:1,000, no further testing. But when it is between 1:52,000, we call it an intermediate group risk, and those you can offer NIPT or cell-free fetal DNA. You will have far more better prediction as far as this is concerned. So there are a few strategies which needs to be evaluated, and these strategies, let me discuss these strategies with you. The combined screening, like what Professor Kipros says, dual test offer to 1:, invasive testing when the risk goes to 1:100 or more, which will have 80% of trisomies and 90% of percent of the population. 1,000 or less risk, no further screening is required. 77% of trisomy, 77% of population will be falling into that, but you have got 3% of trisomy babies which you may not be able to identify. And into intermediate group risk, you do additional marker or cell-free fetal DNA and then do it. This is what Kipros says, and what we know that again a contingent policy by same group, but it was who has done a screening by fetal nasal bone, nuchal, and ductus, only ultrasound. Estimate the risk for trisomy 21. Again, if you apply the same algorithm, and for the intermediate risk, you investigate that lady for double marker and then decide whether she needs invasive testing or not. It has got far more better accurate diagnosis as far as aneuploidy is concerned. After 2020, at Paris protocol for aneuploidy, we have done something different. Screening by maternal age, nuchal, nasal bone, and ductus venosus, we estimate the risk for trisomy 21. If it is high risk, 1:100 or more, we offer them coronary villus sampling. If it is low risk, 1:1,000 or less, we don't offer further screening. We say it is a less risk. To intermediate group, 1:100 to 1:1,000, depending upon their cell-free fetal DNA, we offer them cell-free fetal DNA. If it is negative, no further screening, and positive, we go for CVS. If we don't get result even after 2 samples, we also offer them CVS. So that's what the protocol where what we follow at Paras, again, it's a contingent policy, but we offer, instead of double marker, we offer them self-revealed DNA, because self-revealed DNA testing is now much more cheaper than what we utilize. Is there are good economics. Once we have basically a Gujarati, a Guju guy will always think about cost effectiveness, and the moment we utilize this economics, I will have 33% cheaper with a better 92% detection when we utilize our Paras protocol tendency policy screening. So I'm saving 13% money and adding 4%, 3% of detection rate. That's what my economics is, and that's the reason I always do. And I feel that we earn 25% more by doing better job with a better detection. Nothing better than this. So earning, better purchase of a better machine, that will give you far more better accuracy and of course better detection. So last, low resources. I have one video to play. We had in one of the webinar, we had this. In this webinar, actually, sorry, the voice. I think what Kipros said, that if at all you are working in a low resource setup, the dual marker will give you 90% along with the nuchal, and nuchal and nasal bone also will give you similar kind of 90% of the detection rate. So you can also think about doing nasal bone and nuchal translucency to reach to that 90% of the detection rate, and with a percent false positive rate. So there are few changes. Why I'm showing you that slide again. I've just given you the analysis of last 3 years. 4189 patient, no 21, no trisomy 21 full term delivered, no trisomy 21 missed. We suspected 2 only by NIPT, where ultrasound. Uh, we have utilized liberal use of NIPT 35 or any one ultrasound sign positive we utilize. So we utilize the same system, self-revealed DNA, but this we definitely got advantage since last 3 years. I have given you the facts and figures of four almost 4,200 patients with, but here is a catch: 2 suspected only by NIPT, where ultrasound was normal. If you want to catch these fetuses, you have to utilize the NIPT with a liberal use. NIPT. So there are some of the combined screening will give you 92%. This is the latest from Kipros. Self-revealed DNA anomaly with NT will give you additional thing. But there is one thing you have, if you can read this line: if NT is more than 3.5 millimeter or anomaly present, go for invasive testing. It's not only nasal bone, nuchal, or transverse or ductus venosus. NT more than 3.5, you can offer invasive testing, or associated with anomaly present, you should be offering invasive testing. And contingent PAP combined screening with DNA, what we are following, it gives 98.4% with only 0.7% of false positive rate. That's the best thing. So if you combine all together, if you have a bad nuchal more than 3 point, you can offer them invasive testing. NIPT, which is not normal, you can offer them in invasive testing, or combination of NT-nuchal, NT-nasal bone, ductus venosus anomaly combining together, having high risk of the zone, you can offer them invasive testing. So you should utilize potential of ultrasound marker better and optimal, rather than using a biochemistry in all pregnancy for aneuploidy screening in India. That's what, and my last slide is, it's possible, it's easy. Aneuploidy screening at 13 weeks is the best. Free use of NIPT, and as we have discussed, you should use using. Thank you very much for patient here. And very good morning, Professor Chavi. It's great honor and great pleasure to see you here live. I know he is so busy, and I'm really honored to have you here, Professor Ravi Chavi. I know, as I told you, I know he's a dear friend since I know him since 2012, 11. to be very precise, to organize, to get ESWAG presence in India. And Rabi, look at the difference it has made to India in 10 years.
I know.
One ESWAG meeting in India, and I know it's your baby. You have pushed ESWAG to go to India with an ESWAG outreach program, and I was fortunate to have that program along with all you friends. And look at the difference it has made in India in last 12 or 13 years. Over to you, Ravi.
Yeah, thank you, Prashant. So this is also, I'm proud that we succeeded, and I just see that Ashok joined us. Yeah, indeed. But when we were in ISWAG, we had a strategy planning meeting, and we're discussing where to go to in the future. And luckily, you speak English, because the other issue was to go to China. I said, I will not go to China because it's too cumbersome to get into the society there. You don't speak the language. And I like your mentality, because we are very similar in many things. So and yeah, we were lucky. And but I see that you work very hard. And what I love in your approach, all of you, is you are very technique interested. So technology is all of you are fan of technology, and I was doing a lot of 3D. And also in your approach, let's say teaching and learning is the number one. It's not let's say a question of, let's say, en passant, I know everything. So I think this is one of the major advantages I see in India, that you can approach people and they love to learn, and this is what they do. So Prashant, you asked me to speak on first semester, so I will start with this with the talk. If you don't mind, let me share my screen. And yeah, so I hope you see everything very well, and you see my screen.
Yes.
Yeah. Okay, great. So let me now go with my talk. I need the clock, so I have almost an hour. I hope I will not cover the whole hour for you. It will be too boring. Prefer to have more discussion, and the same with the brain talk. So the question today is actually, you have shown very nicely how to approach diagnosis of thalassemia 21 in the modern age of first semester, but there is now mean to think of starting anomaly scan in the first semester. And if you let us look back to what happened at the beginning, this is Kipros in the 90s. And this is a picture from his first paper on the thickened nuchal fold, the nuchal translucency. You imagine how bad the image quality was, and then how bad the scanning conditions were at that time. But anyway, this is how it started. And it was not his discovery, but he used it as a technique, as an observation, and said, let us start now and seek for something simple, measure the fluid, and then we get there. And the screening became possible. He moved at the beginning from 10 to 13 weeks to 11 to 13 weeks, mainly for two reasons. One of them is that you can perform the CVS more safely up to 11 weeks. And secondly, that you don't miss an anencephaly. So the CVS was already possible 10 years before. So since the beginning of the 80s was possible, then we had more and more good resolution. Remember, in the early 90s, we had the first steps of transvaginal ultrasound, achieved more in gynecology, but then let's say used also more in obstetrics. And then it was then possible to install a complete program of worldwide program of nuchal translucency. And the major advantage and the major, let's say, issue of Kipros, that he was the first time he offered to go with the quality control, because otherwise anyone can measure anything. And this is similar to what labs are offering. Today, when the nuchal translucency came on, it showed that it's more what I call, let's say, a democratization of scanning for thalassemia 21, because then it's not offered only for patients more than 35 years, but for all, because it's safe. You remember, amniocentesis were done mainly in age. In some societies, it was more than 40 years old, the is the cutoff. Then it moved the soft mark and the observation to the first semester. Then what is important to know, we had some age stratification. Then instead of doing CVS, we're doing, amniocentesis, we then started doing CVS for specific conditions and for age and for abnormal anatomy with the nuchal fluid. And then it replaced the routine amniocentesis if the woman was over 35 years. Now, at the beginning, you say we don't need to replace this, but then you have patients coming to see you, said, I struggled now 4 or 5 years to have an IVF, succeeded, now I want this baby, but please try your best to rule out that there is anything else, but I don't want to have the, let's say, the issue of losing the baby after amniocentesis. Now, I'm happy that the NIPT did not came at that time, because otherwise, if this would have been the case, I think our job would have been completely different. And this is what things have changed. Now, in many places until now, first semester screening is still synonymous of aneuploidies. But so people who did not understand this, they will be unemployed because it is now killed by NIPT. So of course you can show that you are looking to the baby, but I know that in many places in the world, people, they said doctors offering nuchal, they were replacing this by NIPT. So instead of NT, you add 2 letters IP, and it's called NIPT, and then you don't care actually. But we have to tell our patients, and this is what the aim of the talk, that the first semester screening has now evolved into 3 parts. One is the screening for aneuploidies, one is detailed ultrasound, one is risk assessment of pregnancy complications. And this is why when a patient comes to see me, we sit together at the beginning. I have almost the same sentences like many of you. I say, today we have now examination with 3 columns. One column is dealing with aneuploidies. And some say, I had my doctor already an IPT, the result is not there, said I will measure many things, and also the nuchal to document that it was normal. Then the second part will focus mainly in this examination on fetal anatomy, and then the third part will look at the perfusion, look at the uterine artery to see if you have any risk for complications, if you have a previous cesarean section, also for the scar and so on. And my message today is for many of the audience is that we spend a lot of time in the last 25 or 30 years in establishing a good program of good scanning skill in first semester. Please don't give it up for one blood test, because keep in mind if the patient is willing to pay the money we're saying, even 70 euro, or in Germany it's still 200 euro, but it's still covered in the meantime by the insurance company. So since last summer, if the patient is willing to know if the baby has one disease, which is Down syndrome, she's also willing to know if the baby has 100 other diseases. This is why you should tell her and teach her. So let's start with the data, with statistics and so on. And so I will first, I want to show you 2 studies. The first one is one of my favorite. There are several meta-analyses, but this one is practically has a good, let's say, outcome and impact and message. Jihan Karim showed, working with Papa Giorgio in London, she's Canadian origin, showed that if you're looking at more than 100 fetuses, that if you have a low-risk group, when you do appropriate scan, you have 32% detection rate. If you have scanning a high risk, you will have detection rate of 60%. Now, but keep in mind, at the end of the day, that, when you put data together, it's always the data of the reporting center. So I can imagine someone like Prashant, or like someone like me, or Ashok say, my data show better results. Okay, but, if you don't publish them, they will not appear. If you are not doing on your own the whole screening policy, but let's say some selective patients, it will be mixed population. But more important from the study is following, that if you are using a standardized anatomical protocol, then you will improve the sensitivity in first semester for all anomalies. So the main message is that you can improve your detection rate. So what I like in these numbers is that when patients come to see me, I see the whole fetus, the fetus looks normal. They ask me, why? Now I saw everything. Why should I come back at 22 weeks? Because they are surprised that we have finished. That you think we have seen the heart and the chambers, but there is involvement. We in pregnancy there's changes in the heart, but mainly the brain. The brain is only 2 halves of the brain, so I don't want to guarantee you that there is anything appearing from today to next time. And according to some studies, you are a low risk. We may still have roughly 50% of cases not detectable at this stage because the statistics show this one. The second study is this one by Kipros group, and it is almost like a meta-analysis, but which shows that in his centers in London, so they took several hospitals where he has the same approach, and they taught sonographers and trainees and so on to work. After half a year, they were allowed to perform an anatomical survey in first semester, in addition to the nuchal and so on. And almost all were done abdominally. And after removing the chromosomal anomalies, they showed that the first semester detection was 470 cases out of the 1,300. So again, the 30% detection rate. So it shows that if anyone can learn to do systematic examination and to improve the quality and reach a detection rate between 30 and 50%. So this shows also the application of what was shown in the other meta-analysis. Now, recently, a few weeks ago, the new guidelines of his work for first semester were published. It was done within, let's say, quite like a half-year work. Kipros was let's say, writing emails with Leona Poon to hurry in finishing the guidelines after 10 years. The last one were 10 years old. And let's say in the guidelines, we did something new. So instead of writing the structures which can be seen and it's optional or obligatory, mandatory or optional, we decided to keep for the expert the freedom to do what they want in a way to show them these are the typical planes the experts are doing. You are not stuck to one plane, but what we added here, and we thought we need to add it, is to have so-called minimal requirements. So every patient going to a center, getting a scan, if it's not a specialist center, or she wants to have an NIPT, she needs at the end minimal examination where it's beyond the simple measurement of the CRL. And the reason was following. If you look at now, in the past, some years ago, the ideal word for IPT was suggested to be NT with normal early anatomy scan. And if there is intermediate risk, you have an IPT, or the patient wish, you can get an IPT. And let's say, but the true word of today is the doctor checks the heartbeat and then an IPT. People tell me, I don't believe, and we're struggling with Kipros. Said, you cannot say minimum requirements because people should learn how to do the nuke. That people forget it. Kipros forget it because people are doing NIPT without even looking to the baby. So, and if looking into this slide shows you following. If you do a nuclear transfusion as a prerequisite, you need a good ultrasound machine. You need a license. You need the license from the Fetal Medicine Foundation. For NIPT, you need neither ultrasound qualification. And so this is why we said we need at least to look at the fetus before starting. I'll show you a case from Germany, 2022, because last summer, it was since July, possible that the normal doctor gets an NIPT, so the patient could go to the doctor, to her treating doctor, and then they can take blood, and sometimes they send them to us. So you see here, it is this test was done, trisomy 21, the baby seems not to have trisomy 21, and the fetal fraction 12%, and she come because he could not measure the head, and 21 weeks anencephaly. And this is something we say, it's not possible that after so many years of work, so many years of screening, and we had 2 cases within 1 year, and we're assuming that there are more cases coming in, all severe anomalies, because if people do not look at the baby, they will not see this. So I'm sure in your country it could be different, but believe me, it will not be different if you don't ask them to focus on these things. And this is what we said. Now we need the minimum requirement, and this includes following. There are anomalies detected directly with one glance, and the minimum requirements should be able to detect these things. So instead of saying in the guidelines, you should see holoprosencephaly, you should see gastroschisis, you should see omphalocele, you should see etc., etc. We said do it the other way. Tell them what they should do, and then they do it indirectly. So first of all, you should get an overview. And then with this overview, if you look at the fetus, with one view like this one, you may be able to see these severe anomalies. You may see that the baby has no head or abnormal head or a lot of fluid in the bladder, or the proportion may be different and the size may be changing, like this one, like a triploidy, kind of sacral agenesis with a short body or omphalocele and so on. So, or a severe hydrops. And then you stop at this stage and you send the patient further. So we said we oblige people to document the CRL to find out whether there is a early growth retardation as a hint for aneuploidy, trisomy 18, triploidy. We will ask him to measure the nuchal translucency, at least to document that it was not thickened, and to measure the head with the main aim to document on one hand the gestation age, but also mainly to show that they had to put the caliper somewhere so they cannot miss anencephaly. And looking to the brain, they should see a midline. That means they can see here or rule out let's say complications like anencephaly and holoprosencephaly. So in other words, oblige people to do 3 measurements may lead to this thing. And then we said, from the anatomical point of view, you should look at the head to see the head, 2 hemispheres, and then we'll rule out mainly 3 possible conditions: anencephaly, holoprosencephaly, and if the contour is abnormal, cephalocele. Then you go a little bit lower. I was against asking to get the 4th chamber because this is really a big skill to get the 4th chamber view. But we're saying, you know, you should be able to see if the heart is outside the thorax, if there is bradycardia, or is with severe cardiomegaly. So at least look at the heart beating, and you should see it in the thorax. Then you go to the abdomen. There you should be able to see that the stomach is filled there, that the bladder is filled, and there is no abdominal wall defect and no megacystis. And we had a debate on the question of the limbs, but actually it's quite easy in a way to have a look that the limbs are there, especially that most people are scanning the 10, 11 weeks vaginally, so they will be able to see that the baby is moving with the hands and feet. So, and at the end of the day, this is what can be seen. And I write prior to NIPT, even without NIPT, so every doctor should be able to see that there is no severe discrepancy between head and abdomen as in triploidy, no hydrops, no abnormal shape of the fetus that you are able to measure the CRL, no head where missing a brain, no holoprosencephaly, no omphalocele. Only the megacystis may be tricky because some cases, as you know, may not yet be apparent at 11 weeks, but if you document that the examination was done properly, it's fine. And this is here what I would recommend. So this is a transvaginal examination. You move from up to down. And if you do it vaginally, look at what you can see. So you move here and you say, I see the head. There is no anencephaly, no holoprosencephaly. There is no thickened neck. I see there is no ectopia cordis. There is no hydrops. I come to the here. There is no omphalocele. There is no megacystis. I see the limbs here. These are the feet, and so the hand. So, and there is no molar placenta. So within one sweep, you have all these things. But, you know, we need to train people to, let's say, to go these let's point step by step. Now we come to the point of view of patients. When the patients come to see you and she says, you know, I've lost a child with malformation seen at 22 weeks, depends on which malformation. If it's an agenesis corpus callosum, there is no way to do it earlier. But in many other conditions, this is the scenario we do. They ask you, why did this happen? And you did an invasive procedure to confirm it's genetic or not. And then there is always the culpability, have my husband or me done something wrong? And why was not seen earlier? So the questions come, why should I wait until, I don't know, 19 weeks? And could we see this earlier? And then they pushed us to work on getting the diagnosis earlier. And then they can ask you, when can I come next pregnancy to get the examination done? And this is where you are struggling then to say, I need to know if we are able to see your malformation early in gestation. So this is now today, I put these 4 groups, saying if you want to detect anomalies, there are 1 groups like being detected directly, which is the gross anomaly, as I showed you before. The second group is the indirect hint of a thickened nuchal translucency. So I think this is a quite very important part because it is a hint for down, but it can be also a hint for cardiac anomalies. But many other anomalies can be associated with the thickened nuchal, but these are not, let's say, typical. So you may have the same anomaly seen with and without thickened nuchal, but it could be a hint. The problem for us is if you have scanned like the specialist, many fetuses with a thickened nucleus, at the end you assume for one moment if the nucleus is normal, the baby should be okay. So it is similar to the second trimester growth retardation or absent fluid. So you say, oh, if there is a normal growth, yeah, it is unlikely to have this and that anomaly. But at the end of the day, if you don't seek for the anomalies, you will not see them. So this is why there is also a group of family history. Then it's easy because you can go target to the region of interest. For example, encephalocele or Meckel-Gruber group, then you know it is autosomal recessive with 1 to 4 recurrence, then you seek for it. And the more challenging is knowing all these, that to scan on a fetus as if it has all anomalies and go step by step all the organs. And this is why we need something, a new approach. And many people think it's quite easy because I am an expert in second trimester. And I want to show you this slide that you should forget the one glance diagnosis, because if you have renal agent in second trimester, you will not have absent amniotic fluid in first semester. So you have your experience in the second trimester can be only partly applied to first semester, mainly in the skill, but not in the one glance view. So you don't have lemon banana span bifida, you don't have big cystic lesions, there is no almost never cystic kidneys or cystic lungs in first semester. You will not have polyhydramnios in first semester. You may see oligohydramnios only in one condition. What I observed until now was the seronegalia. All other conditions do not have oligohydramnios. And the second trimester growth delay is a hint. The hint is the thickened nuclear threshold. So let's say there are few conditions where there is a growth delay. Otherwise, the baby may have a normal size, even if it's going to be growth retarded later on gestation. So you see, you should relearn, and this is what I say. You should now not only turn the pyramid of care as Kipros suggested, but also to think different. And my suggestion, what I'm trying to explain you, is you have to reinvent first semester ultrasound. Imagine now if you want to teach someone doing ultrasound, they should rethink the whole approach of scanning, because it's completely different. You think similar, but it's completely different, because you will have other tools to measure. You will have an approach vaginal abdominal. You may learn to use how to use 3D. You may to know how to cope with the always moving baby. So it's not that easy. And Bernard Benoit, a good friend from France, who's doing a lot of first semester, we had a discussion together. He said, you should dedicate for your patient 1 hour scan per pregnancy. So, and to me, I think it's true, because ideally you will scan the first semester, if possible, between 30 minutes and 40 minutes if needed. Sometimes you can do it in 20 minutes, not the issue. But then you know that if you have seen a lady in first semester yourself, next pregnancy at next examination at 22 weeks, you can hurry through the examination, because I will not need to look at each hand separately, quietly. So there are many things I've seen. I know that I've seen the heart. There's so few anomalies. So what I do at 22 weeks, I go roughly through the fetus to see that the head, the cavum septi is there, the posterior fossa, and then I go rapidly to see the abdomen and the lungs. And so I know at one point there are no severe anomalies, because I've spent more time in early gestation. So 1 hour time, 40 to 20, instead of having, let's say, 10 minutes at first semester looking to the neck, and then later on you spend half an hour and you discover, oh my God, there is no hand, no fingers, or one kidney is absent, and so on. So this is what I call the yin-yang of first semester, because we have a lot of discussion. Should we scan low risk or high risk? If you are doing high risk patients only, it's not a screening anymore, it's a target examination. So it is one glance check, as I showed you in the minimum requirements, or a systematic examination, which is my favorite, and transabdominal, transvaginal. You can do both, but transvaginal, don't think because you go transvaginal you see all things. You need really to move the baby. You have difficulty in orientation of left and right, and if the fetus is, let's say, more standing, like you see at 13 weeks, you may not see many things. So this is why you need to know how to cope with both conditions. And then grayscale versus color Doppler, 2-dimensional versus 3-dimensional ultrasound, first semester versus second trimester. It means these two, one is ruling out the other, but actually they are completing each other. So this is why think of the yin-yang on first semester scan. So this is why now what I would recommend you, and you see, it's not my recommendation, it's in the guidelines and also in the study of Kipros showing use a protocol. I'm not telling you use my protocol. Everyone should know how he or she is working, but at least you should have a checklist, mental checklist, and please try to have the checklist in your computer that you don't miss anything. So in our book on first semester scan, Dr. Abu Hamad and me wrote a chapter dedicated only to this systematic examination, and you see that the planes. If you need formulas, I would recommend you to refer to the nice book of Prashant and his family on the 100 thumb rules. There are very, very used formulas. So I would recommend you this one, as you see with the peacock here. And now we go rapidly through the planes. We start with the BBD view. There it is also recommended today that you can either have the 4 images, or you can even divide your screen into the 4. Instead of dual, you can do 4 images at the same time, and you go from up to down. In the upper plane is the transventricular plane with the 2 choroid plexus with the falx, and you see the ossification. Then a little bit lower, you see the here the region of the thalami with the cerebral peduncles, and with the falx. You go a little bit lower, you see the keyhole sign of the IT or fourth ventricle, and the echogenic choroid plexus of the fourth ventricle, and then the connection through the Blake's neuropore here to the posterior fossa. So these are the 4 planes needed if you are scanning abdominal or vaginally, but these are easier to get vaginally, but I will focus mainly on the 2 here showing this one. Then you go next step to get the profile, because you need anyway to measure to document the nuchal translucency and the nasal bone. In this view, in the past, you were looking mainly to the nuchal. Later on, you added the nasal bone. Today, you will add the frontal aspect of the face, including the maxilla and the mandible. And also don't forget to look at the brain. So at the moment when the patient sees this, they think this is the ear. What you are seeing, you tell them, no, this is the brain. And the brain shows the typical structures here, including the IT, the choroid plexus, and the cisterna magna. So you have now with the profile magnified, let's say, 3 tasks to look at. First, it's the face, anterior aspect of the face. Then you have the nuchal, and then you have the brain and the shape of the head. So next step would be to turn the probe. When I get the profile, I turn the probe to document the presence of 2 eyes, and they say the distance between the eyes, so there is no hypothyroidism. And of course, you can look at the lenses, but the lenses are really tricky to see if you are scanning abdominally. So, but keep in mind, this is a view, and then you tilt the probe and show the patient the presence of a normal anterior alveolar ridge as a sign of this is large clefts. And then we go further to the thorax. In the thorax, we see the heart. I would recommend you to have 4 images. One is the stomach filled, one is the four-chamber view on 2D, one is the four-chamber view on color Doppler, and one is the 3-vessel trachea view. These are the planes that do as a standard. So 4 images to scan the heart, and then you look at indirect to the lungs and to the cardiac axis, because the heart is not shifted. But my favorite plane is, of course, this one with the 3-vessel view, because it includes many anomalies. Getting a little bit lower, you'll arrive to the abdomen with the stomach filled here, documented on the left side, as we saw in the previous image. Then in the lower part, we see the normal attachment of the umbilical cord. We see the bladder filled with the urine, and adding the color, you see the 2 arteries surrounding the bladder and getting out here as a normal anterior wall. So this is what I say, these are the 2 vessels surrounding the bladder and forming the umbilical cord. And then the kidneys, for me, the best, and for me, almost only plane where I can see them properly is the frontal view. We had a discussion in the guidelines, you can get a cross section and so on, but believe me, the best view is really this one, because then you have a view to the spine, you see the ribs, and just below the ribs, you see these almost slightly echogenic structures, and you can add color if you want, but you don't need to, and you can see them, because in a cross section, you may see one black dot, assuming this is the kidney. Another trick is when you have a, let's say, sagittal view, you see the black aspect of the adrenal gland, and then below it, you see the echogenic kidney, but I prefer to see them this way. I'll show you later on why. Now we go to exactly, this is the what I see, and then in the same time, I look at the diaphragm. This is also a good view to see the stomach would be here and under the diaphragm. And then we go to the spine. To be honest, I don't get in many fetuses this view, a sagittal view of the spine, because it's almost not possible. Because if you are happy that the fetus is lying on its back, I will get a frontal coronal view of the spine. But if the baby starts lying on the abdomen, then you will have this view. You can measure the nuchal if you want. And I can take sometimes, I sample the ductus venosus from this view as well. And then we have to go to the limbs. What you see in the limbs are the three segments of the arm. And this is a moment where the patient say, oh my God, I can see the fingers. And then they realize why it is worth to have with you a specialized ultrasound. And then they realize how accurate the details are you are demonstrating. Because until then, they were not really appreciating. But this is something they see. And when they see that the lower arm has two bones and you see they can count the fingers. So this moment when they realize this is a good guy, and if they are crazy, they will tell you have a good machine. My doctor told me I have a good machine. I tell them I have also some good experience, but I think this is a lost war. So, and then we move now, what I prefer also to do, to avoid a classical question, I prefer to have also, you see here, the legs, the feet, and I'll try to get also the two limbs at the same time. And you see, this is the heart sign, so the love sign, and these are the two legs. Because as I say in some other talks, patients, when you show them the hands, sometimes, you know, they are doubtful. They say, have you shown me both hands, or is the same hand you show me twice? Because they think there should be, let's say, some mistakes in your work. So if you show them both, then you'll do it this way. So what I do, I get the sagittal view. I go to the right and the left. So use the right hand, the left hand. Then I rotate the probe, show the heart, the head, the eyes, the maxilla, and going downward. As you see now, the two hands, you see the 2 feet. And when I add at the end a 3D, then they see the complete fetus. More or less, actually, my dear friends, this is what at the end was adapted by the ISWAG guidelines. This is, you can get the paper online for free, so it's on the website of the ISWAG journal. But what you see here is a general overview, the attachment of the cord on the placenta. I sample the umbilical cord at the end to document let's say the heart rate, even if I do the ductus venosus, but I prefer to sample not inside the fetus but outside, and I use this opportunity to see if the attachment of the cord is probably on the placenta. If it's not, I will document for myself and check later on without telling the patient, oh, you see, I'm not sure about insertion filamentosa and so on. Then for twins, you have the lemon and the lambda or the T sign. Then they see the images of the head, the profile, the frontal face view with the mandibular gap sign of Sepulveda. Then the four-chamber view of the heart with the axis, four-chamber, and the three-vessel trachea view, the stomach filled, the abdominal cord, the attachment, the bladder with the vessels, the bladder size in the sagittal view with gender if needed. I know in India you are not allowed to look at gender. Neither are we in Germany, so we are officially we are not allowed to tell the gender in the first semester. And you see here, these are the kidneys and the spine with the limbs. So more or less, this is the protocol. Now let me show you in the remaining time some anomalies. So we'll go from up to down. So let's see the first on the CNS. From the point of view of CNS, there are anomalies which are obviously can be seen, and some can be suspected, and some can be only suspected, but the diagnosis is delayed. So you will agree with me that anencephaly is a must, that holoprosencephaly, the allobar is easy, the other one may be difficult. That span bifida and can be seen, encephalocele can be, if there are some hints, you can be seen, but the posterior fossa and ventriculomegaly are tricky. So for anencephaly, here you should keep in mind that we have several hints. Typically, you don't have a forehead, so you cannot measure the BPD. So you have more an exencephaly and acrania. So part of the brain are still outside, and you have. I don't use the words frog and Mickey Mouse sign, because even if they are helpful in understanding about the patient, it's a nightmare to tell them, oh, you know, there is a Mickey Mouse face. I'm sorry, your fetus has no head. And yeah, you see here, these are different shapes. So more or less, you will, I'm sure you will see it, and your referral doctor should see it as well. And you see here, this is how things work in everyday's life. So this patient came, it is almost 6 o'clock. You see 70, 55. I have finished my day, and the nurse says, you know, there is a lady with a referral sheet. The doctor has just seen there is this problem in the head, said, okay, let me check her. We cannot send her home without. And then we did this. So she terminated and has, in the meantime, a healthy child, next pregnancy. So, and the butterfly sign is known by many patients. So this is what it looks like. So you see here the two choreplexes of the lateral ventricles, and then in hollow prosencephaly in allobar one, you have more circular head and absence of the midline. Now, sometimes, as you see in such case, it can be tricky, especially if you don't have more fluid, or if you have in one plane this view here, you move to another plane, and then you see that there is an hollow prosencephaly. So in other cases, like the semi-lobar and so on, may be tricky to be discovered, but keep in mind, go up and down to see this. And by using the trick of getting the several views, you know, the one picture with 4 images, I'm sure you will get to these diagnoses as well. The next part is on spina bifida. You know, it was my favorite for years, but now I think things have been solved, and it's not so, let's say, not challenging anymore in a way. So we started 2009 with the observation that in many cases, or in the article, if you read the article carefully, at least in some cases of spina bifida, because of loss of the fluid here, there is a shifting, posterior shifting of the brainstem, and almost emptying of the fourth ventricle. So, and using the same plane for nuclear translucency, and can help in detecting spina bifida. You know, it is a challenge to ask people to go to do a special extra plane. This is why it should be very simple. And the genius idea of Kipros was in the 80s, to say, while you are measuring the BPD, if you see the BPD is small, look at the posterior fossa, and while you are trying to measure the cerebellum, you will see that the head shape has changed, that the cerebellum cannot be seen, and this is lemon and banana sign. So you are using a BPD plane to detect spina bifida. What we are doing here, we are using a standard plane, which is the neck and the nuchal and the nasal bone plane, to look at the posterior fossa. It is en passant. Well, I'm not asking doctors to scan a special way the transvaginally to look at there, because then if you are so good in getting all the planes, you can see in many cases also the obvious spina bifida in these cases. So you see there are this meningote seal, there are the flat conditions like this one, but there are also the myeloschises, which are really tricky to see. So this patient we discovered on the brain, but we hardly were able to demonstrate this level. So not all cases will be obvious like the one on the left. And this is why when I started working on this field, the first thing I did, and today is so obvious, went to books of anatomy to see what's going on, and what is the developing of the posterior fossa. And this is a scheme given to me by Dr. Benoit, and from his anatomy embryology book. And then I understood, okay, this is what we'll be seeing later on. This is here, this echogenic part is the choral plexus of the fourth ventricle, and there will be fluid here and there. And I found later on a nice paper from McClone on the development of spina bifida in animals. And this is a mouse embryo. They showed this similar picture to the human, and they were analyzing how is the size of the foramen when there is a spina bifida. And then they showed this shifting. It is here squeezed and so on. But for me, it was more important to see that it is true. There is sometimes no fluid in the posterior fossa in comparison to the normal. And it was confirming the approach that you can use this in addition to what you added later on, that because of this squeezing, the brainstem, which is slim here, becomes thick. The distance between the brainstem and the occipital bone is getting less, and this is all squeezed downstairs. And the same was offered to me when at the Berlin Congress by Prashant. You see, Prashant, I'm using this, showing a normal head of a fetus after termination with exactly like the anatomic specimen, with the fluid here, and in spina bifida where you have almost no or quite reduced quantity, and the choral plexus is squeezed in the posterior fossa. So what we have here during teaching to tell the people, look at now the fluid here during spina bifida, there is a loss, continuous loss of fluid, and this is only in the open spina bifida, leading to a posterior shifting of the brainstem, to a thickening of the brainstem. But sometimes you have some fluid here. It's okay, but you don't have the typical lines, the 3 lines we know. So this is why we have a posterior shifting, what is then called later on the banana sign of the posterior fossa, and then it is thickened and shifted posterior. In other words, this is what we should be seeing. We should see 3 lines. The first white line is the posterior aspect of the brainstem. The second white line is the choroid plexus of the 4th ventricle, and the 3rd line is the occipital bone. And you see the size of the brainstem to the distance. And in spina bifida, you have 2 areas. You don't have 3 anymore. You have 2 white lines instead of 3, and you have the reversal of a relationship of brainstem to the distance. Now you see here, this is also one possibilities, and the open spina bifida you see here. And sometimes you see some fluid. I'll show you on the video, but often you will focus then on the brainstem. I would recommend you not to occasionally to look at it, but if you do it routinely, one day you will have an abnormality and you will see it. And I hope many of you have saw these cases easily in the meantime. So this is here one of my previous cases. So you see here, looking to the posterior fossa, you don't see the typical region. And I remember how I was scanning here, and the nurse was asking me, give me the number of the IT. I said, wait, I don't see the IT here, and I scanned the lady vaginally to get to the information. You see here then, vaginally, the same fetus here, you don't see the spina bifida here, but you see some fluid, but you don't see the typical several lines here. So you see more thickened brainstem and fluid, but you don't see the typical floating choroid plexus of the 4th ventricle. Then later on, finally, I succeeded to get the fetus turning in order to scan directly the spine. So if I did get it, I will have asked the lady to come back 15 weeks. Then you have seen the lemon banana sign, or to add AFP at 15 weeks, and you see it. So then when you see this plane, you will acquire a volume and you demonstrate the flat myeloschisis. So you see, it was, I'm sure, 100%, this would not have been a situation I would have seen on this view here. Look, even transvaginal, if you look at here, you don't see the spine bifida. So again, a player for looking to this region. But in the meantime, like me, there are other signs. This is a sign in the mid-sagittal view, and we have done a study in Germany, in Berlin, where we analyzed especially 16,000 fetuses, and all 11 cases were detected, but not in all cases at first step. 3 or 4, we were suspecting these, and then they were called back 2 weeks later in order to demonstrate the anomaly. It means in the hands of experts, it's feasible. And the best performer was the ratio. In the meantime, there are many, many other signs. You will use the sign you want, but one quite popular is the one when you see transvaginally. Under normal conditions, will you see the aqueduct of Sylvius between the cerebral peduncles, and Finn and co-workers with Simon Marr have published the distance here between this and this one as a standard measurements, instead of looking rapidly, and you see that there is an angle between the CP and the thalami, and in cases with spina bifida, there is a posterior shift, and the distance is shorter, and this was called then by Fred Ushakov crash sign as a new sign of spina bifida, which is actually not new, but it was given a new brand, but it was reported earlier by Buisson and then by Finn and Marr 2011. But you can use the technique you want, but provided at the end that you are seeing what you want to see. So this is why this is better seen vaginally than abdominally, to my experience. And another sign reported also by the group of Simon Marr, by Ramakrishna and co-workers. What you see here is you draw a line along the maxilla, and you will see that the brain stem and the midbrain are higher than the line, whereas in spina bifida, it is then shifted lower. So this could be also another approach called the maxillo-occipital line. Or another sign here, what we reported is the absence of fluid here. When you have the loss of fluid into the spine bifida, then you will have less, and it looks like a so-called dry brain. and we measure the relationship of the coronary plexus to the head. So this is actually well seen between 11 and 12 weeks plus 5, 6. But after 13 weeks, when there is an obstruction in the posterior head, then you will have more fluid in the lateral ventricles. So, and you see here, this is normal, and these are the all abnormal cases. Now, when you see this, that it was obvious. Why have we seen this before? And, these studies were easy to do because everyone has documented any BPD. So you go there and you say, can you please send me images of BPD? And then you put them and say, oh my God, it works. And we do the measurements to confirm this situation. Okay, then last but not least, we published last year with Paolo Volpe from Italy, an observation. And we had discussion online actually at a meeting, and he was reporting on the straight sinus, and he was saying that in cases with Dandy-Walker malformation, the straight sinus has a course along the tentorium cerebelli, and the tentorium is high, and he can see that the tentorium is high in Dandy-Walker, and he offered a measurement between the tentorium and the brainstem. And I was looking for years for this region, but did not find how to quantify this observation for spina bifida. And when he offered this, said, okay, look at now, in this case here, when you have Dandy-Walker, you have a high tentorium, and the measurement of the angle between the straight sinus and the brainstem is distorted. And I told him, in spina bifida, you have a very, very low tentorium, so you can use it for spina bifida. I give him some of my cases, and then we published this together in the White Journal, the low torque or hair position. So under normal conditions, you would have for spina bifida a small angle, for normal condition, a small angle, and in spina bifida, because the tentorium is low, you have an almost 90-degree angle. So I'm not saying it's going to be, let's say, a technique, but it's interesting that you can find many, many other things. And I hope that the adding of many additional science can be of help one day in detecting more anomalies. So you see here, these are two cases, the normal and on the other side here, the abnormal position of the straight sinus. Something new for you, I hope. Now, today, I want to be more provocative. The question is not if you can detect spina bifida, but what is the technique you are using to make the detection? Since we have many, many things in many planes, on 2D, on 3D, you can have a direct spine, axial view, sagittal view, color Doppler, and so on. It should not be the issue to say, oh, I'm not able to do it. So please put it on your list. It could be, especially in India, more important than spina bifida, especially that you have younger patients there, and some undernourished, and some having not a complete successful supplementation of folic acid. So you see here, these are the typical views. Once you start doing the BPD, you see that there is a dry brain or a small head. Then when you get the mid-sagittal view to measure the nuchal and the nasal bone, you see that the posterior aspect of the fossa is abnormal. And if you go vaginal, you see the crash sign or the obliteration of the aqueduct of Sylvius. Let's move now rapidly to the dilated posterior fossa. I will not spend time on this, because while you are looking to the spina bifida with the posterior fossa, you see that in many cases, or in some cases, you see a lot of fluid here, and some will be transient, some will be part of a severe anomaly, because like me, that fetuses with thalassemia 18 may have dilated posterior fossa. You can detect them, or like in this fetus here, but some may have an isolated Dandy-Walker. But please keep in mind one thing: a Dandy-Walker is such an extremely rare condition. Really, if you have in big centers 1 case a year, it's really very high. It's quite extremely rare. This is why the most cases are going to be part of another abnormality of the posterior fossa, or they are going to be resolving Blake's pouch conditions. So really, keep in mind, this is here a summary of the slide, what you can be seen. It can be transient, it can be hint of aneuploidy. Typically, thalassemia 18 and triploidy, they have more fluid. It can be Blake's pouch resolving later on, Dandy-Walker, but also other CNS anomalies. Encephalocele may be showing the high quantity of fluid before the expulsion of the brain. Now, ventriculomegaly is a tricky condition because you may see sometimes more fluid in the brain. It's quite rare, And these cases are from, let's say, from the book we showed you. It can be an early aqueductal stenosis when you scan at 30 weeks plus. It can be here an early work of warble. But what you should keep in mind is the main message is it is not a ventriculomegaly. It is not a dilated size of the ventricles, because if you measure, they are exactly the reference range normal. But what you see there is an inverse relationship of the size of the chorioid plexus to the lateral ventricles. Under normal conditions, it should be more than 50% of the area or of the size being filled by the chorioid plexus. If it's like you see on the left side here, less than 50%, then it is something where you call ventriculomegaly, and you go the same list here to check if it's transient by having a follow-up at 16 weeks, if it can be hint for aneuploidy or for rare brain anomalies, and it can be also posterior fossa anomalies like a true Dandy Walker or a true rhomboencephalocynapsis, and early aqueduct stenosis may show also this as well. So in general, the early cases are almost all, let's say, in relation to aqueduct stenosis, and the aqueduct you can see on 2D quite easily even after 15-week gestation. So observe and control at 15 weeks before getting to the final diagnosis. Now, for facial anomalies here, the second part will be, we'll have a look to the eyes, to the nose, mainly to the face, to the cleft. I'm sorry that I forgot to add the R here, macrognathia. So this is the view to the face, is the mid-sagittal view and the frontal view. And then what we can see here easily is the frontal view of the face with the maxilla and with the mandibular gap as a normal sign, as reported by Sepulveda. The profile provides, as you know, more hints than the nuchal translucency. So you see here this abnormal face in all these cases. And let me go with you through some of these. So my message was then, because you are looking to the face and you're looking to the nasal bone with the two processus maxillaris, look at the maxilla, because you can see pretty nicely how it is continuous. And in the posterior aspect, you see the double lines here. And the message is, don't focus only on the nose and on the neck, but also on the maxilla and the mid-sagittal view. And we reported some years ago on the observation. The aim was to increase the detection rate of clefts without telling the examiner, please, for this mean you need to rotate the probe to look at the face from the front and so on. So because the more images you are adding to your examination, the less is the acceptance. So this is why use the same plane as done for the neck and for the nasal bone, as done for the IT, and look at the maxilla. So, and this leads to an additional hint for until then often overlooked anomaly. And look at now these images here. Today, I hope when you have seen this sign, you say, of course, when I see the face here, I see that there is a gap, there is a gap, there is a gap, there is a gap. So in cases where you have a protrusion like here, it may be obvious. But in other cases like this one, you may see easily that there is an absence of the anterior aspect of the maxilla. And this is a mid-sagittal view because you don't see the processus maxillaris. You see pretty nicely. And this was a case overlooked in our center because you see this is where my colleague measured the nuchal translucency and looking later on said, oh my God, now that I know this, that there is a sign. This is where we were inventing the sign, that now we see this observation. And then it's like always in life, how have not seen this before and no one has seen this before. So, and you see here, this is then you rotate the probe to get a frontal view. Bilateral cleft to the protrusion can be seen here. This is, as you see, a fetus with trisomy 13 with the gap and the protrusion, thick nuchal. Or this one is a median cleft, midline cleft, and typical in trisomy 13 as well, where you have an almost severe facial anomaly. And the more tricky one are the one like this one here. So mediolateral cleft, where you have here images, nasal bone. And interestingly, my colleague she tried to show the frontal aspect of the face, and she assumed this is the maxilla region, and she was satisfied with this. But looking to these images, but looking to this one, as I showed you, showed that there is a gap. So I think today with the new images resolution, you can see even better. But I think this is enough to show that it is worth to look at this in this way. And turning the probe, you can see here another case that the gap is present there. Look at now this fetus here. I'm going from the left to the right, and you see here that in some part you will have the part of the maxilla, and part can be in the middle of the vomer, can be seen. Now, another way is also to look at the retrognathia, because the position of the mandible is just under the anterior aspect of the maxilla, and you see it is lower than the more in posterior aspect, and this is typical for macrognathia. It can be isolated, like in Pierre-Robin syndrome, but can be also sign of severe hints of the face. And Sepulveda reported on how to discover the macrognathia by having a frontal view. Now, I want to explain for you this shortly. If you draw a line here where you are looking to the face from the front, your plane is behind the anterior aspect of the mandible. This is why you will have, under normal conditions, you are in the region where you are behind, and this is called mandibular gap. If, however, there is a macrognathia, this mandible part will be behind it, and you will have a closed, and there is no gap. So in case you have a frontal view with no gap, this can be the hint, according to Sepulveda and co-workers 10 years ago, of a retrognathia. But I think the frontal view is better. I cannot speak on the gaps without citing Dr. Lakshmi from your country, and she examined with her team many fetuses, and she reported on what she called the superimposed line sign. What is the case here is, with discussion of the frontal view was focusing on the anterior alveolar ridge, but not on the secondary palate. In my approach of getting the mid-sagittal view to report the no interruption of the maxilla, was focusing on one line, but you can get sometimes a line here because the vomer can be there. The vomer is, the septum of the nose, and then it is, let's say, touching the secondary palate, and this is why you see two lines. And she said that in cases where you have secondary cleft palate, you see either one line or no line, and then you can see this one. In other words, my recommendation is, when you look at the mid-sagittal view, don't focus only on the presence of the maxilla alone, but also on the posterior aspect on the two lines, because then the absence of one of the lines here can be a hint for a cleft palate. You see here, this is a fetus where it had anterior was closed, but here in the part of the posterior aspect, there was only one line, and this is a cleft palate, secondary cleft palate with a normal mouth in a trisomy 18 fetus. And what you can see also in the face is the presence of an epignathos, and it can be early in gestation. And this fetus here had a hyperfusion, but I will not tell you what happened, because we just submitted with Kurt Hescher paper on the laser approach to stop the perfusion here, but unfortunately it went bad later on gestation. So await the White Journal case report. Now we go rapidly to the lungs and to the heart. I told you before that I want to have these four images: upper abdomen, four-chamber view, color Doppler, three-vessel trachea view, and then you see here the typical images of an abnormal four-chamber view are here, showing the absence of a ventricle, a common ventricle, an AV septal defect, or a single ventricle, a dextrocardia, and a narrow left ventricle incoarctation. But mainly, and I love to perform my work mainly on the three-vessel trachea view, because many anomalies can be seen here, from the reverse flow in the hypoplastic left heart to the right aortic arc. Even ARSA can be seen, or double arc, or even transposition of the great vessels. For the lungs, you can appreciate the presence of the two lungs, left and right, to the heart. In general, we don't look to the lungs carefully unless you are seeking for diaphragmatic hernia. I will do it in a sagittal view, or if there is a pleural effusion. So the abnormalities of the lungs are seen in these planes. You see here the heart is shifted, but extremely rarely you see at 12 weeks the stomach already up. The stomach is moved slightly and it's more vertical in its view, but you see mainly the heart shifted either to the right or to the left, depending on the presence of the diaphragmatic hernia. And you see pleural effusion in Turner's, in Down syndrome, but also in threatening Noonan syndrome later on. So I will move rapidly here. Gastrointestinal system, here it's mainly the anterior wall defects and some cysts in the abdomen. So don't forget, at 10, 11 weeks, you still have the mid-gut herniation disappearing after a 12-week gestation, and you can see the large omphalocele with the sac around the bowel. You have the free bowel and gastroschisis, mainly in younger patients, right side from the umbilicus, or you may have pentalogy of contrail. Typically, when it is a high position, you have an let's say the lower part of the abdomen is empty and no defect, and it's close to the heart, and the heart is beating inside. And you have here the body stalk anomaly where the baby is not moving, and you may see the foot close to the head. So this typical abnormality of the, I will jump this one. For the urogenital system, it's mainly the megacystis, where you see in the sagittal view, the size of the bladder should be less than 7 millimeters. And if I told you how to look at the kidneys and the adrenal glands, and you may use the renal arteries. I use them rarely, only if I want to confirm the presence of the two kidneys in a previous history. But in general, with the new machines, you can see pretty nicely the two kidneys. And this is the normal bladder size. If you have a megacystis, you will have one bladder being more than 7 millimeters. If it's between 7 and 15, the prognosis may be good. If you have more than 15, the prognosis in general is very bad. It's either nephropathy or a, let's say, severe condition. So you see here the data. Under 7 millimeters is normal. Between 7 and 15 millimeters is either aneuploidy, 10% uropathy, 70% will be resolving. If you have more than 15 millimeters, it could be aneuploid, but it's mainly uropathy with, let's say, with abnormal kidneys development and later gestation leading to dialysis postnatally. So you see, this is a case here, a large kidney, a large bladder at 12 weeks, and look at the follow-up 14 weeks, normal size bladder, and no thickening of the wall. So it is possible. The first time you see it, you don't believe, but this is what you have to keep in mind. And here, these cases are quite abnormal because the kidneys are also dysplastic, becoming dysplastic through, and you have the typical keyhole sign. Now, when you look at here with this view, and this is quite challenging, when you see the bladder is empty, but the kidneys are present, think of the possible presence of a bladder exstrophy. So bladder exstrophy is a severe condition. We don't see any bladder all the time, but you can see the kidneys. And what you see here typically is the lower aspect of the abdomen is quite very short. So if you measure here the distance between the umbilical cord and the pelvis, it has length, and it's here almost close to this condition. Look at now, there was twins at the control 13 weeks plus 6. You see a normal stomach and making the image larger. You think first it looks like gastroschisis, but you don't see the lower aspect of the abdomen. It's quite tricky, and this can be quite easily missed if you are not focusing on magnification and on the standard examination. Rarely you will have such enlarged kidneys like in Mecklenburg, because these are really the typical severe polycystic kidneys with empty bladder. The most challenging diagnosis, and quite rarely seen, is the bilateral renal agenesis, because it has normal fluid, as you see here. The typical hint is you have no bladder and you don't see any kidneys, but I will recommend you to wait until 15, 16 weeks, because you may have two pelvic kidneys, and it was at this examination not a full bladder. But you tell the patient, if it's true, we should have almost no fluid between 15 and 16 week gestation, and then the next time she will come and she will confirm the diagnosis, and then you can go for termination. And the more challenging diagnoses are the one where you have unilateral abnormalities, like you see the flat adrenal gland, and you see here this picture of the two kidneys, one in the pelvic kidney, the other in normal position with the flat adrenal gland here. So if you are using linear probe or vaginal examination, you can see this very well. And I prefer, as I told you, to do the frontal view of the kidneys in order to rule out a horseshoe kidney, as can be seen in this plane. We will finish now with the skeletal anomalies. There are two groups. One are the anomalies of the skeleton, which means some parts, the limbs, the spine, and one is the group of the skeletal dysplasia. And I want to show you some images here of abnormal limbs like the hands, or you see here the radius aplasia, either isolated, rarely, or in combination with some of the syndromes from trisomy 18 to factor syndrome, or the TRR syndrome, thrombocytopenia, absent radius syndrome, autosomal recessive. When you are seeking for aneuploidy, keep in mind that polydactyly can be a hint, not only for trisomy 13, but also for some ciliopathy, especially if you are dealing with consanguinity. And I will not discuss today the hint of skeletal anomalies because it is a topic on its own. But you should keep in mind that as we publish in our book or in this paper by Asma Khalil some 10 years ago, that there is a short list of possible conditions which are typically abnormal early gestation between, let's say, typically thanatophoric dysplasia, osteogenesis imperfecta, and achondrogenesis can be seen very early in gestation. So these are the hints to look at when you look at the different skeletal anomalies. And we cannot say any word about the pro of the ultrasound early gestation without discussing the cons. The cons is, of course, that in the pros that patient can be prepared and can do the invasive procedure work, but the cons is, of course, that some patients may be worried about the borderline findings, and in some typical diagnosis, they may go for termination of pregnancy. And I show you two cases where the patient decided to go for termination with a cleft. You may say, of course, but in Germany, it's not such an easy situation because this is something which can be well corrected. But in general, the cases we detect are severe. And transposition, medical doctors said, I know the literature. I don't want to have a child with a big heart operation of several hours after birth, and at 12 weeks they don't have a relationship yet to the pregnancy, and they may decide to go for termination. So I want to finish with this slide. I like quite well because until now the new modern technology is selling patient let's say NIPT and letting them 100% and so, and in some countries boy or girl, but please give the patient the complete picture, because we can see with your skill and with the systematic approach, as I showed in my talk today, many severe anomalies and many normal conditions. So rule out as many as possible in early gestation. And this is why we have to be honest to our patient and tell them, if you are worried about one disease, let me, with my machine, with my skill, show you many things, and tell your friends that you are able to see this and to rule out these things. I thank you very much. I will stop the screen sharing and I will have a cup of water on time. I start at 10 past and then it's 1 hour.
So thank you, Professor Chavi. Can you? Hello.
Hi, I'm here.
Yeah. Okay. Excellent. I would. There are no other words for me to put it across like that. Excellent cases. Excellent presentation. I mean, you are. I would consider you as one of the best. Oh, thank you very much. Thank you very much. Hope I know you have liked it, and you have also mentioned in your presentation. I hope it is useful too. Thank you. Thank you very much.
Thank you, my friend. So tell me.
It's about. I would like to know something about this talk, especially about the anomaly scan during this trimester, first trimester. How many people around in Germany will be able to carry out the scanning of first trimester anomaly scan? Is it a routine protocol to perform the scan?
I prefer to have discussion later on. We'll have a discussion together. But let's say for this, we have in Germany 3 levels of expertise. We have the level 1, which is the normal doctor, and the level 2, the one doing specialized and fetal ultrasound. These are around 800 in Germany.
Okay.
The problem is the doctors should refer the patient there, or the patient decides on her own to go there. I did not put in my talk, but let's discuss later on. I think this is better because,
all right.
Because
okay,
it's going to be more philosophical.
Okay, let me go to Dr. Ashok for his talk on the second trimester scan, and you'll have rest at least. You'll have rest for at least 1 hour to have not 1 cup of water, but more cup of waters. Over to you, Ashok. Ashok is a very dear friend. Everyone knows him across India, and of course, he's a very close dear friend to me also. Ashok is running his private ultrasound clinic in Delhi, and he is the president or whole and sole authority for the Society of Fetal Medicine. He is also one of the founder trustees in Indian Society of Ultrasound OB/GYN, a very well-known international faculty too. So Ashok, over to you for mid-trimester anomaly scan.
Thank you, Prashant, and thank you for organizing this morning for us. May I check if you see my?
Yes, I can see your screen. First thing first.
Yes, of course. And do you see my title slide now? I think that's
mid-trimester anomaly scan. Now you can
yes,
start your talk.
to remind everyone that that's what we're talking about, and I will take you through this. We will also highlight guidelines, some of the older guidelines. Because now there are no new ones currently of both ISWOG and the Society of Fetal Medicine. ISWOG because it has a global approach, and the Society of Fetal Medicine because that has a more of a local approach for India, where actually speaking, we need to be more strict about them because so much depends on this scan. And so here we go, and thanks once again for having me here on the faculty. Let's start with first things first. And the first thing is, what do we call this scan? It's been known as the TIFA scan, as the level 2 scan, but none of these words apply today. And I will be talking a little more about the level 2 nomenclature because we need to straighten that out between ourselves. The word TIFA, the targeted evaluation for fetal anomalies, is again something that is maybe just localized to one or two systems and may not be used completely, but we realize that it's not just the fetal anomaly scan, but that the mid-trimester scan involves more than just the fetus, and therefore it's nice to call it the mid-trimester anomaly scan. When I have that level 2 concept, I want everybody to know that this level 2 concept is a historical situation, which means that you and me knew that, yes, there used to be this level 1 in the 80s, early 80s, late 70s, which was a level 1 scan, dating scan at 14 weeks for everyone. And then all these girls went to the lab and got their maternal serum alpha-fetoprotein done. And then if they had an alpha-fetoprotein that was 2.5 times the normal value at that lab, they came back at 16 weeks for a confirmation of an open neural tube defect. So that really was the level 1 and the level 2 with the 14 and a 16-week window. What happened was that we did realize that there is much more that you can see in an anomaly scan, not just neural tube defects. And the fact that the 16-week window was used was purely logistical. And the embryological timetable now tells us that the right time to do this scan is a little later in the second trimester, and that we can see a lot more between 20 and 22 weeks rather than at the 16-week window. And therefore, we should call it the mid-trimester anomaly scan and not just a level 2. Some people, of course, call a level 1 the 11 to 14-week scan, the level 2 to the 20-week scan, and the level 3 to the third trimester growth scan. That, again, is not universally accepted nomenclature, and we really should move on to a common language that we use all over the world so that nobody gets confused. What it always involves is more than just the fetal anatomical survey. Of course, the fetal anatomical survey is central to all of this, but it does involve the fact that we like to look for fetal life, that the fetus should be alive, the number of fetuses and the type of twinning, if it's not been established so far, fetal biometry and the fact that the fetus is moving, and there should also be a maternal anatomical survey. That would complete the mid-trimester anomaly scan, and it will not be called the 1, 2, or 3. We really have to go beyond that and realize that there is much more than all of this. What we also must understand is that in terms of the Indian setting, we have the only scan that is allowed, or the only scan that is mandated by the government of India, is the mid-trimester anomaly scan. And this is something that we just have to carry out. And the nation owes it to every patient to actually do this kind of a scan. And therefore, we must carry this out. So I will take you through some of our local considerations, which is our PCP and DT Act. I will take you through the fetal environment. I will take you through the biometry, a bit on documentation, reporting, and management. I will not take you through an atlas of abnormals because really that wouldn't be doing justice to the basic stuff. And yes, we will discuss limiting factors, we will discuss technology, and there'll be a lot of emphasis on the planes that we must be using, the way we should be moving, the technology involved, the techniques involved, and basic biometry, because this is where there are a lot of variations. But like I said before, please do remember that every patient has a right to this scan. Unfortunately, expertise, number of machines, sophistication of machines is not available in every government organization. And therefore, we end up more with an institutional protocol and not really an anomaly scan. And that isn't fair. So if we have a compromise thing, either because we just didn't have enough people there who had the expertise, or there was an overload of patients, or there was technology that just wasn't good enough, then we should not be doing this scan in that institution. And the patient should be referred to an institution where this is done, or at least the patient should be informed that, look, we're not matching up to standards. And therefore, we have to be careful about what we're really talking about. Remember that this level 1 to 3 is also dependent on expertise in some parts of Europe. But again, even in Europe, this has been given up. And we don't strictly depend on any of this. And therefore, we go by what I just said. Remember that when should we be doing this scan? There is this generalization of 18 to 22 weeks. Earlier scans date better, undoubtedly. But earlier scans also require high-end equipment, they require high-end expertise, and they require a lot more time. Therefore, we start wondering what we should be doing. We do know that later scans see better. Later scans see much more. And you can see from this little graph here that if I were stuck at 17 weeks, I'd be picking up 40% of abnormalities. At about 19 weeks, which is what we used to use until our new MTP Act came along, I would be picking up half the anomalies. And if I were to do it at 21 or 22 weeks, I'd end up picking up about 70% of anomalies. So which one would I choose? My MTP Act is certainly a good one. And therefore, I have to be careful that I must be sure about the fact that I do these correctly. I have an MTP Act that allows me to act all the way up to 24 weeks. And therefore, if I even do this at 21 or 22, I'm going to be able to see a whole lot more. And I'm going to be able to, therefore, miss fewer anomalies. And I'm going to be able to see it more efficiently. I'm going to be able to see it with less technology, and it's going to be faster. Therefore, the ideal time has shifted because of the new local legislation, and we now do it between 20 to 23 weeks now. Why do I say 21? I like people to remember one single figure, and therefore I say 21 weeks. Now, the other thing that we must understand is that the scan, unlike what the people of India believe today, is not a guarantee that just because somebody has had a scan done and they have a normal report does not guarantee a normal fetus. And physicians don't understand this, our obstetricians don't always understand this, healthcare givers don't understand this, and the population does not want to believe this. But it's very important to make sure that we counsel every patient and the couple regarding the potential benefits, but also the limitations of the procedure. Because we do understand that this is not peculiar to India or to developing countries. What we do understand is that all of this is worldwide. That if you have experienced centers, we will detect up to 90% of abnormalities. And otherwise, in a general center, we would pick up between 15 to 99%, depending on which fetal anatomical system we're looking at. So there will be some, such as neural tube defects, which will pick up close to 100%, or anencephaly close to 100%. But we will miss out on, say, small abnormalities within the heart, such as the bicuspid aortic valve, or a small finger anomaly, and sometimes even spinal anomalies, just because they're not apparent enough. And of course, if we do a scan too early, they're going to get missed. If we do a scan too late, they'll also get missed. And therefore, it's right to make sure. Yes, of course, the really serious stuff like the gastroschisis, the omphalocele, the ectopia cordis, the holoprosencephaly, the exencephaly sequence will be picked up as early as the first trimester scan. But in general, you should expect that good centers should pick up about half of all the major structural defects in the early scan and about 80 to 90 by the time they come up in the anomaly scan at the mid-trimester. Now, this I've already told you, but you must realize that what we've also done is that in recent years, we've added Doppler. And a uterine artery Doppler is great. And you heard from Ravi that it would be wise that we should be picking up this nice, wonderful prediction of disease in pregnancy and the complications of pregnancy. And the uterine artery Doppler helps us to refine our risk of preeclampsia and to put into effect a different surveillance method. And therefore, uterine artery Doppler must be added to our perspective when it comes to the routine mid-trimester fetal ultrasound scan. We do understand that we need a protocol. And we heard from Ravi that when we do have this kind of a protocol, we're going to pick up more abnormalities. Yes, we will also pick up more abnormalities if we look harder in patients who have a high risk. But most of the anomalies, just like cardiac anomalies or any other anomaly, will be far more common in the low risk group. And therefore, we need a protocol for everyone. And the protocol is an examination which will be like a guideline and will tell us that, yes, you have to pick up this, this, and this by doing this, this, and this. It makes sure from the patient point of view that we're doing an adequate examination. And it also makes sure from a medical legal situation that we're doing an adequate examination, and it protects us in the court of law. After all, what is quoted in the consumer forums of India today is whether a protocol was followed or not. So when we do a scan in the mid-trimester, we must actually make sure that we are mentioning the protocol that we're following. So you could follow a very, very simple protocol. You could follow a very, very complicated protocol, but it doesn't matter which one you're following. It must find mention somewhere in the body of the report or as a footnote at the bottom. I don't like small font footnotes because they don't convey enough. It's something that every patient should be aware of, and therefore we should be doing it exactly like that. We do have guidelines from many, many, many international organizations, and therefore I want to know which one will we choose. We have the American guidelines, we have the UK guidelines, we have FIGO guidelines, Canadian, Australian, etc., etc. But we do understand that the ISWA guidelines have stood the test of time, particularly the updated 20+2 plane format. Plus, we have the Society of Fetal Medicine guidelines, which were written about 10 years ago, but still hold true. So between the ISWA and the SFM guidelines, you can choose which one you want, or you can use your own guideline. Like Ravi said, you don't have to follow a guideline. You can enhance it and make it your guideline and mention this in the report. Or you can choose a guideline and you can reduce it and say, this is my institution protocol. But it should be apparent from your report whether you compromised or you enhanced and what you included and what you didn't include. These are all published and available free of cost on the internet. The ISWA practice guidelines from 2010 and the Indian, which were in the Journal of Fetal Medicine, March 2014. And you can see that, yes, this is something that has stood the test of time. The upgrade has been the ISWA basic training. And of course, this comes with a license. It's worked on part of the educational program of ISWA. And it's a concept which tells us one of the many methods of carrying out an adequate mid-trimester anomaly scan. And it's been developed really to train people who are new to ultrasound. But I'm going to show you all of those because although it's been developed for sonographers and physicians who are completely new to ultrasound, you should be completely familiar with this, because very often you and me just completely forget to follow this. And we don't want to miss out at any point, which is the reason also why, apart from a guideline, we need a checklist. And the good news is that some machines have their own checklist. Some machines you can add a checklist. And in the newer equipment, we actually have an AI-based checklist where the computer recognizes that this is an appropriate section. It ticks it off there. And where necessary, the AI can actually, the artificial intelligence can actually figure out what the measurements are. So things evolve, and we have to evolve with that. But the important thing, like I basically said, that we must have a guideline and a protocol and a checklist in place. Please do also understand that these represent minimal standards. And like I said before, we could go beyond this and add it on. There are some official add-ons like a fetal neurosonography or a fetal echocardiography, but you could just add on whatever you feel like and say, okay, I will routinely do a mid-sagittal view of the brain to look at corpus callosum when I do my 20-week scan, and then you mention that in your notes. Or that I know that a cleft of the palate is extremely important, both psychologically and pathologically, and therefore I will always include an anterior axial view of the maxilla in all my routine scans. So you put that into your report so that people become aware of it. And you have every right to go beyond and become a more sophisticated, if I may use the word, operator as you get more experienced. And then, of course, like I said, you can downgrade in any way you wish, but it must receive mention in your report. The original guidelines that we had were the 2013 ones from ISWAG, and even ISWAG has added some beautiful guidelines, such as those that are for the heart, which were updated several times. And we also have the neurosonogram, which has been updated very recently in not just the old one of 2007, but the 2021-22 also. So it's wise to keep that in perspective and tell the patient that, yes, we'd like to do those. Some of us have a different system. We are not covered by out-of-pocket expenses. They're covered by insurance. So then you need to make sure what applies in your situation. But the idea is not to say that, look, if you can't afford it, we won't do it, or if you don't get reimbursed, we won't do it. The idea is that I will examine your baby in toto as much as I can manage with what I have, and whatever is missing, I will mention, and I will enhance it to make sure that people get the best report possible. Because you just can't say that, look, I don't have to do it. That doesn't make any ethical sense. You have to include it. Otherwise, like I said, you can mention the institutional protocol, which says that we do less than the minimum. Now, where do I get a checklist from? When we were updating a lot of our Society of Fetal Medicine guidelines, we mentioned checklists which came out 4 or 5 years after the original guideline, and they were published in our Journal of Fetal Medicine in 2017. And you can get a reporting form from that copy, and it's available free on the internet. We have a beautiful ISWAG mid-trimester reporting scan, which is a checklist and a report at the same time. And this was part of the original guidelines, and it's free of cost as a download, and you can go to www.iswag.org. It also has a column to mention the actual sizes, the placenta, the amniotic fluid, the fetal movements, whether it's one pregnancy or more, the date expected from our previous scans, the date expected from the period, and so on. And importantly, at the end, we have this, which says that I have a normal and complete examination, or that I have a normal but incomplete examination, or that the examination is abnormal, and that I need this kind of a follow-up. All that to be included as a conclusion, so that it becomes a good guide to the clinician. And then, like I said, normal, abnormal, or not visualized, to mention what you did not see. And what you did see is as important as you did not see. Now, who should have a scan? We already decided. The government of India has also decided that everyone should have a scan, irrespective of age. It's not that it would be confined for people who have a high risk for Down syndrome, such as those over 35. Even there, it doesn't apply anymore. We do know that most of our Down syndrome actually happen only in 70% of them happen in women who are less than 35. So we don't have any of those criteria anymore. Excuse me. So we have that, and we say, okay, this is the way we're going to be going. Now, what equipment? And this becomes important because we have this virtual explosion of the types of equipment. And when we see those, we realize that we have handheld portable equipment, we have not so handheld but portable equipment, and then we have equipment that can be moved around all over a hospital but is actually a nice high-end machine. Typically speaking, and we love to be quoted on this, we should use a medium or a high-end machine. And the problem is that if you use a low-end machine, the resolution will definitely not be good. Our patients are having a much higher BMI now than they used to have 10 years ago. And therefore, you really need to work very hard in case you're using equipment like that, and you will not be satisfied about 30 to 40% of the times. So if you leave an examination incomplete and say, okay, refer to higher center, which is our standard excuse when we don't understand something or we don't see something or she's obese or there is an oligoamnios, then we say, all right, this is what is the conclusion. So it's nicer that these scans should be done on equipment that has at least some promise. The question then arises is that something is better than nothing, that you should have a scan where we can actually try and exclude anencephaly. But does it matter? If we're living in such a wretched world where we can't even offer a good scan, then it doesn't really matter to that woman whether she has to abandon that fetus at term compared to earlier, because she's been treated so badly by the nation anyway. So what we really have to do is to make sure that we don't get into those hassles, that we make sure that decent equipment, medium or high-end, is made available at every center, and that we do this according to the recommendations of the Ministry of Health and Family Welfare, Government of India. The equipment must have a real-time grayscale, and we certainly will not use anything of the old-fashioned variety. It should have a transabdominal transducer and a transvaginal now for sure, because we like to assess for preterm delivery. Preterm delivery has a huge economic impact, and therefore it must be expanded and it must be included. And we can have very fancy transducers, but at least one in the 3 to 5 megahertz range. We must be able to adjust the acoustic power and the display, and should be adjusted so that you can fit in as much as illustrations for that case. Of course, there would be nothing that will not have the freeze and the electronics. But this business of the capacity to print or store images is important, because it comes under not only the fact that it becomes a medical legal document, but the fact that it is also part of the PCP and DT Act. And for your own learning in what I refer to as what my professor used to, retrospectroscopy, this is something that becomes very, very useful. And of course, it should be equipment that should be calibrated from time to time. Who should perform this scan? Government of India very clearly says if you have a postgraduate degree in gynecology and obstetrics, a postgraduate degree in radiology, or a MBBS degree with a 6-month training course, and these can be done. There's been recent controversy on whether the 6-month training course certification is adequate for an anomaly scan. I don't think we'll ever have an answer to that, because we, in heart of hearts, understand that not all obstetricians are great at obstetric scans. Not all radiologists are great at obstetric scans. Not all medical colleges give training for obstetric scans, either in obstetrics departments or in radiology departments. And certainly the exposure to MBBS students to obstetric ultrasound is close to zero for most parts of the country. So we should be practical, and we say that, look, anybody who does good scans should do this. Can we have a certification in place? We are aware that in India, certification is something that has not worked, because we seem to be sitting a lot on corrupt minds. It is embarrassing, it is shameful, but it is the truth. And therefore, you and me really have to make sure that whoever's doing a scan should be doing good scans, and that not just because a scan needs to be done, it needs to be done. After it does have limitations. This is a family photograph. I have nieces from all parts of the world. And they're all polycystic, they're all huge. And we've never been able to see their babies nicely except at the 12-week window where we looked at a suprapubic view. Therefore, you must understand that these things have to be done correctly and that the mid-trimester anomaly scan may not be the best. You could be limited by gestational age if you were doing it too early, or you could be limited by gestational age if you were doing it too late, because then you have ossification of the ribs and the general ossification, and that is difficult. You could also have a fetal position that is not suitable and the baby doesn't move. You will then say, okay, reschedule this whole thing, plus mention in your initial report that these are the areas that need to be looked at again. Then there is maternal habitus. We do understand that not all fat is the same, but typically once we cross a BMI of 32 or so, we have a lot of limitations in visualization, even with good technology. And that must be mentioned in the report if you're not satisfied with the scan. Oligoamnios is another big enemy. And then, of course, there's equipment considerations and expertise. And all of this, if it has limited your evaluation, should be mentioned in the ultrasound scan as you go on and do it. There's also the embryological timetable. And in the embryological timetable, it's important to realize that the cerebellum vermis and the cisterna magna will continue to communicate as late as 22 to 24 weeks of pregnancy, and that's not an abnormality. And you should just reschedule these for later on. Then the corpus callosum again may not be completely formed or thick enough or uniform enough until about 22 weeks of pregnancy. Then microcephaly is actually a third trimester diagnosis, as is the most common skeletal dysplasia, which is the achondroplasia. And therefore, you will not be able to see it. There is the bowel atresias and the respective urological disease, where it depends on how much a fetus swallows or how much a fetus produces urine. And only if the amount of swallowing is enough or the amount of urine is enough, will we see the manifestation of a fluid dilated viscera. Therefore, these would be the limitations from an embryological timetable point of view, and this should be conveyed to the patient and this should be mentioned in the report. And then, of course, the general insurance of letting the patient know that, yes, look, I have let you know, please sign this, and include them in the report as well. Because the patient could deny that she was ever explained this, or the husband can deny, or the companion can deny. And it's nice to get them to witness this document, because truly then they will know the expectation. Of course, they will still go to court, and it's not something that prevents you in case you are neglectful in your attitude. But the fact remains that at least a certain degree of frivolous cases will be reduced, and that's useful enough. Then, of course, you must put these images. These days, it makes logic to be kind to the environment and do this electronically. And these can then be stored up on your machine or on a local server or on the hospital or the clinic information system or on the cloud or in the software that is currently available. And ideally speaking, if possible, you must have video clips of the fetal heart. I think that's extremely important also for other areas, because then you can document fetal movements as well, something that's very important. And the fact that a video clip shows much more than a still image a lot of the times. And therefore, you must record this. Of course, remember that under the PCP&DT Act, you do have to keep images for a period of time of 2 years from the day that the patient was examined. And then we come to the report. It could be a single statement, which actually is good enough, but it doesn't appeal so much to our dear courts of law. It could be an essay which conveys a lot, but lots of people don't read that. And it could be a checklist, but most people don't even look at the checklist, they only look at the conclusion. Irrespective of which method you use, just make sure that you do always have the report and a conclusion. It also serves as a teaching instrument, and it also makes sure that you've done everything if you have a checklist. It also communicates better within the profession and outside the profession, and therefore it's something that I always encourage, that you should have a checklist as part of your reporting format. Then, of course, there's this question of what if you're doing an exam and you're not happy about this matching up. In that situation, it's nice to arrange a second opinion, and it's nice to facilitate that this is done as soon as possible so that the patient is not distressed and it's done by somebody who you think would be able to do a better job than you can. And sometimes if you find an abnormality, it's just medico-legally useful to actually do this and say that, look, I think someone else will be do a better job on this, and why not? Then, of course, we come to the core stuff, which is fetal biometry and well-being and the anatomical survey. Now, when I mean that, I say, okay, you will go through all of this and you will add on your uterine artery Doppler and you will use an anatomical checklist like this one, which is from the Society of Fetal Medicine. And notice that it says genitalia not examined, and it includes the umbilical cord. And it also talks about position, the no masses in the placenta, and so on. So it does include an evaluation of the environment. It is also one of the few that actually says that examination of the neck should form a routine part of your anomaly scan evaluation. And then it tells you exactly what you need to do. So the Society of Fetal Medicine guidelines do add on the fact that you will look for a 3-vessel view, just like we do all over the world. And of course, that when you look at the chest, it's not just the lungs, but also that there is no evidence of diaphragmatic hernia. Now, the second part that I'm going to take to you now is the 20+2 planes, and we will talk about how to do it correctly. So the first plane is something that is a general sweep. It's sweep number 1, and it confirms that the baby is alive, that there is only one or more babies, that the heart can be looked at. So what do you do first? Even before you go on further and you get into the formal part of the scan, remember that once you've confirmed that it's one single live baby and you see the heart nicely, there's a good chance that the heart is not going to behave itself for the next so many minutes. So you grab the heart and you finish the heart study. You also apply the same rule for the face. The moment you see the face and you see a frontal of the face, you grab it as much as possible and complete that study. While you're doing this, you also make sure that the urinary bladder is filling and emptying. And while you're doing this, you also check out that the stomach is filling and emptying, because these are the things that can delay you. The rest of the stuff can then follow, but this is the first step, really. Single live baby, heart showing, heart apex pointing anteriorly, finish the scan then. Face also being seen, do it in between or soon after the heart. And then, of course, keep on watching this so that you don't waste time later on to see whether the bladder is there or that the stomach is there. Remember that in the measurements, we have a biparietal diameter, head circumference, the abdominal circumference, and the diaphysis measurement of the femur. I also like to add the cerebellar transverse diameter because that's the one that goes down the least when it comes to growth restriction and the last. And therefore, if you're confused about the dating of the pregnancy, then you have to say, okay, I'm doing well, and I know that this baby is not restricted in terms of this, because the cerebellar transverse diameter is this many weeks and the size is also this many weeks. But remember that these are the measurements to be included. Do you do additional measurements? Yes. Those are done mainly for anatomy. And a lot of people now include orbital diameters and the binocular distance, which is the outer distance of the orbits. They include a measurement of the lateral ventricle, humeral length, nasal bone length, and of course the nuchal fold. So these are done additionally, not from a growth point of view, but from the detection of anomalies and the quantification of anomalies and for future comparison. So this becomes very, very important. Remember that this particular set of 3 images from ISWOG is now legendary, and we should use it as much as possible. That we have a standardized plane. For instance, we should not see the cerebellum when we are looking at the BPD plane, and we should see a very nice clear cavum septum pellucidum. When we look for the abdomen, we look at the spine in the back, the stomach here, and the entire portal sinus going like this from anterior to posterior, from the center to the right, and that would be the correct plane for the abdominal circumference. It should not include the kidney. What you see here is the suprarenal, and if it's the kidney and it's both kidneys, then it's not the right plane. So that's the way we go about it. When it comes to the bone has to be horizontal to the horizontal plane, and You only measure the diaphysis and don't measure whatever is poking out here in terms of ossification of the epiphysis. And you have an end-to-end. And if you're getting a shadow from the bone at both ends, then perhaps that is the most perfect plane, because then you measure the beginning of the shadow more than anything else. So do also document these and make sure that you get your results audited by an outside agency. We, of course, must also always at the same time look for fetal movements, not only of total fetal movements, but also individual joint movements. And all of this goes on side by side. But what we must carry out is the first sweep to see where the head is, to make sure what the position of the baby is, to make sure the number of babies and that the fetus is alive. Then you go on to the 20 planes and you go on to the last sweep. When you're doing the first plane, main thing then for seeing that the baby is alive is to look for the heartbeat. Then, like I said, we go on to identify a lot of abnormalities because we're following this protocol. And these are the planes. The sweep one is for a longitudinal and the head and body for initial orientation. The next three sweeps, planes 1, 2, and 3, will take you through the spine. The next three sweeps will take you to the 3 standard axial cranial planes. Then you have an evaluation of the thorax in planes 7, 8, 9, and 10, which will include the lungs, the 4-chamber view of the heart, the left ventricular outflow, the right ventricular outflow, and the crossover as a special attention. And then, of course, the 3-vessel trachea view, and that would complete half your planes at 10. Then there is, of course, the second part, which includes the abdomen, pelvis, limbs, and face. In the abdomen, there has to be one section showing the stomach and the umbilical cord, and then one of the cord insertion at the apex of the abdomen, and the transverse sections of the left kidney and its renal pelvis, and a transverse section of the right kidney and its renal pelvis to see whether it's dilated or not, and to identify the antero-posterior diameter in case of a dilatation beyond 4 millimeters. What do I do with the pelvis? Well, the pelvis really is used to assess the bladder and the umbilical arteries around it, and not much more than that. And for the limbs, you have to make sure that you have the proximal, the middle, and the distal segment, and it should be in the right upper limb, the left upper limb, the right lower limb, and the left lower limb. And you cannot say that, look, I studied only one of the hands and it's okay. No, you can have deletion skeletal abnormalities. You don't want to miss out on those, and therefore it's wise to look at both upper limbs and both lower limbs. You then move on to the face and make sure that you're looking at the upper lip, the nose, and the nostrils, that you're looking at both the orbits, you're looking at the lenses within the orbit, and that you're getting a good median facial profile. Then that will complete your 20 planes, and you do then an additional evaluation of the spine, which is a transverse sweep of the body from the neck to the sacrum, with the spine pointing towards the transducer, so the fetus must be in the right position, and you go one vertebra at a time with a completely open mind. That is the way then that you will complete the 20 plus 2 planes. You will then document all of this, like is shown here, as a sample from the ISWAG protocol, and that includes the head, the lateral ventricles, the 4-chamber view of the heart with the outflows, and then, of course, the abdominal circumference plane, the femur, the upper and lower limbs in their segments, and then we have, of course, the upper lip and midsection of the face and the orbits, and, of course, then the lower limb as well. So then that would complete that particular list, and you would be happy. Now, the question is that how much can be excluded? Not everything, of course, because this is population screening. You can do, for a high-risk group, a specific targeted screening. And as you learned about the first trimester, so it is with the second trimester. The moment you have a targeted approach, you definitely see much more, if, of course, that is a high-risk one. If it's not a high-risk and it's a low-risk, the moment you use a protocol, you will do much better than if you don't use a protocol. Now, where in the uterus are these sweeps? Let's try and see the first plane. The first plane is a sagittal from the back of the baby, and it's the whole spine with the skin covering it. The second plane is obtained by angling the transducer through 90 degrees, and that will bring you to plane 2, and that plane then will be the plane which is the coronal complete of the spine, and you will also get a coronal section of the body when you rock your transducer, and that would be plane 3. The next thing you go out to do is to see what images look like. This is the cervical spine. This is the dorsal spine. You can see the skin covering the spine. You will specifically look for the level of termination of the cord. You will then rock your transducer from side to side, pick up the level of the iliac wings and say, okay, 5, 4, 3, and 2. And my level of termination of the cord is at that point, and therefore I'm in clover. You'll make sure that you make an effort to see the spine all the way to the coccyx, and that you will not forget the coronal view. And then you will go ahead and make sure that towards the end, you will also go through a transverse evaluation of the spine at every portion from the neck down to the coccyx. The other thing we must realize is that we must try and make sure that the spine is always anterior, because some small lesions like this may not be so evident when you're looking at them unless there's fluid between the uterine wall and the posterior wall of the fetal body, and the lesion is of course large enough and that the fetus has the spine anterior. So that is a situation that you and me have to be very careful about and make sure that we're not really missing out on any of this. We also need to make sure when we're doing this that we are not missing out on the planes inside the brain. So we do need our standard transventricular plane, the transthalamic plane, and the transcerebellar plane. And we do know that we have a translation movements for our transventricular transthalamic plane, and for the transcerebellar plane, we need to tilt and pass through the occipital area and then come to the answer that you're looking for. From plane 1 or 2 to 4, you rotate the transducer through 90 degrees. And from plane 4 to 5, you rotate and slide manually. And for plane 4 to 6, you rotate. So how do you keep this in mind? You actually don't. You train your mind by doing many scans that you're going to be actually able to handle all of this. Do remember that 4 and 5 are parallel planes, and plane 6, which passes through the cerebellum, is at an angle of your 2 parallel planes. We also understand that while we're doing this, we will continuously be looking at everything within that image and within that section that you're focusing on your screen, and that you will do a good job of picking up all these factors. Remember that your checklist will then include lateral ventricles, including the choroid plexi, the cavum septum pellucidity, that you will definitely include the midline forks, the thalami, the cerebellum, and you would have additional views, which I like to do. I like to always make sure that I'm doing a mid-sagittal view also. Is it part of standard protocol? Not yet. But we do understand that the mid-sagittal view for the corpus callosum and the mid-sagittal view for the vermis of the cerebellum are useful. But again, remember that in the CNS, if you're doing a scan at 18 to 19 weeks, you may not see things as clearly. So do encourage scans to be done more at 20 weeks so that in a single scan you can go on and do this. We have strict guidelines also now for how to measure the width of the atrium of the lateral ventricle. And we look for this little dip here, the pointer, and this pointer very clearly indicates to me where I should be measuring. If I see the glomus, it does not mean that I have to measure there. No, that went out of the window a long time ago. What I need to do is to put my plus calipers onto on, which is inside to inside, and then get the answer that I am truly looking for. You then go on to move 2 or 3 things: the shape of the skull, the compressibility of the skull, and the continuity and the sutures of the skull. And therefore, you will then start figuring out what is going on. So this becomes your classical lemon-shaped skull for neural tube defects. This is the clover-shaped skull for thanatophores. And then here you have a strawberry-shaped skull, which is your typical skull of a trisomy 18. Here you notice that ossified, but when you press it, it seems to get flattened. And this was an abnormality of ossification of the skeleton that we picked up. And then there is this group here where you pick up a defect, and therefore you're pretty much sure at that time that the cranium is incomplete, that something is bulging out, and this therefore would be in meningocele. And it will evolve through pregnancy. So there's no guarantees to be mentioned at this stage. It could go either way. Is it likely to go this way or that way? Very difficult to predict. And therefore, we just say it could go either way. Then we move through the 20 planes further and come down to my thoracic planes, which will be a cross-section to include the lungs and the fourth chamber of the heart, a tilt towards the fetal right shoulder, so I will get left ventricular outflow, a tilt towards the left shoulder, which will give me a right ventricular outflow tract and the crossover of the major vessels, and I will pick up a 3-vessel trachea view. I will, of course, at the same time make sure that my stomach and cardiac apex were at the same side of the fetal body, and equally importantly, I need to make sure that I'm doing all my planes together and recording my stomach very, very clearly and making sure which is left and which is right. What do these things look like? You know this old diagram, which starts with the stomach plane, goes on to show you a 4-chamber view, goes on to show you a 5-chamber view with the ascending aorta coming off the left ventricle. As you go higher, you see a larger vessel on the medial side, and this is on the side of the left side, and that is the main pulmonary artery. The next is the plane of Ravi Shavi's original 3-vessel view, which shows the bifurcation of the pulmonary artery right and left. And then, of course, you have a classical 3-vessel view. And somewhere while you rock up and down, you will demonstrate the connection between the pulmonary artery and the transverse aortic arch. So this is something you have to do. And remember that when you're looking at the heart, you can't afford to remember that you need to look at the lungs too. You also need to see the spine. You have made sure that you're in the right section. So that's why we see the entire rib along its length. And then you say, okay, I know when I look at this whole thing that this little valve is higher, this one is lower. There's no holes in the interventricular septum, that the cardiac apex is formed by the left side of the heart, that the right atrium is that the right ventricle is also doing well, that we do have, if we look carefully, the pulmonary veins emptying out on this side of the fetal heart. You then go on to rotate, and as you keep on rotating, you will find this junction between the right ventricular outflow and the rest of the pulmonary trunk to be very, very obvious. And then for the clean, neat things, you will record them right away. Otherwise, you will make a mental note and say, okay, I will come to this later. You then go on to, of course, demonstrate much higher the 3-vessel trachea view of the heart, and you rock yourself down so that you can see a transverse section of the abdomen with the stomach and the umbilical vein, that you can see a transverse section of the abdomen at the level of cord insertion onto the anterior abdominal wall, that you then get a transverse section by rocking your transducer to include the kidney in axial section, as well as the AP diameter of the renal pelvis. And you do that separately for the right and separately for the left. And then you go on to have a section that shows you the urinary bladder, the pelvic viscera, and both umbilical arteries. What do these look like? This is your classical 3-vessel view, and you don't need color to show that. This is your abdominal circumference view, with the stomach seen beautifully and the umbilical part of the portal vein seen beautifully. That's cord insertion onto the anterior abdominal wall. Here we see that we've got an oblique section, which is showing me both kidneys on the side of the spine, and that you're looking at an AP diameter of both. Of course, it's within the normal range, but the fact is that some babies will have the spine anterior, and that's a really good time to look at the kidneys. You could have a discrepancy in the renal AP diameter, but as long as it's less than 4 millimeters, you're pretty happy. The abdominal circumference plane must include the this portion of the umbilical vein, and then the portal sinus must include the stomach, and then also make sure that it's the adrenal here and not the kidney. And then you go on to the bladder area and you look at it like so, and you say, all right, two umbilical arteries, and we're completely happy. Then you move on to the rest of the planes. And let's see what those are. Those are my limb planes. So they actually include the whole limb. Little tricky, both in early pregnancy and later pregnancy. You have to time this very correctly and you have to be patient with yourself and say, no, I will look at the proximal, I will look at the middle and the distal segments. And we say, okay, I will measure the femur. I will make sure that my humerus and my ulna is there along with my femur. I will make sure that I see the entire foot. Then I move on to the opposite side, and it's exactly the same situation, that you look for these, and this is what it looks like, pretty much identical looking at this stage. The femur, the knee, the nice, wonderful tibia and fibula, and here radius ulna on this side, and this is the actual humerus. So that would bring you to the end of what we call the planes for the skeleton and the trunk. Then you have a very important one, which is for the face, and that refers to planes 18, 19, and 20. When you're at plane 4, which is your transventricular plane, you slide and rotate through 45 degrees to about 70 degrees, depending on maternal habitus. And then you say, okay, my 4 to 19, you will rotate minimally, and you will also from plane 4 to 20, slide an angle through 90 degrees and minimal rotation to try and see what's going on. So that is the way to make this attempt. You will also not forget that the face is part of protocol, and you will have one mid-sag view that will show you the nasal bone and the rest of the things, which is the skin of the nose and this portion, which is the tip of the nose. Your next view is an axial view, or tangential view as we like to call it, of the two nostrils, the lips, and the nose. And this is the situation that you and me must understand, that this is a very, very important view and that you must see it. While you're doing that in your rocking, you can in this view or in an axial view also pick up both the orbits. You can measure the distance from the outer margin of the orbits, the inner, and so on, and come to your conclusion on whether you need further testing. You will also make sure that you add this additional view. These are the two central incisors, and they're very, very well seen in a large section of the population that is from the northern parts of our country. So this view is made by rocking the transducer when you're trying to achieve a good view of the orbits, and then you're able to go a little lower and you're able to achieve this, and it works pretty well. So basically what we'll end up doing is to take a few sections through all of these and say, okay, I will now complete my 20 and this, and then I will try and detect at least this many abnormalities. It says exclude 50 abnormal fetal appearances. Now that's very tricky, but it can be done. So you have to check with them on what they have decided to follow, and then we will follow it completely accordingly. Remember that because of this, there are certain things that you will see very clearly. You'll find charts like this on ISWAG, which is the most fantastic counselor I have ever come across. And I say, okay, you will look for all these conditions, and these are all lethal conditions, and we must therefore take extra care when we do these. What do you report, or how do you refer? Well, you make a summary like this, that yes, we saw the spine, head, thorax, abdomen, pelvis, limbs, and face, that the atrium of the lateral ventricle is greater than 10 millimeters, and that the BPD and head circumference are on the outside. Then we also have a range where you have one or both the renal pelvis greater than 7, and in the final one, you're thrown out of the window when the femur length goes less than normal range, saying that there will be a problem. That is no longer true. And so there is no question of there will be a problem. So what I've taken you through is the 2 overview planes and the 20 planes in the described sequence provided by ISWAG. And if you use this efficiently, you would be doing a very good logical use of your time, and it will be very time efficient. Remember that examining the fetal anatomy correctly is more important than the order in which it is assigned, which means that there is no business of too many disturbances. Then, of course, remember that your role is to distinguish between the range of normal, because there's so much of a variation, and abnormal appearances, the mid-trimester fetus. And therefore, then you have to be careful and see what you are truly up to. Then, of course, you can always ask second opinions. And then you say, okay, I did something, she has a history of cleft palate, I will look harder and I will look for the palate. Or there was this history previously of something in the brain, we don't know what it was, and sure enough, this time you have a frank arteriovenous malformation. Then, of course, you have techniques of color, 3D, and so on, which help you on a very daily practice of the subject and make sure that you not only work up each finding, but look for associated abnormalities, know the natural history, and do not limit the use of technology to come to a complete diagnosis, because teamwork is really the answer for all of this. So there we are at the end of this particular talk, and we're quite happy to answer queries. And if one of you wants to do a summary, that's fine. And of course, we don't have too much of a report delivery system, but not such a bad idea. And communication with the obstetrician in case of abnormal findings is becoming important, because we all need to be on the same page, even though it can sometimes turn very, very unpleasant. Very nice, my dear. So we move on to the last bit, which reminds me that I might see anomalies late because of the attitude and bones limit evaluation. This might even be very tricky, but I must do a systematic evaluation even later in pregnancy, and then plan out in case I see an abnormality on what we have to, where we have to deliver, and so on. Then, of course, there is something that you must understand, and that is that every scan is an anomaly scan. That you will look for limbs, that you will look for the heart, you will look for everything else, including the high risk factors, but you will also look at the low risk factors at week 30. So you have to be organized accordingly. You must use appropriate equipment, acquire proper skills, and make sure that you have a liberal use of ultrasound genetic technology in your daily practice. Patient counseling must include limitations. Patient counseling must be done, because there are no guarantees in these tests, and therefore we need to be careful. And then the report must include limitations. How does that sound? That it is possible to reduce the so-called burden of congenital anomalies. That scans should be done at 12 and 21 weeks, and additionally when indicated. That you must remember that dating is best done between 8 and 13 weeks. That anomalies evaluation is shifting to the 12 to 13 week 6 days window, and so is the brain, and that limitations exist and should be handled appropriately. And thank you so much for your attention. There we are.
Thank you, Ashok, for your excellent presentation. We have a few questions here for you.
Yes.
First question is, at what gestation will you prefer? Is it at 18 or 22 or 21 weeks?
Well, as we emphasized, definitely at least 21, preferably 22. And the 23-week girls are so marvelous because you can get them done so fast.
Okay. There's one more. Actually, this question is for Naren, but he is not there, so I'll ask you. Can amniotic fluid at 9 weeks scan looks echogenic like hemorrhage with a live fetus?
Yes, of course. And so you can have echogenicity within that. It could be blood. You could also have pus if there has been an attempt to enter that uterus. And you have to be very careful about that. And you could otherwise not have as many flakes. So there's no question of vernix at that time, but you could have a live fetus and a huge amount of hemorrhage. And if it's hemorrhage, it will evolve in terms of its appearance. It might disappear, and you can have a perfectly good outcome of that pregnancy. Or it might just look very different and look different every 2-3 days.
Okay. One more question, Professor Khurana. Do you advocate mentioning that external genitalia are not examined in final printed report in MATS?
We don't even mention the genitalia. Because you see, we live within a world where nobody understands the English language completely. And the patient will think I didn't do a complete scan. And the government will think he did a good job. Now, are we just going to do everything that the government asks for? Yes, of course. Do we have to make such a fuss that it erodes the kind of faith that the patient has in you? And importantly, everyone who does an ultrasound scan knows that with the least of effort, the genitalia will stick out both in a girl and in a boy. So, truly speaking, we tell lies 25 times a day, and nobody has the guts to admit this, except people like me who can retire tomorrow. There's no problem. And I know they won't retire me. But most people cannot get away with this. And so it's wise to just not even include genitalia in the report and just keep it quiet.
Thank you. Professor Chavi, this is for you. Which route is promising for 11 to 13 week anomaly scan, TAS or TVS?
Appropriate both.
Appropriate for 11 to 14 week anomaly scan. Is it transabdominal or transvaginal scan?
Both.
Both.
But
So
let's say if you have to be prepared, 11 to 12 transvaginal, 12 to 14 transabdominal. So roughly, and then you see what you want to demonstrate. I say in my talks in general, my aim is always, I have my checklist. If it's done abdominally, it's fine. If it's not done, I will finish as much as I can abdominally and scan vaginally. It is by far more easy to have a transabdominal nuchal measurement than transvaginally, by far.
okay, there is one question. Is it necessary to identify bilateral nasal bone ossification at NP scan time, or can a single ossified nasal bone be considered as normal? That's for you. For you.
You know, if you are able to see the one and the other one, actually, you know, today in the age of NIPT, no one is really caring for all the micro details, you know, and, you know, it depends also what gestational age you are scanning. If you scan 11 weeks, you may not see any nasal bone. And there are patients when you see they have a small nose. So this is not the issue. But, you know, actually, if you see 1 out of 2 and the other one is absent, it's considered as absent, because you can't get a plane with the absent nasal bone. So the question is, let's say I will invent a setting. Imagine now we have a setting in the ideal world. No country is ideal world, but in ideal world where you have to recommend, and if there is a recommendation of an IPT, then it's paid by the insurance company. This could be an ideal world. You have a proper scan and you write the risk. So in that situation, I will use the nasal bone to increase the education. But I will not, if the lady has an IPT, start by saying, oh, the NIPT is nice, you have no Down syndrome, but the nasal bone is absent. What does it mean? I don't know what does it mean. So, and then she says, my husband is from Africa. You know, it could be, but no one knows. There may be syndrome. There are no syndromes. So come on. Today it's easy, you know, this is, you know, this is why, let's say, I want you to learn your skill and to put all in a context. The context means for me, if you have a 20-year-old lady coming to see you, the neck is 1.5, and you see a short nasal bone, and you don't find anything else, that is normal, the heart is normal, come on, it's okay. It's 11 weeks plus 5. If you have a 45-year-old lady coming to see you, and the neck is 1.8, and there is no nasal bone, it is down. It is down because she the prevalence of the disease in this group of population is 1 to 30. So put things in the context.
Okay, thank you. What is upper limit of nuchal at 12 weeks for you only? Question.
I will take the book of Prashant and have a look.
So it's
how much did you pay me for the advertisement?
So
no, you know, this you have table. You know, you have tables. So there is no rule of thumb. Say, oh, you know, this is why you have reference ranges, and it's not 12 weeks. It's the size of the fetus, actually.
So the moment you call it as a one that the latest reference from Kipros, they said anything more than 3.5, you need to investigate.
No. Okay, no, this is look, this is different. What Kipros is saying is. What I like also in the approach, he took the whole data at the beginning, you know, the stratification. He said, let us look at now fetuses having Down syndrome. And if you take 1,000 and you look at back, what were the risk? Part 1. And they found out that 80% had the risk of 1 to 50 and more. 15% to 17% had a risk 1 to 50 to 1,000. He says, so 97% have a risk always more than 1 to 1,000. I will offer to this group more comprehensive scan. And the 15% between 1 to 50 to 1 to 1,000 are the one where in the past he added nasal bone ductus and tricuspid. In the meantime, it is NIPT. So if you approach the same, and you do now the same for other issues, then you can approach this in this way. You should go back and see what are the risks leading to let's say to increase risk for trisomy 21, and then you can get back to all the numbers. So this is I think the best approach to do it. Yeah.
Next question is, can we detect AP window, aortopulmonary defect in the heart on antenatal ultrasound? Of course, yes, you can diagnose. Next question is, can we...
What aortopulmonary window?
Yes.
Such a rare condition. Come on. You want to see it at 11 to 13 weeks? No, you will not see it. Forget it.
It's a general question. Can you diagnose on antenatal?
Yes, it is diagnosable, but the main problem is you need to have a good 2D, because if you add color, you will cover with the color everything else, and you will not see that there is a gap. It is possible to detect.
Can we take nuchal translucency measurement during a transvaginal scan?
Yes, you can.
Yeah.
But let's say you can do it, but let's say in my experience, I will say 7 out of 10 times you will fail, because you don't get the plane. If you get, unless the baby turns, if the baby turns, that you can see the nucleus, you don't see the heart. So I'm more interested in the heart and the kidneys when I scan vaginally, but not in the brain, but not in the nuchal.
Do you recommend NIPT for every patient instead of combined screening?
You know, the word recommend is really hard. Recommend means, let's say, let's do it the other way around. If I write recommend and the insurance company comes and say, please write me an explanation why you are recommending, I should need a justification, and there is no justification. I'm not interested in hunting Down syndrome. So it's not my job. My job is to offer the patient the best treatment and the best counseling she wants. If a patient come to see me, said, you know, and this is Germany, I want, you know, for me is Down syndrome not an issue, but I want to see that the baby has normal anatomy. I will not tell her, but I recommend you. So I don't care. I said, you know, and some patients said, you know, doctor, Down syndrome, these babies, that, you know, stop. It's not my job. You come to me and you are ask me. For me, if you accept a child with Down syndrome, it's fine for you. I don't care. It is your decision. You don't need to justify to me. But if you want to be prepared, you can go for the test. So this is why I will not recommend. I recommend only when I have, let's say, a mixed group of disease and then a previous history. I recommend, of course. And if you have intermediate risk, I offer to all. And
so in India, we have got a different scenario. Patient has to pay everything from their own pocket. So if, say for example, patient is really very well affording, and they can afford 7,000-8,000, because in India you can get your NIPT test done in 70 euros or 6,000 or 7,000 rupees. So if they can afford, they can spend, if at all they want a better detection for a Down syndrome only. And there are people who can't afford, they are not getting it done. So it's not driven by only one situation. Okay. There are a lot many factors which are affecting any aneuploidy assessment in India as far as first trimester is concerned. What is your thought, Ashok?
I would agree that yes, we offer this to everybody and give them the option, because there's no way to tell whether a patient is rich or poor or wants to pull that money out from somewhere. In a poor country like ours, when we need the money, we always manage to cough up the money from somewhere or the other. And most of us have the money, even if we pretend that we do not have the money. The second thing is that what I really would like to know, in addition to Down syndrome, is the anomalies, of course, as we've heard today, but the screening, as Rabi told us in the beginning of his talk, for what are going to be my complications of pregnancy. And in India, we don't have just a 4% incidence of preeclampsia and its complications. We have a national average of 8%, and some areas that have a 33% incidence of gestational hypertension. So the test I'm looking for in that situation is a PLGF. And that is going to be combined with my uterine artery Doppler. And I need to do that because that will stratify care, that will save the mother, that will save me from iatrogenic preterm delivery, and that will save me from postnatal complications. So what I'm really looking for is a test that will tell me, A, of course, about Down syndrome, but additionally, my outcome of pregnancy. So that is a very, very important test for me.
So, Ashok, you have opened a Pandora's box now.
No, I haven't.
Ashok, in that case, ideally, if you ask me, the patient should have, before she comes to you, the IGF, before, like what we were doing with the PEP-A in the past. And when she comes and the value is abnormal, you met the blood pressure and you have another discussion of the scenario, because then you are focusing on the complication, less on the nuchal, for example, But what is bad sometimes is you do all things, you are finished, and then you do the blood test, and then the news come, they are bad, and then you restart the discussion. Oh, you call them, the values and so on. Ideally, they can have it before.
Yes.
Let me add to the discussion. The moment you play with the software with or Astraya, which I'm using Astraya, the moment you add on the values of uterine artery Doppler, your obstetric history, and the maternal demographic data, you will have more than 90%. The moment you add on 10% false positive rate, you will have detection rate of PT or prediction is going to be 90%. That's what they say. Adding PLGF will add on 6%. In India, there are quite a lot of issues about doing PLGF. They are charging almost around 3,500 rupees or the 3,500 rupees. And in India, government pays you to deliver a lady 3,500 rupees. So where is the investment for PLGF versus investment of doing a normal vaginal delivery or doing a cesarean section? There are a few government schemes which are offering you only 3,500 rupees to conduct a delivery. So it's about doing a uterine artery Doppler, yes. Adding good demographic data of mother, doing a good blood pressure measurement of mother in the first trimester will guide you, and using aspirin to a lower threshold can solve the problem rather than adding a PLGF as an investigative armamentarium. The moment I reduce my threshold of aspirin at rather than 1:100 to 1:200, I cover those PLGF investigation and save a lot of cost to the patients.
Of course, I agree with all of this, Prashant, but this is what we have to do. We have to change our mindset.
Yes,
we are not a poor country. B, we're going to pay out of it of pocket ourselves. C, every single company, which is all of them, is now charging us only 400 to 600 rupees extra when they add PLGF to our first trimester screen. So if I'm going to be doing all of this, it's very, very clear. So if we change our mindset, we will do it. If we respect our women, we will do it. Also, if we double check our uterine artery Doppler with a PLGF value, we will not get that many false positives. So you have a balance in place. The first thing we have to do is to realize that we don't like to pay for healthcare. That is what needs to change. And if we don't, as professionals, realize this, then not the patient is not going to realize this. So just because what the government does is not the gold standard. What the government does not do is the gold standard.
The gold standard.
And that is what you and me have to fight against. And that is why I sit in the passages of the Ministry of Health and Family Welfare day after day to get new rules done. And this is necessary for the people of our country because we cannot afford intraventricular hemorrhage because of iatrogenic preterm delivery. That is a killer. We cannot afford nursery care at 50,000 rupees a day. We cannot even afford nursery care at 10,000 rupees a day. This is a wise investment. So we have to change our mindset irrespective of whatever cost analysis you give me. This cost analysis is equal to the cost of 2 pizzas, 2 boxes of French fries, and 1 Coke. And if you're not able to do that for our babies, it's not worth it.
Ravi, your comment?
Yeah, exactly. This is what I want to catch up. So a friend of mine, he's a funny person. When he scans the lady and said, I will recommend you to do, I don't know, NIPT and IGF and so on. She said, how much is it? No, it's expensive. And he said like this with a serious mindset. I'm worried that what are you? Why or what? You want to have a child and you start sparing money just before the child is there. Later on, you'll pay money for toys, for parties, for hamburger. And now you tell me 50 euro here and 100 euro there. It's a bad beginning. You want to have a child, you have to take a bunch of money and you pay for the good scans, the appropriate scans, and the tests. And then you will get the healthiest child then you can have one pizza less, because this is an example. And then, then she realizes that she cannot get a child and start to spare money from the moment of 11 weeks. And he said, I'm worried that you want to have a child and you spare money just before beginning. So, yeah, I think this is, what it's important for the patient. Honestly, this is what my approach is, to tell them that I am not caring because it is their decision, that they have the impression I'm not doing this, that I earn more money, but it's for well. And what I do is the Amazon approach. I tell them, people in your age, in your situation, 90% of my patient will opt for an IPT. And I have on my desk the fresh report to science that look at from yesterday or from last week. We have 10 reports. It is our daily work that patients are doing this. If you think that you cannot cope with a child with Down syndrome, I would recommend you to go for it. I prefer to offer you the test as an addendum instead of saying I recommend warmly because I suspect something. So most patients will do it only to be on the safe side. And you spend the time today to come with me that we see the baby is normal, but I tell you, there are many babies appearing normal having Down syndrome. So if it's your worry, pay the money and do it. Otherwise, it's up to you.
Thank you very much, Professor Ravi and Ashok. We will continue. It's exactly 1 o'clock. We are dot on time. So we'll again rejoin after 30 minutes after finishing the lunch.
1 o'clock is for me 4 hours from here.
Yeah. So
half an hour?
30 minutes. Yes.
Okay.
Perfect.
Thank you.
Thank you, Prashant. Thank you, Ravi.
Right.
So, good afternoon in India, good morning in Berlin. In this talk, I will be discussing with you the neurosonography, and I will call it basic and advanced. I want to consider my talk rather as a, let's say, a kind overview, as a discussion for all of you. And I will recommend you just at the beginning to refer to the guidelines just published by the ISWOG the last 2 years, because there are a lot of information what you can use in your daily work. So let's start now on different approaches to the fetal brain scan. It's similar to other regions like the fetal heart. You will have here the high-risk patient for CNS anomaly because of history or other reason. It will be sent directly to a fetal neurosonography, but you also have a group of having no risk, and then the basic ultrasound screening is the mandatory, where you will be focusing on some details, and then when there is a suspicion, refer to neurosonography. Now, the question is, if you are working as a basic doctor, this is where you have to learn. If you are an expert, this is how you should teach your referral doctors, and this is the aim of my talk today. Now, I think the BPD, the biparietal diameter measurement, is a successful story. And if you look at now, over time, it started to be the first part how to detect that there is a head in the fetus, the A mode with the two lines of the skull with the with the falx cerebri later on in the first compound images, as it looked like. Today, we see the BPD in this way, and the images are linked also to some, let's say, aims over time. At the beginning, it was to rule out anencephaly and to detect what is the head position, if it's a breech or a vertex presentation. Then later on, when it can be well delineated, this is where we started to measure gestational age by BPD measurement. And then later on today, because we see a lot of information in the brain, especially in the distal part, in the transducer away part, then we can use the BPD measurement as a first step in order to recognize abnormalities of the brain and use it as a checklist. So this is why it's important to focus on these things. As you have heard in the previous talk, the basic examination consists of two almost parallel, close to each other planes, the transventricular, where you can see the lateral ventricles, and the transthalamic, where you can measure the BPD, and tilting the probe slightly to the posterior fossa. Then you will demonstrate the cerebellum with the fluid behind it, and then you will be able to assess the fossa and measure the cerebellum. Now, in some specific cases, and some specialists are doing on routine, you may add to your basic examination additional planes. The additional planes can be frontal planes or coronal planes from front to back. And these include this one, like the interhemispheric fissure in the anterior part, then one with the frontal horns with the cavum septi pellucidi, where also you may see clearly the thalami and the corpus callosum in the frontal view, but also in the posterior aspect of the brain in frontal view, where you will see the cerebellum. And then one of the preferred planes is the sagittal or parasagittal planes, are the one you use the fontanelle, either the anterior, or here it's between the anterior and the posterior one, where you are able to demonstrate the midline structures, including the corpus callosum in the middle of the brain, or in the posterior fossa, the cerebellar vermis with the different fissures. And then if you are fond of the neurosonography, then you need to go transvaginally, because this is by far the best view to look at the brain. Now, I do it in some specific cases, but in comparison, Dr. Ritsuko Pu from Japan, he does it on all the patients. So it is also an approach. If it's your field of interest, then you can focus on it. And but if you want to have a proper good approach to study the brain with the vaginal probe, you don't have always fetuses lying in a good position like this one. Then you need to reconstruct images, and this is what I would recommend you to do next, is to learn to use 3D tomography or 3D ultrasound in order to get to the different planes of the brain, and to reconstruct, as here, a multiplanar mode tomography showing you the different planes of the head of the brain. And look at now, this one picture summarizes everything you need. It shows you in the upper part the falx cerebri, and in the middle part the cavum septi pellucid, the choroid plexus, the lateral ventricles, the cortex with the insula here, and the thalami, and the region of the cerebral peduncles until the cerebellum with the posterior fossa. So you have one view, and you can go and get this. In general, if you, depending on the numbers of views you are using, you can choose the distance, and then you can have it as a preset in your machine, what I'm doing. And then if the baby is not in good position, then you can reconstruct. You can reconstruct the corpus callosum out of the volume. You can reconstruct the cerebellum vermis out of the volume. So this is also a good combination using 3D multiplanar mode tomography in combination with a good scanner, and in combination sometimes with the transvaginal ultrasound. Of course, people ask me like always, you know, the role of MR and so on. Here we have to be careful, because MR is a technique, and MR information is depending on the user. So it's like saying transvaginal ultrasound is better for the brain, but if you cannot examine the brain, you cannot get any good images. The same is for MR. You need an expert, but the expert in MR will be providing you 10 to 15% more information than the ultrasound can get, because we don't have any shadowing. We can see also different structures of the brain. So it is a wise combination in cases you need more. Now today, I will focus on how to accurately assess the brain. I will do it more basically by looking at the BBD, and let us keep in mind 5 things. These 5 things will include: the first approach is to look at the size and the shape of the head, then to look at the lateral ventricles, to look at the cerebellum, the cavum septi pellucid, and the cortex. And when we have done all these, I'm sure you are then expert. Then you can go the step further into neurosonography. So first of all, head shape, contour, and size. Of course, you need to do measurements, but I would recommend you to have a first look, your first impression, the first glance. And this is here, the first is the shape of the head, should be like an egg, and this is the normal shape. And here in conditions where you may have a short head, like trisomy 21 or holoprosencephaly, you will see it because the head is more circular and not like an egg shape. And in cases you want to focus on measurement, you will see that the relationship of the BPD to FOD is then shifted, and it's less than the number you know. And this is here is like a tennis ball instead of an egg. And look at now, this is a fetus, unfortunately referred after having had a normal first semester scan with an holoprosencephaly seen. It is a semilobar, so you see the posterior aspect is normal, but the anterior aspect have shown here that a fusion of the two hemisphere without a separation and with an absence of the CSP. The referral was CSP is not seen, and it was an lobar, semilobar holoprosencephaly in this case. You see the shape of the head is abnormal. And another condition where you have the shape is abnormal and the contour may be abnormal are these 3 conditions. So these are findings which I think are obvious. So you look at them, you see the head shape is abnormal. One looks like a banana with the frontal compression of the frontal bones. And the middle one is the craniosynostosis with the abnormal shape of the head. And you have here in the posterior aspect a gap, which is the encephalocele with some brain outside, and ventriculomegaly. Look at now this head shape. And of course, it's obvious, but not all cases will be obvious at this one. And late detection after 25 weeks will lead to the ventriculomegaly. Now, why is the scalloping of the frontal bones occurring like this one? Because of the lack of fluid, of leakage of fluid from the spinal region. You will have also an effacement of the subarachnoid space. And this is why the head cannot continue its nice form of an egg, and this is why it is collapsing in the anterior part. So this can start to be apparent seen at 16, 17 weeks of gestation. Now, the interrupted contour may be obvious like this one, but sometimes it's not so obvious. So you need to look at out of the box, out of the head, to see if there is a contour like this one, and especially if you have an abnormal shape of the head. So go ahead and have a look to an interruption like in this posterior encephalocele. But the encephalocele can be also anterior. This is the recent case we had this summer. You see the head shape is abnormal, but you see here the anterior aspect is showing a kind of cephalocele, and you see here the profile of the fetus shows this entity. It had in addition later on a microcephaly in addition to a short corpus callosum. Genetic has not shown any abnormality, unfortunately, but termination had been achieved. Look at now this head. This is an abnormal shape of the head. It is craniosynostosis. But what you observe here, if it's not yet so severe, is the typical shadowing. If you look at the head like this, there is the anterior aspect is always in the shadow here. You cannot really clearly see at the CSP because it's always behind the shadow. The shadow is due to the fusion of the suture here, and you hardly are able to see anything in the brain. And if you have some shadowing in the brain, think always on the possibility of having craniosynostosis. Now we come to the measurements, and you measure, and you have the impression the head is small. It could be first a wrong date. So you compare with the other measurements, especially if you have an early crown rump length, or you look at the femur and so on. But the head should be according to other measurements within the normal range. If you have a small head and you have small abdomen, small femur, it may be a wrong date, or it may be a severe early case of abnormality. The two typical conditions having microcephaly are spina bifida and holoprosencephaly, because they are quite common. Other conditions with a true microcephaly are really rare, especially at mid-trimester, as Ashok said before. But it can be also an early development of abnormality in combination with the CMV infection. But in general, you have more than a simply abnormal size. You have here like abnormal shape of the cortex. You have some ventriculitis signs as these lines here, like cysts. And you may have a small brain with a large pericerebral fluid in some genetic conditions. But be careful in cases of genetic microcephaly are quite rare in general. Now you see this is a case here with where it was associated with a CMV infection, and you see there is a cyst and there is a flat and abnormal head and abnormal brain inside. Now, it can also be rarely a macrocephaly, a large head. The large head can also be due to a wrong date, but often you will look at the parents and you see one of them, in general, the father may have a large head. So I will have always a look. In general, it can be a boy and the father has also a large head. It can fit. And I will write in my report and they will tell you, yes, when I was born, I had a large head, or they know this because for years they have always been, as children, known to be large-headed. But it can also be due to what is the parents are afraid about, to hydrocephaly. You should tell them the head is large, but I see inside the brain there is no fluid. Unless you see the fluid, then you are not related to measure the head size because you see already the fluid. But there are some syndromic conditions where the head can be large, and there is a short list of syndromes, like even this one here. This was an hemimegalencephaly. You see this, the line dividing the brain is shifted, and you see this is a here fetus with a Costello syndrome, erasopathy. And what was the reason for referral was a large head and polyhydramnios, and it was really a large baby. And the termination occurred a week later with a 1 kilo weight at 24-25 week gestation. So you see, but you see the head size is already abnormal, even if the intracerebral structure were here normal. But you see the shape is also some change. So macrocephaly is rather family history, but it can be due to some few diseases related to large head size. Now we come, after the rapid measurement and the general overview, to the target examination of 4 different structures. These are the 2, 3, 4, and 5 of your hand. 2 is the lateral ventricles in cyan color. 3 is going to be the cerebellum with the cisterna magna. 4 is going to be the CSP assessment, and 5 is going to be the cortex. So let's start now with the lateral ventricles. Here, the main aim is to check for ventriculomegaly. You know that we have in the brain the lateral ventricles, the third ventricle, and the fourth ventricle. But when we say ventriculomegaly, we are dealing mainly with the posterior aspect, with the posterior horn of the lateral ventricles. It should be measured at the level of the sulcus parieto-occipitalis, and the rule of thumb is how you put the dots here, and it should be less than 10 millimeters. So you see here, this is the plane, and then in cases you have more than 10 millimeters, you will call it ventriculomegaly. It can be moderate, between the region of 10 to 15, and it can be severe if it's more than 15 millimeters. We don't really use the word hydrocephaly unless you have a severe ventriculomegaly in addition to the macrocephaly and to the effacement of the pericerebral phase. But in general, I prefer to use ventriculomegaly because it's more a quantitative description as an entity, because hydrocephaly is not one disease, it's a group of diseases. So this is why, keep in mind, this could be the first hint to seek for additional anomalies. The expert will see, when they look at the brain this way, they will see that it is a symptom, and they will see from these images roughly a possible diagnosis. Even if you cannot, only in this one you can see diagnosis. This is why your workout is then to go and to check, for example, the posterior fossa, to do neurosonography, to check transvaginal ultrasound, to use 3D, to combine with some invasive or genetic tests like infection diseases, MR, and then go and check the different conditions typically associated with ventriculomegaly, from spina bifida to Agen's corpus callosum till other rare conditions like with schizencephaly or L1 scan. So let's see here now a nice scheme from an article by Kusi and co-workers. I like it in a way because it gives us a good overview, even if there are many mistakes in this scheme. Look, for example, this arrows shows the lateral aperture, which is not, it is the pons and not the lateral aperture, and there are other diseases, so forget it. But I think it shows us following, that you can understand what is the reason, the different etiologies of hydrocephaly. It can be, or ventriculomegaly, it can be more production of cerebrospinal fluid, like we see it in infection, or hemorrhage is, let's say, stimulating the choroid plexus, it produces more fluid. Or it can be dysfunctional production, like we see in ependymal, in cilia diseases, or ependymal, let's say, granulations, what we have as abnormalities of cortical development. It can be, the main reason I think is one of the most common conditions could be an obstruction of CSF flow, typically at the region of the aqueduct here, because it's one of the narrow regions, and this can be due to some infections or abnormal genetic diseases, or in hemorrhage. Obstruction in this narrow region leads to ventriculomegaly with the triventricular aspect. So, and the fossa anomalies can lead also to obstruction here, as you know, in Dandy Walker and in spina bifida. And it can also be obstruction flow at the level of the foramen of Monro, sometimes associated with the unilateral ventriculomegaly, and it can be other conditions. So in other words, you know, the turnover of the CSF can lead to the different reasons of ventriculomegaly. Now we see here ventriculomegaly in spina bifida is due to an obstruction of the posterior fossa, an obstruction of the aqueduct, leading to this dilation of the ventricular system. And this is why you seek for the posterior fossa and look at this, the direct spine lesion. And here in toxoplasmosis, for example, this was also due to the affection of the region of the aqueduct of Sylvius. How do I know that it is toxoplasmosis? Because in general, they should have a little bit more. This fetus had a week later ascites, the placenta was taken, and looking transvaginal to this brain showed me that there are here some brain lesions, which are the abscesses. You see these echogenicities. The referral was the doctor was not able to see the corpus callosum, and it was assumed to be corpus callosum agenesis, but let's say the picture of the placenta and the less amniotic fluid and these lesions in the brain were typical for toxoplasmosis. I took the probe, I did amniocentesis. A week later, it had ascites, so we have enough data to show that this is the diagnosis. The typical picture of obstruction of an aqueduct stenosis is what is called the triventricular ventriculomegaly, which means the two lateral ventricles in addition to the dilated third ventricle. What you see here is also that the two foramina of Monro are dilated and open, so you have a communication between the lateral ventricles and the third ventricle, which is dilated. And you see here in this video, you see that there is a communication, and then later on the middle line is torn, and then there is the coral plexus from one side going to the other side. What I will do in these cases, I will try to see if what is the region of the this is the third ventricle dilated, if I can see any aqueduct, but it is compressed, and this typical aqueduct stenosis. The aqueduct stenosis is a mechanism, but the reasons leading to aqueduct stenosis are sometimes known, sometimes unknown. One of these can be this condition called rhombencephalonkinepsis. In the past, we assumed it could be cerebellar hypoplasia, but the typical shape now we know the disease very well is rhombencephalosynapsis. And what you see here is a very small cerebellum without a vermis, with a fusion of the two hemispheres. And these are often associated with let's say, obstruction, 80-90% of the cases of the fourth ventricle. It is sometimes not only fusion of the rhombencephalon, but also of a diencephalon. And the French group call it also a combination of rhombencephalo and diencephalosynapsis, often with a severe ventriculomegaly. Now let's move to the third part, which is the cerebellum and the posterior fossa. In this group, interestingly, what you'll have is to evaluate the cerebellum and the fluid around the cerebellum. And the rule of thumb says that the fluid should be more than 2 millimeters, but less than 10 millimeters, to have neither the Lemon sign nor the Walker variant group. And we assess both the hemispheres, left and right, and the vermis. We do it first in an axial view, and we measure the size of the cerebellum. And in this case, you see the typical view of a transvaginal examination of a spina bifida with the compression, with the Chiari-2 shape of the cerebellum called banana sign. I would recommend you to go for 3 evaluation ways. Since these were described by Laurent Guibault from France, I give them the color blue, white, and red. The first one is to look at the abnormal cerebral anatomy. The second is to look at the degrees biometry. And the third is to assess when there's more fluid in the brain. So abnormal cerebral anatomy means you look at the shape of the cerebellum and it looks abnormal. So this one is the Chiari-2 malformation. This one is the rhombencephalosynapsis. And this one is a focal hypoplasia of one side of the cerebellum. It can be isolated, can be due to vascular lesions, as we know in faces syndrome. This one is a disease biometry by, let's say, apparently normal shape of the cerebellum. You see the cerebellum, you measure it's by far lower than its size. The hypoplasia is in general genetic disease. The PCH is the abbreviation of pontocerebellar hypoplasia. There are different genes responsible for the PCH on one hand, but on the other, it can be also due to other extracerebral diseases like the Cri-du-Chat syndrome, the 5p minus, or also in Charge syndrome, you may have some abnormalities of the cerebellum. So it's not always the PCH in terms of recurrence of autosomal recessive disease associated. Then we come to the next group, the red. The red is the increased fluid. And the increased fluids, there are 5 groups. Here I have 4 of these. One is, which is not shown here, it can be a cyst in the posterior fossa. The second is a megacisterna magna. What you see here is the normal cerebellum apparent, and you see here the fourth ventricle is not communicating with the posterior fossa, while the other 3, like Blake's pouches, you have a communication between the fourth ventricle and the cisterna magna. The Joubert syndrome or Vermian hypoplasia partial can be look like this one, like a V shape, and not like an hourglass shape, and then you walk over and have a severe dilation of the posterior fossa. What is known here is in the past, it used to be called Dandy Walker variant. We abandoned this term and we call it today abnormal posterior fossa fluid, and then you get a sagittal view, because by changing the approach to look at the posterior fossa, you will see what is the involvement of three parts. What is the role of the vermis, what is the role of the fluid with the tentorium, and what is the role of the choral plexus of the fourth ventricle. And this is megacisterna magna. You see the cerebellum, and you see the fascidium, and the choral plexus is here touching this approach here. In this way, you'll have a kind of the Blake's pouches. You have a slightly expansion of the Blake's pouch and a kind of cranial or superior rotation of the otherwise normal vermis. So in other words, well, the difference between these two is there's still a communication here, and this is the persistence of the Blake's pouch. If there is an opening later on of the foramina of Luschke, the lateral size, then it will be emptying this, and this can occur after 25-week gestation, and then it can resolve. This one, however, you see there is an abnormality of the cerebellar vermis. There is half of the vermis is missing, and you don't see it here very well. And in this case here, you have an abnormality severely similar to this one, but in addition, you have an elevation of the tentorium, as we discussed before in the Walker malformation. In other words, the suspicion is quite easy in the axial view, but you need to perform a neurosonogram to have the view to these images here. And you see this is an example of a dilated fossa in megacisterna magna. You see the difference between the fourth ventricle with the fascidium and the cisterna. Here you have the continuum. You see the cerebellar vermis looks fine, and you have a continuum between the fourth ventricle and the Blake's pouch cyst, as seen is in this case. And you need to see it in this plane, otherwise you cannot appreciate the size of the vermis. And what you can do here is, in this case, it is a Blake's pouch as well. You see like a fluid connection between the fourth ventricle and the cisterna. By presenting this way, you will see properly the communication and these typical Blake's pouches. The rule of thumb, as you know from also from the book of Prashant, roughly speaking, the height of the vermis is half the diameter of the cerebellum. So when you measure the cerebellum of 23 weeks gestation, it was in that case 26 or 25, then you have half of it should be at least the height of the vermis. So if you have less, then I will refer to true curves if needed. So this is roughly a view to look at the posterior fossa and the vermis. Now, vermi hypoplasia, you see here, it is a part of the vermis is missing, but the tentorium is still low. And this typical picture of Dandy Walker malformation, where you have, in addition to a partial or complete vermiagenesis, a high tentorium cerebelli, typical additional hint for Dandy Walker classification. Here we have a recent case, and you see here a huge fluid in the fossa with an elevation of the tentorium. Now we come to the fourth group, which is the cavum septi pellucidi. The cavum septi, what we have here is the assessment of the anterior aspect of the brain with the fluid in the cavum and with the two anterior horns. And what you see here, which is not very well appreciated, is the genu of the corpus callosum with the two interhemispheric fissure with the falx. So under normal conditions, you may see this. And when you have an absent of the CSP, you should think of the presence of an agenesis of corpus callosum. So this is an entity which is very, very, very important to detect. It's, in my experience nowadays, more common than a spina bifida. So we see more cases of ACC. What we'll have here is it seems to be 1 to 1,000 cases. It has many syndromes. Some of these can be isolated. In isolated cases, the prognosis can be good, provided there are no extracerebral anomalies and no normal genetic workup. And in order to detect the agenesis corpus callosum, we rely on different signs. We have 7 indirect signs and 1 direct sign. The 1 direct sign means there is no corpus callosum in the mid-sagittal view, but it's difficult to seek for something which is absent. This is why we are relying on the indirect signs. The indirect signs are following. Some of these will be detected in the BPD plane, and some will be confirmed with coronal and sagittal views. So let us go through the different signs. Sign 1 is the absence of the CSP. The CSP present in the anterior aspect is not seen here, and so you have these 2 images, the absence of the cavum septi pellucidi. The sign 2 and 3 are the compressed anterior horns and the lateralized horns here, and the number 3, because of this compression anterior but not in posterior part, you have a dilation of the posterior aspect and the compression of the anterior form leading to the shape as a tear drop ventricle shape, or called colpocephaly. So the reason of the compression here is the nerves, the neurons from one side to the brain, they want to go to cross the midline. Since they cannot cross the midline, they will go and accumulate here, going to the posterior aspect of the brain. And these huge bundles here lead to this compression of the anterior horns, and these are called the Probst bundles. This is why it is the typical picture of an Agen's corpus callosum. Now look at the next sign. The next sign is the interhemispheric fissure. It seems, which is dilated, it seems that this may be due to the, let's say, the 2 hemispheres are falling apart in the head, because there is no corpus callosum holding both together. This leads to this dilation, and then you see many lines. In general, when you count them, you will see 7 lines. The 2 on each part are the compressed anterior horns, and then you have already 4, and you have the phalanx cerebri and the medial aspect of the hemisphere of the brain, and you have 7 lines. So when you see too many lines, think of the possible presence of Agen's corpus callosum. In my experience, I think it's even easier to teach than the absence of the CSP. Why? Look at this condition here. You may see a fluid here. If you have no experience, you think, oh, I see a CSP. This is not a CSP because it is in the center of the brain and not its anterior third. It is not surrounded by the 2 lateral ventricles. It is found between the 2 thalami. And this is here how it can be seen. In the upper part, you have the many lines. In the lower part, you have the cranially and dilated third ventricle, as you see in these images. So let's have a look now to a video of these different signs. We see here the dilated ventricle. We see the colpocephaly, and looking back to the upper part, as you have seen just now, the many lines here. These are the many lines. This here is the absence of the cavum septi pellucidi in the center of the brain, dilated third ventricle and cranially shifted, and the tear horns, the teardrop shape of the lateral ventricle. Now we move to the 6th sign, which is a transvaginal, or you can do transabdominal, but better transvaginal frontal view of the brain. What you see under normal conditions, you see, as you remember in my beginning of my talk, in the frontal view, you have the corpus callosum here, like an anchor. We have the CSP, and with the 2 fluid in the frontal horns. What you see here in the Agen's corpus callosum is what is called the steer horn sign. The steer horn means these are, on one hand, the compressed lateral ventricle's horn, on the other, the cranially shifted a third ventricle with an absence of any anechogenic structure like the corpus callosum, which is seen here or seen here. So you see, this is the corpus callosum here, and there is no corpus callosum here, neither there. So again, here nochmal another case. Now the 7th sign is the absence of the corpus callosum. This is why you may see it directly because there is no corpus callosum, or indirectly by using color Doppler, and you see the anterior cerebral artery having an abnormal course. And we just submitted the paper to publication on how to assess the vessels here and how to perform measurements. I hope when it will be accepted, I can show you more details on that. So they have now different signs. I hope it is now not so difficult to make the diagnosis of ACC because we have 7 different signs we can use. Now, an abnormal CSP, in addition to the agenous corpus callosum, can be present in holoprosencephaly. I showed you the case where the main suspicion at the referral doctor was the absence of the CSP. The CSP can have no lamina left and right, so no border, and this is then called agenesis of the septum pellucidum, because after birth there is no septum. It is a communication of the two anterior horns, because the communication here, the separation is absent. This can be as an accidental finding in some diseases. It can be sign of, rarely, luckily, of septo-optic dysplasia, but it can be secondary, as I showed before, in the case of dilation of the ventricle, either in the combination with the aqueductal stenosis of different origins. Rarely, you may have a condition where there is no fluid in the cavum, so you see a septum pellucidum, but no fluid inside. After birth, it appears like a normal case, but here I will focus more on the presence of a normal corpus callosum and normal gyration of the brain. And in this case, here you have the presence of the CSP, but the shape is quite abnormal. It is more short and wide instead of different. So you see here, this is case where you have a agenesis of a septum pellucidum, and you see that there are no lamina. This is not the same like agenesis of the cavum septi pellucidum. You have here a agenesis or absence or the torn of the lamina of the septum pellucidum. And we finish with the cortex. With the cortex here is until now not very often evaluated. And what you can see here are conditions where the cortex is affected. And in this case, you see the echogenicity typical for an hemorrhage. In this case, you see that the cortex is quite thin and the pericerebral fluid enlarged, typical for brain atrophy. In that case, it was secondary after a laser of a twin-twin transfusion with let's say, some demise of the other twin. And here you have the condition of schizencephaly. They 90% of the cases have no cavum septi pellucidum seen, and here hemimegalencephaly and abnormal brain tissue left and right. So this abnormality of the cortex may be obvious to me and to all of you, should be. But what we want to learn today are the diseases called malformation of cortical development. And I cannot expand on this because this is, let's say, a long talk, could be a long talk, but I want you to learn how to assess the proper development of the fissures here. And look at now, between 17 and 33 weeks, you have the development of gyration like seen in the brain here. And the easiest way to assess this is to focus on the sylvian fissure. You see 17, 19 weeks, it is flat and start to form, and then here, then it's closed by this opercula forming of the insula or the sylvian fissure. How is the best way to assess this? The rule of thumb I would recommend you to do is following. If the head is BPD 6 centimeters and less, or before 24 weeks gestation, the sylvian fissure shape should be open like this one. So the angle is either open or square shape. But after 24 weeks, we start to have the two lobes, the temporal and the frontal lobe, are getting here, covering the insula. And this is what is called operculization, which means the covering of the insula. This leads later on to a complete covering. So in other words, if you see after 24 weeks, picture like this one is abnormal. If you see at this age a very flat sylvian fissure, this is suspicious. So keep in mind, these are the two let's say the simple hints. If you need more, you refer to the papers. There are enough papers written on the different aspects on how the single fissures appear. So this is here a case, 26-week gestation, a flat one, and you have other lesions here in the brain and the cortex, like in tuberous sclerosis. So this is typically abnormal. And look at now this brain, 22 weeks gestation. It was too flat for me. I called back 26 gestation, too flat here. MR confirmed the finding. In comparison here, this is a normal brain at this age, and this is how it should have looked at after 24-week gestation. So this is a lissencephaly, which means a lean brain. Look at now, this here is the lissencephaly, which is the LIS1 mutation. Miller-Decker is the diagnosis when there is a deletion on the chromosome 17, and you have a smooth Sylvian fissure here, this 27-week gestation. You have echogenicity, you have abnormal the color in the cortex should be gray, and we don't have any fissure here. The main diagnosis would have been seen by ventriculomegaly and the dilation of the third ventricle, but here you see that the cortex is also abnormal. And I hope in future we will learn more and more on how to evaluate the cortex on a routine basis. In general, it's not part of the typical routine, but I want you to encourage you to do this. Now, this is the normal brain. I will, at the end, I would have wished to finish with you by discussing a lot on other features like the intracerebral cystic lesions here. They can be at different places. They can be in the posterior fossa. They can be inside the brain between the different hemispheres. And they are classified actually according to their position. There are three general groups. One is within the brain parenchyma, intraparenchymatous. The other one is in the ventricular, and the third one is called the extra axial, which means within the head, within the brain, but outside. Sorry, within the skull, but outside of the brain. These are the one, for example, present in between the hemispheres as interhemispheric cyst. And the rule of thumb: keep in mind the size does not always predict outcome. If you have such a condition like this one, this was an arachnoid cyst, are the most common one present interhemispheric. This one was supracellular, so it means in the cella turcica, it means very large, but the baby did well after postnatal surgery, after the drainage of the cyst. However, this one, for example, are cysts within the parenchyma. These are cell destruction. This is leukomalacia in a co-twin after the fetal death of the other twin. And this small size may have bad outcome, while this large size may have good outcomes. This is why be careful. The size does not always matter. It's not always related to these to outcome. So, and this is a recent case I saw at a meeting. You scan the head, you see a small cyst. In general, this cyst is typically the location of where you may find 22 weeks caving belly interpositivity, but be careful even so early. If you add color, you may discover a vein of Galen malformation. We were taught it is a third trimester diagnosis because in the past, the image resolution was not so good and we're not able to see simply these small cysts, and we're not using routinely color Doppler, and the heart is not yet enlarged. These typical sequelae of this disease may be seen later, but if you are focusing on the brain, you may see this. If you are using routine color Doppler, you'll discover this one, and then you turn the baby, you get a sagittal view, and then you can demonstrate with 3D the typical dilation of the vessels by transabdominal approach at 22-week gestation with this dilation of the vein of Galen here with the dilated posterior aspect. So I will close now my talk by summarizing again. I showed you today the 5 tricks you have to keep in mind: the head shape biometry at beginning, then look at the lateral ventricles, look at the cerebellum, the cerebellum magna, look at the CSP with the presence, absence, or abnormal shape, and don't forget to focus also to learn how to assess the cortex. If you need only one thing, it should be the Sylvian fissure, because it's the key to make the diagnosis of lissencephaly and abnormal brain development. If you want to have more information, then you will go and scan vaginally, because then you will have all other diseases seen in the target field neurosonography, as you have seen here, some with the thickened cortex lissencephaly, with these with the cysts in the leukomalacia, or with the abnormal gyration and abnormal shape of the brain, and so on. If you want to read more, of course, you can refer to the nice book of Ramamurthy, but if you want to be more actual, up to date, there is a new edition of the Timothy Rich book called The Timor's Brain, published by Malinger and Dario Palladini and other speakers, and it's going to come February 23. I just have my own copy. I'll show you. This is here. Very nice book, warmly recommended. And if you want to hear more on these topics, please join me. I just invited many speakers to participate to a one-day course on fetal neurosonography, including Azumendi, Rowe Birnbaum, Palladini, Rizzo Koppu, Svi Leibovitz, and who else? Asma Khalil, myself, Simon Marr, Bernard Benoit, so all the creme de la creme, speaking on 7 weeks embryo to term, on all possible new signs of the brain anomalies. So join me for this one-day course of 11 of March, and you can, if you cannot attend, you can have recorded access for 31 days. And I finished my talk by saying thank you very much, and if you have questions, I'm really happy to answer them. Thank you.
Thank you, Ravi, for excellent presentation, and I hope everyone will join you for that neurology course. And any further questions right now? Let me see the chat box if I can find some question.
I answered all questions. Come on.
Yeah, counseling in partial absent corpus callosum.
In partial and complete are the same. Partial even worse, actually. In the past, we used to say, luckily there are some fibers going on, but the complete could be one event, but the partial can be more genetic. And this is why, but let's say the question should be different. What are you doing with? We'll put the book to elevate my, so I will do it this way. My approach to agenesis corpus callosum. I see this, I tell the patient, there is a structure which is called the corpus callosum, which is not properly present. I would recommend to do the following. We do invasive procedure. We'll go for trioexome. Unless you have 3-4 additional signs, it can be trisomy 18. But let's consider the one you see nothing else. And I would recommend to have 2 weeks later an MR, because for the exome we'll need 3 weeks. And then we bring all things together. I sit with them, discuss with them. We have normal exome, we have MR not showing additional signs. So it is very likely that the child has an isolated agenesis corpus callosum, which means in 70 to 85% of the cases may be well developing later on in life with some mini handicaps which can be handled with. Next, you will go to a pediatric neuropediatrician. They will tell you the outcome, and they write the same in their offer. Some patients tell me, I don't want to have a child with neuro handicap. I said, okay, it's okay. They can terminate. But what should not be done is, if they want to terminate, they should, in my setting, tell me at the beginning and not after. After everything is done. So in other words, if they say since the beginning, I don't want to continue because of this condition, we may wait even until exome and then they can terminate, or they go directly to termination. But I will give them, trust them, the chance. What I don't want is when all the settings are normal to say, I don't like now. They should at the beginning say, if everything is normal, are you willing to continue? I had a patient called me recently, 34-week gestation. I'm wondering, is that, it's today, sorry, I gave you the offer, we discussed this, and all was normal. Why don't you give your child a chance? And we have seen, you and me and everyone, family coming back, the child is sitting on the table drawing a scheme, and he had agenesis were developing well, but they need some observation. This is what I do.
Ashok, your thought on partial agenesis in Indian circumstances?
You see, we have a huge association between intrauterine infections and partial agenesis.
Yeah.
We label as partial agenesis, but actually it's a destructive process. And therefore, I'm very scared of partial agenesis. So I try to paint a very balanced picture with not too much encouragement.
So
Yeah.
because there are quite a lot of there is a lot of support, government support
Yeah.
or a technical support as far as Western countries are concerned in Europe or UK or anywhere. In India, there are no such supports, no such organizations who are going to support these kids. And for the family, many a times it becomes a burden. So it's 1 out of 3 will have a poor neurodevelopmental delay, maybe developmental delay. So that's a problem for India. Of course, the things are going to be a little bit different.
But you know, what I'm afraid about is how safe is your diagnosis. I know that in India you scan at 19 weeks.
24.
Not anymore.
Now the things are different.
So we
You can
changed that
terminate,
for,
you
yes.
can
Okay.
terminate the pregnancy
Because,
during
you know,
24 weeks.
what I'm concerned is that what happened in Germany sometimes, they hear at a meeting that the size of the corpus callosum is roughly gestational age. They say 22 weeks, and they come at 19 weeks, they say 19 millimeter, and it's 17 millimeter. They start to say, oh, it's a short corpus callosum, it's this genetic, because they measured at 19 weeks some 17 millimeters. So this is, and this should not be the basic of discussion. And I would recommend you always, especially if you have a short, not an odd, a short, to have at least a follow-up to see if there is a growth, because we have a lot of variation.
Yes.
Yeah. All right. It's exactly 2:25, so we are going ahead with the next talk so that we can finish everything on time. Thank you, Professor Chavi, for joining us. Thank you very much for all your phenomenal and fantabulous talks. Every time when we listen to you, there are not one or couple of things. There are at least 10 things we learn, new things. So every time, even if the same talk, if I listen again and again and again, still will have. It's like Indian music, you know. These are typical in Indian song. If you hear that for 100 times, maybe 25 years old song, still you learn a lot of new things from that music or from that part of the song. It's exactly the same way your talks are. Very lucid, phenomenally. I mean, you can make the difference. It's something really.
No, thank you. But you know what for me is when you are a young teacher, you think you open a book, you read there, and you can tell. But later on, when you have life experience, in each comment I'm giving, I'm putting a recent experience of what I had. So, you know, and when you have some, let's say, some experience in a recent case, you will put this case in your talk. Say, next time I will say this and I will say that, because to avoid a mistake I did. So, and this is how I learn from my talks. You will not believe, but I learn when I prepare a new talk. It's a challenge for me too. And I learn a lot when I listen to other people speaking like you. So when I was listening to Ashok, I said, okay, this is an interesting way. This is another approach to teach. And let's say the best way of teach is not yet there. So I'm still working on getting even better. So this is a challenge.
So
okay, guys, I will be in the background and listen to you. And
thank you.
If I disappear, goodbye. And Ashok, I send you the email. You change that. You send me a next version of the 3D program, please.
Yes, of course. We certainly will. Yes.
So good luck, and thank you again, Prashant, and congratulations for this nice meeting.
Thank you very much. And today, what I'm going to discuss is about the fetal heart and fetal autopsy specimens. Lot of fetal autopsy specimens, and through that, learning the fetal echocardiography. That's what I'll be doing. So next talk is again about what I'm going to speak is on the fetal echocardiography. What at least you should understand or you should know about the fetal echocardiography. Hope can you see my screen?
Yes, we can see your screen. And,
okay.
We can hear you.
Also, your telephone number.
Oh, thank you.
and bank account as well.
I will share, no problem. So, fetal echo, what you need to know at least. What Professor Ravi has told you, what at least you should know about the fetal brain. What I'm going to discuss, what at least you should know about the fetal heart when you are scanning a fetal heart. I have three gurus as far as fetal heart is concerned. Of course, Kipros is there to push me in 2002 that, okay, this is something, a new world. of fetal medicine or fetal scanning. And there are two good friends and two gurus, Ravi and Alfred. And they have written a Bible on fetal echocardiography, that is a practical guide to fetal echocardiography, normal and abnormal heart, Alfred and Ravi Chavi. Thank you. This is a photograph, a lifetime photograph in Berlin Congress. So now you can have, if you work on fetal heart, you can have, or you can reproduce the images like diastole of fourth chamber. You can have an interventricular septum, two chambers which are filled, or a pulmonary outflow and aortic outflows and whatnot. But before going to that, you need to learn the art of heart. So that art of heart, when you want to learn, there are things you need to remember, that there is a similarity between driving a car and doing the fetal echo. Why I'm saying this is because you have to follow the rules, take some precautions, use the gadgets to its optimum best. And if you don't know, don't try, you will end up in a disaster. So follow the rules, take precautions, and use the gadgets to its optimum best. That if you follow these three things, then you can learn. If you don't want to learn, then you are going to end up in a disaster. So I wish that you learn. To learn in fetal echocardiography, first thing is you should learn what real anatomy you are looking at, because this heart is a three-dimensional structure which changes with every few millimeters. Your left side of the screen, this is where I have opened the thorax and removed the thymus. You see that this is the right side, this is the right ventricle, a main pulmonary artery, it arises. On the left-hand side, you have got a left ventricle, this is the left atria, aortic arch arises, then it gives rise to three branches and it opens up. If I just remove the entire fetal thorax with keeping the thymus here, then you have to see the video on the right hand side. So the whole bunch of the structure is thymus. So once I lift the thymus, what happens? Then you really come across the structures of the fetal heart. This is the right ventricle. Here the main pulmonary artery, this is the ductus arteriosus, after it gives rise to two pulmonary artery branches. Left ventricle, this is one coronary artery. Arch of aorta, this is the arch of aorta. Ascending aorta gives rise to three branches. And this is the vagus nerve. When you still make the picture very clear, and the most important part, if you really look for this, is ductus arteriosus. After the third branch of the arch of aorta, the descending portion, this portion is known as aortic isthmus. And when they joins together, this section, this is the typical section when you look for the tracheal V. So this is the tracheal V, three vessel trachea view. This is the section where you are interested in looking at the junction of the ductus arteriosus and aortic isthmus. So that is what the real anatomy is. And when you are interested in looking at this anatomy in a 2D, you may have 3D, you may utilize a color Doppler, you may utilize power Doppler, you may use slow flow depending upon the organ or the vessel you are interested. Now, there is a difference between what Professor Ravi has taken the lecture on neurosonogram and the fetal heart. The brain changes its anatomy. At 12 week it is different. You may not see the cerebral. You may be seeing cerebellar hemisphere, but vermis may be difficult. You may not see the corpus callosum. But at 22, 24 week, you will see everything like what we are used to see at for the fetal brain. The heart has similar structures, whether it is at you are looking at 38 week, 24 week, 20 week, 18 week, or at 12 week. Only thing is the organs are smaller and smaller. Now with a better resolution of the ultrasound machine, now those smaller structures now you can reproduce on the screen, and you can also reproduce a slower or a smaller vessels by using a slow flow technique, and that makes your ultrasound evaluation of the fetal heart shifting from late gestation from 24 week to maybe 14 week, 13 week, or even 12 week, so that you can evaluate a lot many things like that. Look at this video and below. You have got interventricular septum, chambers, atria. You can see the crossing of the heart. Now you have got a pulmonary artery bifurcation. You can see the three vessel, and you can see the three vessel trachea view, the brachiocephalic vein and everything. Now this is a typical what we have learned to see on a second trimester. But look at the heart. This is at 13-week 5 days, so it's practically 14 weeks. Just look at this umbilical. You have got umbilical vein. You have got an hepatic vein which is seen. The moment you take it forward, you have got a four chamber view. You can see interventricular septum, which is really good. You can see the pulmonary vessels which are really you can reproduce. Then you can have three vessel trachea view. Still you go up. You can have a brachiocephalic vein, you can see, and you can also look for the aberrant right subclavian artery. So it's not only about the size now, it's all about the resolution. And the thing is, it's a smaller organ, moving organ, that makes examination a little bit difficult. But still now you can see, because of the recent advances in the fetal ultrasound or the machine technology, the AIUM guidelines, which is more extensive than ESWOG guidelines, and I think this gives you far more information about published by AIUM in 2019, the all phenomenal views which are available, and you need to evaluate them. What we at Paras protocol, we evaluate a dozen of a section and a dozen of a structure. That's how we always take it across. There are right and left side structures, 2 atria, 2 ventricle, and 2 major vessel, pulmonary artery and aorta. And there are 6 connections, 2 on each side, 3 on each side, atrioventricular, ventriculo-arterial, and veno-atrial. So you have got these 12 structures if I take, and 12 sections like AC, 4 chamber, crossing of pulmonary artery and aorta, 3 vessel trachea view, highest point of arch with brachiocephalic, aberrant right subclavian, RVOT, LVOT, aortic arch, ductal arch, and azygous arch. The moment you look for this, your fetal evaluation is all right. As far as cardiac screening is concerned, it starts with abdominal circumference. It goes to 4 chamber, then it goes to 3 vessel view with a bifurcation of pulmonary artery, and eventually you will have a tracheal V formation where you see along with the RVOT and LVOT. But as I feel, when you are learning on fetal cardiography, or when you want to embark upon doing a fetal scanning, at least these 3 sections will take off more than 75% of the cardiac malformations. If you are really good at abdominal circumference, if you are good at 4 chamber view and evaluation of all 12 points, which I'll discuss, and 12 points of outrotrax, then you will be able to detect more than 70% of the cardiac problems. Unfortunately, in USA still they are struggling at around 45 to 50% of the cardiac disease diagnosis with them, because there are sonologists who are working there. Here we as a consultant always do the scan. Still there is no concept of sonologists or echocardiographers were doing an echo. So by cardiac screening, my aim is to detect more than 90%. So if I do good AC, 4 chamber, 3 vessel and 3 vessel trachea view, I will be quite happy that if you will be able to detect more than 90% of the cardiac defect, and that is what my aim is at the moment. This video you have already seen, so I'm not going into the outer arrangement of the 4 chamber, thymus and the 3 vessel. Let me show you the intracardiac arrangement of the fetal heart, or what real anatomy is. So if I switch on the video, this is where the fetal right side and this is the left side is. So if I freeze the image, then here there are quite a few things which I would like to put it across. That on the left hand side, left ventricle, if you really see, this is an interventricular septum. Left ventricular wall is very, very smooth. It makes the apex of the heart. Here, right side of the heart, the interventricular septum is really irregular. You have got a moderator band. So these are the 2 things. If you really look inside the heart, then it will make sense, a lot of sense about intracardiac. Now let me show what exactly I'm talking. So this is the anatomical specimen, and this is the ultrasound. Look at the smoothness of the ventricular wall, and similar kind of smoothness here on the ventricular wall. Look at the moderator band or clumsy of the echogenic structures here. That is produced because of the moderator band inside the thing. Apex again is formed by the left ventricle, and you will have the aorta, which is right kissing the spine, and left atria, which is also going to kissing the aorta. We will discuss this when we are discussing the area behind the heart. But I want you to learn when you are learning with autopsy specimens, your correlation of the fetal ultrasound is going to be far more simpler. One of the most important point is whenever you are doing a scan or doing a fetal echo, it is mandatory to identify the fetal left and fetal right side. So there are two ways usually is for the situs orientation. One is drawing a doll on your hand. Because I'm doing scan from my right hand, I'll draw a doll on my left hand, just like this. This is the head. This is the thumb, and this I have drawn a baby. For this baby, the thumb becomes right side. So I'll just put my hand on the mother's tummy to identify if it is vertex, right occipital anterior is like this, left occipital anterior, bridge, transverse, whatever way I'll put it this across and identify whichever fetal left or fetal right side is. And another approach is clockwise for cephalic, anti-clockwise by bridge like spine, stomach, and portal vein. But there are a few difficulties when you are coming across to an oblique lie or some kind of lie. I find it simple. If you find clockwise, anti-clockwise simpler, you can utilize that. But identify fetal left and fetal right side. It is not heart is on the left hand side, stomach is on left hand side. Identify fetal left side and fetal right side. Then decide that okay, this side is up near the probe is fetal left side, or away from the probe is fetal left side. Then look at on abdominal circumference whether the stomach is on left side or stomach is on right side. Because in situs inversus totalis, everything is going to be on same side, but the heart, stomach, and the tracheal V pointing towards the right side. That's a total in totalis. So you will never diagnose situs inversus totalis if you don't follow this. It is easy to identify the discrepancy between the presence of a stomach shadow on apex of the heart. If they are on different side, then you start thinking whether it's a dextrocardia or is it a situs abdominis, situs inversus abdominalis. So you will think in a line when they are at a different positions, but when they are on the same side, because the situs inversus, you have to do an invasive testing to identify the ciliopathy. If there are no ciliopathy, then outcome can be good. So you need to identify the fetal right and fetal left side. Simplest point. Now, once you are at a 4-chamber view in the thorax, identify the cardiac axis. Draw a line from spine to the sternum and a line on interventricular septum. This axis has to be 45 degree plus or minus 10. It's like whenever you have got a watch, if at all you have got a watch or you are wearing, it's like a 5 o'clock. So that is how your apex of the heart or a cardiac axis is going to be. So whichever way, whether it is spine apical 4-chamber view or basal 4-chamber view, anywhere, the rule of 5 it never changes. So the moment you have got, because anything, whether those both are at 4 o'clock, that is a left axis deviation. At 6 o'clock, that is a mesocardia or right axis deviation, that you will come to know instantly, and you have to do a detailed scanning. If you have got a left axis deviation or a right axis deviation or mesocardia, any abnormal axis, you need to have far more detailed evaluation. From axis, let us go to the cardiac position. Same way, draw the line and divide your thorax into 2 portions, right and left side. The 1/3 of the heart is going to be on right side and 2/3 should be on the left hand side. In case if it is positioned on the right hand side, axis is maintained, you may have push phenomena if there is a right lung hypoplasia because of the many reasons of Shimitar syndrome or right lung hypoplasia, the entire heart will shift on one side. Or maybe because of the push phenomena, if there's a left diaphragmatic hernia, the stomach will go up, it's going to push the heart on the right hand side, and you will have change in the cardiac position. So that will give you idea about the cardiac position. Then again, one rule of 1/3, 1/3, 1/3 is the entire cardiac is going to occupy 1/3 of the total thorax. So again, a rule of 1/3 is applied here and looking for the cardiac size. The moment cardiac size is increased, there are what we typically take as in cardiothoracic ratio, and any cardiothoracic ratio which is more than 0.6 is always going to be abnormal. We have again come out with one of the thumb rule is cardiac circumference. If the cardiac circumference is 5 times then the gestational age in millimeter, that is definitely abnormal. And there is one more measurement that the moment you draw a line between the two valves, AV valves, if this is more than 1/10 of the gestational age, if you are evaluating with 30 weeks, if it is more than 33 millimeter, you are dealing with cardiomegaly. So cardiomegaly or a cardiac circumference 5 times the gestational age, there are quite a lot of simple rules. If you remember, you will be able to diagnose those anomalies, which at a go on a screen, just one 4-chamber view will give you idea about the abnormal cardiothoracic ratio. It may be altered in case of skeletal dysplasia. Please remember that also. If the thorax is narrow, you will see the heart enlarged. But in fact, whenever you measure the ventricular size on the both sides, you will find it normal. The thorax size going to be smaller. So an altered cardiothoracic ratio again gives you a poor prognosis as far as pregnancy outcome is concerned. So these are the things you need to look for. Any abnormal excess, you may have a transposition of great artery or DORV or tetralogy of Fellow or common arterial trunk. You will find left axis deviation like that. So from 4-chamber view plane, this is the simplest 4-chamber view you can come across. The best part is if you are lucky to have a apical 4-chamber view, or second is a basal 4-chamber view. They are the one which are preferred. Now let us understand the basic rule of the fetal ultrasound. Whenever here the ultrasound beam is in this direction, right? So the structures which are parallel like this, they will be seen best. So whenever you have got apical 4-chamber view, what the structures which are parallel to your beam is AV valve. You can evaluate both AV valves brilliantly. The same way the pulmonary veins are also parallel, so you will be able to access the pulmonary veins very precisely. But here the issue is, because the interventricular septum is just like it is hitting just parallel to the ultrasound beam, the evaluation for a very small subtle ventricular septal defects are going to be a little bit more difficult. So what you really evaluate in your 4-chamber view plane is, let me freeze it so that we can see it by systole and by both systole and diastole. Now this is where I have freezed the image during what the AV valves are. That is, this is a typical systole. I know that we have already done with the situs orientation. I know we are done with the heart position and axis. Now coming to the opening and the closing valve, I should be able to see the 2 valves which are opening and 2 valves which are closing. So the moment I see this 2 valves opening and 2 valves are closing, I have ruled out all single valvular pathologies of the heart, like atrioventricular septal defects, single ventricle, and so many other defects. Okay, so that is one of the things. Second is 2 equal size atria and 2 equal size ventricle. Next point is, if you really measure from interventricular septum to the left, the wall, lateral wall, look, these are both are of same size. Measure from here atria to this atria, they are also of same size. So measuring atria and 2 ventricle, they are of equal size, and that is what you need to understand. Intact interventricular septum. This is the interventricular septum. which is intact, and that what I need to realize. In interventricular septum, what are the things which will be seen? We will discuss that once we discuss some kind of malformations. Now coming to one of the important point is AV valve offset. Look at the position of tricuspid valve. This is a mitral valve. This is the structure just beneath the sternum. So this is right ventricle, and right ventricle will have a tricuspid valve, and tricuspid valve is attached towards the apex. If I draw a line, and this is the mitral valve, which is going to be away from the apex, and these portion will have, instead of linear insertion, they will have one towards the apex and one away from the apex, and this is what we call it as the AV valve offset. And AV valve offset has to be there. The moment they are in the same line, you are dealing with so many of the cardiac malformations like atrioventricular septal defect and partial atrioventricular septal defect. There are inlet VSDs and whatnot. So we will be dealing with that also. One more point is pulmonary veins draining into the left atrium. This is right ventricle, this is right atria, this is left ventricle, this is the left atria. And these left atria will have opening of 2 pulmonary veins. In total, there are 4 veins, but you will be able to see 2 pulmonary veins draining straight here into the pulmonary veins. That is one of the important points. Then comes next point is going to be the rhythm. The moment I play the again clip, you have got a very normal rhythm, regular rhythm. That is what is going to be there. A pericardial effusion, fluid around the interventricular fluid around the cardiac wall and the pericardium. It has to be less than 2 millimeter. More than 4 millimeter is considered to be a pericardial effusion. 2 millimeter around the normal. That is a normal finding. That is what you need to understand. So you have, all in all, these 12 points which are supposed to be looked for: situs axis, size, 2 ventricles, 2 atria, interventricular septum, crux, 2 AV valve, and 2 pulmonary veins entering into the left atria. And one of the most important point is area behind the heart. Now, why I am saying area behind the heart? Because this is the spine, and this spine, where the aorta is just kissing the spine, and left ventricle is kissing the aorta. These three structures, they are supposed to be practically kissing to each other. When there is much more gap in this area between the left atria and aorta, there has to be one extra structure, and unless proved otherwise, this is going to be a total anomalous pulmonary venous return. Think in that line. The moment you try to think in the line, you will be able to successfully in identifying the subtle kind of cardiac malformations. And these are the 12 points: situs axis, size, 2 ventricle, 2 atria, IVS, crux, 2 AV valve, 2 pulmonary veins, rhythm, pericardial effusion, and area behind the heart. So these are the 12 points you can easily identify in one 4-chamber view plane. Take a 4-chamber view video for 3 or 4 seconds and freeze it. Then scroll back by using your roller or trackball, so that your identification of evaluation is going to be easy. It will take not more than 5 seconds or 3 seconds to grab your 4 cardiac cycles. So these are the 12 points you look for your 4-chamber view plane. So like in atria, ventricle, and interventricular septum, these are the things you should be looking for. You should be looking for in all about a 4-chamber view plane. So here you have got, in nutshell, everything. Put it forward in atrial chambers or interventricular septum and in a 4-chamber view. What you are supposed to look for. Interventricular septum. Well, now I'll show you the difference between what is the difference of interventricular septum evaluation in apical 4-chamber view and a basal 4-chamber view. Now look here, in a basal 4-chamber view, you have got far more better evaluation of or the anatomical evaluation. Like here you see the straight line kind of stuff. Look at the thickness. Look at the smoothness of the interventricular septum on the left hand side. The real anatomy is far more as comparable to this is being seen on a basal four-chamber view rather than apical four-chamber view. So whenever you are interested in looking for a small little VSDs, it is always going to be far better, and usage of color will give you a crystal clear idea that, okay, interventricular septum is intact, there are no interventricular septal defects, and that's how you will be able to assess interventricular septum. So that is where I would like to try to, because interventricular septum basically is like a wall. Whenever you have got a wall between two rooms, it's like that. Wall can have defect at any place. Like if it is at the apex, you call it as an apical VSD, muscular VSD, mid-muscular VSD. Just this is that roof. At the roof, you may have outlet VSD or perimembranous VSD. At the base, like AV valve, you will have inlet VSDs. So you may have a different ventricular septal defect at different location, but definitely it has got a different kind of ultrasound pictures, and of course different kind of genetic associations. Perimembranous and outlet may have a possible associated 2211 deletion association as compared to mid-muscular, muscular, or apical VSDs. So there are other associated malformation with inlet VSDs. Now looking at a ventricular septal defect, look at this. You have got a ventricular septal defect. You can see color going to and fro, and whenever you have got ventricular septal defect, I would like to pay your attention that these margins are going to be sharper, smoother, and that is how you will be able to identify, okay, I am dealing with ventricular septal defect, and look at a color which can go through in to and fro both direction. So that's how you identify the ventricular septal defect, and that's how you should be thinking and assessing the possible other associated defects in ventricular septal defects. Now, assessment of the crux. As I told you, the mitral valve is going to be away from the apex. Tricuspid valve is going to be towards this. Now, the things which you will be able to identify is atrioventricular septal defect. Here you see interventricular septum. Look at this interventricular septum. This is intact. This ventricular septum is intact. And here you go to the four-chamber view of the heart in ultrasound. Look at this. You have got one interventricular septum here. Look at the other interventricular septum, but these crux, which is here normal, is totally missing. When you have got crux missing, this is typically of atrioventricular septal defect. And when you have got atrioventricular septal defect, you will have a single valve. It may be associated with bradycardia or maybe without bradycardia. Color Doppler will give you one inflow, two outflow, depending upon the associated malformation, or one inflow, one outflow, depending upon how outflows are arranged. Whenever you are dealing with single AV valve or AVSD, think about trisomy 21. 50% of them will have associated trisomy 21. And these, also think about the isomerism. When you have got atrioventricular septal defect, think about atrial isomerism and look at the chambers or atrial chambers, whether they are similar or they are not, an area behind the heart, whether there is an azygous continuation or there is no azygous continuation. So because these AVSDs will be associated with left atrial isomerism, both are left-sided heart, so it can be there. Now, once you want to see that, now what a new modality can offer, a new imaging, ultrasound can offer you that, look, this is the diastole, you have got interventricular septum, you can see the septum primum, you can have the beginning of systole, and in the systole you can have left outflow tract and right outflow tract, which you can see. Look at a video, you can see everything, and the crux in the volume also can be picked up, and you can have some kind of brilliant images coming all together. A four valve arrangement, as I told you, the tricuspid and mitral valve, they are going to be at the same level at AV junction, but from in front of that is going to be the aorta, and frontmost is going to be the pulmonary artery, because you have got the pulmonary artery is right there in front. The moment I switch on, this is where I have got two tricuspid valve and mitral valve, and this is going to be an aorta, and this is going to be the pulmonary artery. you can take the magic cut at the level of AV valve. You'll be able to assess these vascular arrangement at AV junction. When you are dealing with outflow tract malformations, whether it is double outlet right ventricle or common arterial trunk, there at that or in those conditions, you may need to look for these AV arrangement. Coming to left outflow tract, left ventricular outflow tract, there are a couple of things I would like to. This is of course graphic representation. You have got aortic valve open in a similar diameter to pulmonary artery. What we call it as a septo-aortal continuity. Interventional septum will continue with the wall of the aorta, ascending aorta, and that is what we call it as a septo-aortal continuity, and we need to think about that valve, that septo-aortal continuity. Just look at this. You have got, this is typical of LVOT, which we know. This is aortic valve, left ventricle, this is aorta. This is same thing, left ventricle, ascending aorta, and three valve. Look at this region. When I remove the myometrium of the heart, you will have septum. If you draw a line on interventricular septum and septo-aortal continuity, you will be able to identify exactly the. Can you see the blue line? And look at the blue line here. Look at the same line here. I draw a red line here, and this is what a septo-aortal continuity. You need to identify the septo-aortal continuity. When you don't find septo-aortal continuity, whether it is right there in the straight line, you are dealing with you may be dealing with the overriding aorta and tetralogy of Fallot or some kind of outflow tract malformation. So think in this line, septo-aortal continuity with 5-degree left ventricle. That's what your left ventricle is all about, and that is what the anatomy of the ventricular outflow tract is. You need to understand this is how it takes curve. Pulmonary artery usually it goes straight, but aorta will take a curve like this. The moment you understand the outflow tract anatomy, life is going to be really simple. Now coming to pulmonary artery outflow tract or a right ventricular outflow tract, this is what you have got: a pulmonary artery, right ventricle. This is a pulmonary valve, and here is a right ventricle and pulmonary artery. Look at the same thing here, and I'm going to show you how exactly the things are going to. This is the right ventricle. You got a pulmonary. You can evaluate the pulmonary artery by long axis or a short axis. So I'll freeze this and I'll show you the video what exactly anatomy of the pulmonary artery is. I have just opened. If you see the incision is on your right ventricle. This is the main pulmonary artery, and what I expect the moment main pulmonary artery goes like this, it is going to give one pulmonary branch on the left hand side, one on the right hand side, and third one will continue as ductus arteriosus. Look at the heart. Look at the specimen. I am going to freeze these images. This is the image of the main pulmonary artery. I am just rotating it here, and look at this. This is the main pulmonary artery. This is ductus arteriosus. This area is the main pulmonary artery because I have just rotated it. And this main pulmonary artery, I'm rotating at 90 degree. One pulmonary, another pulmonary, and this is the arteriosus. So these ductus arteriosus will go in front, and then this will join to the aortic isthmus, and that your tracheal V is formed, and that is what the real anatomy of your right outflow tract arrangement is. Now, what I can see on ultrasound, this is what I've shown you on the specimen, and this is actually a 13-week scan. Let me freeze it. Let me put it at these three structures here, and look at this video of ultrasound. This is 13-week, and here this is inferior vena cava. This is descending aorta. That's an hemocube. This is pulmonary artery, main pulmonary artery. This is aortic arch, and see what best you can. Now I'm rotating the ultrasound image. This is where let me freeze it so that I'll put it. This is aortic arch, and this is a pulmonary arch. This is aortic arch, and this one is a pulmonary arch or a ductal arch. I'm just rotating so that I know this is main pulmonary artery, right, left, and then I go with a straight ductus arteriosus. So these ultrasounds, now the recent ultrasound machines can reproduce the autopsy, the real autopsy images on the screen, and that's where we are interested in looking for or identifying the ultrasound images. Again, I'll play it across to you for you. Aortic arch, pulmonary arch, or ductal arch, rotated 90 degree. You see both the pulmonary arteries going, and here you just try to look at ductal arch and evaluate them at 13 weeks. So that is where I will be interested in and looking for branches and branches like that. So now left outflow, right outflow, now the total overall arrangement. Here is main pulmonary artery, ascending aorta. I'm just switching on the video of this is right ventricle, main pulmonary artery. This is the ascending aorta. Look, I have put a needle and look at the relationship. They are 90 degree to each other. So these 90 degree relationship, which I'm interested, because if they are not at 90 degree, I'm worried because I'm dealing with a left outflow tract arrangement, and that is exactly what I'm trying to look for, that pulmono-aortic septum development. If there are some malformations, I'll be looking for. Just I will also let you know how these things are. I have put in this bottle. I'll open this neck. Consider this as the left ventricle, and this is left outflow tract. This is aorta. So it is going towards the right shoulder. This is right ventricle, and this is a pulmonary artery. So the moment I put it like this, left ventricle, aorta, and that's exactly the relationship of outflow tracts are going to be to 90 degree to each other. So this is going straight back, and this is aorta is going to be at 90 degree. Look at pulmonary artery, aorta. Look at the aorta and pulmonary artery. The relationship should be at 90 degree. That is what is going to be normal, and that is how the things has to be, and that is what the great relationship of these arteries are going to be. The next step, evaluation of the heart from fourth chamber to a step above, that is an axial plane like transverse section, is a 3 vessel and a 3 vessel trachea view. So looking for 3 vessel and a 3 vessel, let us move forward. So again, let me put it across this to you, that I will just show you what you are, where you are looking at. I'll freeze the image like this so that you will have a crystal idea about it. Whenever just at the origin, if I cut the heart at this point, you have the most anterior is pulmonary artery, then aorta, and last one is here is going to be superior vena cava. That is, here the vessels are not meeting each other, they are separate. So it is exactly what the pulmonary artery, aorta, and superior vena cava. Here you will be able to identify the pulmonary artery branching. Okay, so that is what your 3 vessel view is going to be. And when you go up, when you cut at this place, at this segment, you will have the aortic isthmus and ductus arteriosus meeting each other. Here this is pulmonary artery, this is aorta. Okay, this is superior vena cava, but this is the ductus arteriosus, aortic isthmus. This is the main pulmonary artery. This is an aorta. This is superior vena cava. So an aorta this portion is going to be the aortic isthmus. This portion is going to be the ductus arteriosus, and this is going to be the main pulmonary artery. And one of the important structure is thymus. When you want to evaluate, so you have got PAS, pulmonary artery, aorta, superior vena cava. Look for the size, look for the alignment, arrangement, and number. So you have to have only 3 vessels. If there is one extra 4th vessel, you are dealing with problem. Only 2 vessels, you are problem. So it is PAS, pulmonary artery, aorta, superior vena cava. The rule is correct. It is from left to right, anterior to posterior, and the size wise. So it has to be PAS. Size wise, anterior to posterior, and also from left to right side. The moment you are evaluating 3 vessel trachea view, look for the thymus. You may be dealing with a thymic hypoplasia when it is associated with 22q11 deletion and many malformations. Look at a blood flow. The color, whenever you are evaluating, it has to have a similar kind of blood flow direction, and your assessment of ductus arteriosus and aortic isthmus. That is also important when you see fetal growth restriction, aortic isthmus, ischemic Doppler. So these are the few basic sections which are going to be important. Coming to the video, let me show you the video. This is the 4-chamber view. We have already learned. Look for the three vessel trachea view and brachiocephalic. So in 10 seconds, let me go back to this 4-chamber. We have dealt with. Look at this. There is a crossing. There is a crossing happening between the pulmonary and aorta because they are running to different directions. So you will have a different color. Then you go up. You have pulmonary artery bifurcation. Look at a pulmonary artery bifurcation, and then still you go up. You will have a 3-vessel view. This is a 3-vessel view. We have got a pulmonary artery, aorta, and last one is going to be, but there is no meeting. Then when you go still up, here you are dealing with the 3-vessel trachea view. It is forming V, where main pulmonary artery and aorta meet each other, ductus arteriosus and aortic isthmus, they join and going to the descending aorta. This is superior vena cava. And one of the important part, then if I still go up at the aorta, arch of the aorta, at the top of the arch, you will see one vessel going across from the right and from the left to the right side. Will have a different color than this. That's a brachiocephalic vein. So brachiocephalic vein will be seen in 3-vessel and 3 trachea view. Just have a look at one single clip of 5 seconds. 4-chamber crossing, 3-vessel bifurcation, 3-vessel trachea view, brachiocephalic vein. So just a matter of 10 seconds and you will come across everything. So 12 points for 3-vessel trachea view are this: LVOT, size, origin, angle. RVOT, size, origin without angle. 3-vessel, number, size, arrangement, PAS, arrangement anterior to posterior. 3-vessel, direction, size, blood flow, thymus. So that is what you need to evaluate. 12 points for 4-chamber, 12 points for outflow tract. A venous system, again, there are lot many things to look for. It's a different lecture altogether to look for the vessel, but I would like to tell you about the azygous vein, brachiocephalic vein, ductus venosus. What you should be looking at a ductus venosus. You need to look for the pulmonary veins. You need to look for the brachiocephalic vein. You need to look for you need to understand the base of the heart anatomy, and then your venous evaluation is going to be complete. But I wish first you should learn the arterial thing or a major chunk, not a basic kind of fetal echocardiography, but learn the base of the heart and the ductus venosus. Normally, there are in the heart, there are a few things you need to understand. The right atria receives blood from 3 vessels: superior vena cava, vestibule at the base of the heart, and third is a coronary sinus. The superior vena cava is formed by 3 veins: a azygous vein, the left brachiocephalic and right brachiocephalic vein. The vestibule at the base of the heart is formed by 3 things: inferior vena cava, then the hepatic veins, and the ductus venosus. So it follows the rule of 3, and that is how the way vessels you need to understand. So the thing is here, umbilical vein, that is important. Through here, this is going to give you a ductus venosus, and ductus venosus will push the heart towards the foramen of oval. That's the direction. That's the information about ductus venosus, and that is what you need to learn about the basic thing. So now we have learned 4-chamber, LVOT, RVOT, 3-vessel, 3 trachea view. If you don't do LVOT and RVOT, as in the beginning I told you that if you do 4-chamber, if you do 3-vessel trachea view, you will be able to reach more than 90%. If you don't do LVOT and RVOT, because you need to maneuver the probe when you want to go for LVOT or RVOT. If you don't, then you are not missing gross of the anomalies. It's subcritical Aortic stenosis you may miss, which is associated with Turner's, and subcritical pulmonary artery stenosis you may miss, which is associated with Noonan's. But you will be able to deal with HLHS, right hypoplastic syndrome, URB, TOF, CAT, and the structures which are mentioned here when you are evaluating your 3-vessel view, and whenever you are evaluating your 4-chamber, you will be able to access these many malformations. There are a lot of things you will be able to do, and whenever you are dealing with. Now, can you do that fetal echo in the first trimester? As Professor Ravi and Alfred always says, for screening of the fetal heart at first trimester, 4-chamber, 3-vessel view, along with the 3-vessel, along with the situs is good enough. So, and the situs, again, by the similar way, abdominal or transvaginal route, look at a grayscale 4-chamber, look at a 4-vessel, and look at a 3-vessel trachea view. This was in 2010, 8th October 2010. Look, interventricular septum, 4-vessel, 4-chamber, 3-vessel, and 3-vessel outflow tract, which we could evaluate right even at the first 2010. I'm talking about 13 years back. So you can, it's nothing is new. It's a 15 years old technique, but only thing is what you can do now is fetal echo in the first trimester. This is what you can have a much better quality of image, much better interventricular septum, 2-vessel, and evaluation by 3-vessel trachea view. Your image can be good with, this is color Doppler, and look at HD flow. You have got interventricular septum crossing 3-vessel trachea view, the ARSA, azygous. You can see every little thing what you are aiming at, looking at your second trimester. Interventricular septum, 4-chamber, forming an X across the tract. You can have 3-vessel pulmonary artery bifurcation and 3-vessel trachea view you can have. And of course, whenever you utilize stick, you will have some kind of total arrangement. HD in slow flow, all vessel arrangement, you will be looking at from there to a real good outflow tract, looking at a pulmonary 3-vessel trachea view, and also aberrant right subclavian artery. Look at a different grayscale. You have got everything from 2000, since 2010. You can have everything which you are trying to look at 13 week also. So the thing is, looking at an arch view, there you can have both the pulmonary arch and aortic arch seen. This is again E6, old generation E6 machine. But now look at your new generation. This is 13-week aortic arch with the branches. Aortic arch. This is, can you see the volume images? Pulmonary arch or right outflow tract arches, ductus arteriosus, looking at left outflow tract, looking at the complete system of arches. You can do it at 13 week, and that is what the power of ultrasound has gone to in the first trimester. You can have a volume. Just look at this. This is again 13 week. Systole and diastole, outflow tracts are brilliant. Inflows are fine. Interventricular septum is all right. My ultrasound images, and I know that there is no gross malformations, and I'm done. Even for screening, I'm okay. Now look at this images. You first image interventricular septum. This is what you have got, a 3-vessel view. You have got the thymus, thigh box, sub artery and pulmonary artery bifurcation along with the pulmonary vein. And this is the pulmonary. This is the pulmonary artery. Look at this in the video. You have got hepatic veins. This is a hepatic vein. That was a portal vein, venous system. 4-chamber of the heart. Where you see the pulmonary vessels going into the left atria. This is where you look at outflow tract arrangement, 3-vessel trachea view, and you have got the ARSA and thigh box evaluation. So that is what you can have. I'm trying to show you. I still have got 10 minutes, 15 minutes. I'll take few of the volumes. A roll of stick, normal image, anatomy, old variety of volumes. These are the new volumes. You can have just a gross normal picture in front of your eyes. Outflow tract, that is what you can have. Look at the diastole, look at the systole. You will have a diastole chambers are full outflow tract arrangement. Now, where they are helpful? Okay, the helpful, these are the very handy when you try to evaluate in general anatomy. Look at this point. This is aorta, this is inferior vena cava, this is hepatic, this is umbilical vein, this is ductus venosus. But what I will expect here is there has to be an angle difference between aorta and line of the inferior vena cava. If they are running parallel, I know that you are dealing with azygous continuation and IVC discontinuation. Not only that, where I will be interested in also looking at the arrangement of the hammock view. Azygous arch also is seen here. And when I rotate the image completely from right to the left hand side, I also see that, okay, this is a classical arrangement of the vestibule, which I told you. This is the vestibule which enters at the base of the heart, hepatic, ductus venosus, and inferior vena cava all goes in the vestibule, and you know the normal arrangement. Here, a gross image is telling you that, okay, the crossing which is not there, this is classic overriding of aorta. And the overriding of aorta, the moment you want to diagnose the overriding of the aorta, you need a lot many other things. So volume will give you, okay, instead of crossing, these are the parallel things, and these parallel things will letting me know that, okay, you are dealing with pathology which has got a parallel outflow tract origin. So you need to differentiate what actually the parallel outflow tracts are going to be. Then a normal outflow tract, look at a single outflow. This is only one vessel which is coming below. This is PAVSD. This is arch hypoplasia, single outflow tract. There are one way will give you lot of information about the outflow tract anomalies. So first trimester, this is the image with a pulmonary stenosis in the first trimester. Look at the pre-stenotic dilatation here. And this is the pre-stenotic dilatation. This is the pulmonary stenosis. So will give you a lot of information about the first trimester arch, first trimester heart anomalies also, arch hypoplasia. You have got a hypoplastic ventricle. Left ventricle is hypoplastic, HLHS with arch looks very small. You have got a reversal of flow from ductus arteriosus to the arch of aorta. And that everything you wanted to see will be right there. Another case of ductal right ventricle right at 13 weeks. So it's overriding of aorta, which I told you. It's all about looking at a pulmonary artery size and location and looking at a pulmonary artery. So there are differential diagnoses which you need to look for the from where the pulmonary artery arises and how this arises. So I won't go into the details because there are lot many things which you need to understand that, okay, 4-chamber view looks all right, but here you find an outflow tract which is an overriding aorta, and that's what you are looking at. Overriding aorta, that means you need to look for the pulmonary artery and look where exactly they are located, because you can have a similar, this is autopsy image, this is ultrasound. So that kind of brilliant correlation you can always make it around what actually you are dealing with. So now I'll show one case and then a couple of cases. Let me show you four ventricular 4-chamber view, overriding of the aorta. That's a 2D evaluation. Even if you are expert, you will see, okay, there is something which is going on. There is one small vessel which is seen at the end of the clip. At this point, you see some kind of, there is a grayscale, color shows reverse, but you really do not know exactly where actually the location is going to be. Furthermore, second clip, you have overriding of the aorta, but I could not make out where exactly the pulmonary artery is and how far the pulmonary artery is and what kind of arrangement, because I want to categorize what is the defect. The moment I took a volume, what I could see is that, okay, look at this. There is origin of one of the main pulmonary artery, and then it bifurcates in pulmonary artery. Look at this. Well, the arch of aorta, elongated arch, and when I rotate the image to look what is going on another side, I precisely know that, okay, look at this. Here is the pulmonary artery, main pulmonary artery from after the root, and this is the common arterial trunk type 1. So then another variety is this. You have got, you can have a look at the pulmonary artery bifurcation, origin pulmonary artery bifurcation, and look at quite a lot of varieties of this. I think I'll skip to some of the slides which are thing is tetralogy of fellow, which is going to be there. Overriding of the aorta. Look at the overriding of the aorta. This is the image, and here what I know that this is pulmonary artery is small, much smaller as compared to the outflow tract. So this is a classical variety, and I know that this is the tetralogy of the fellow, and tetralogy of fellow with a forward flow in pulmonary artery gives us a good hope after ruling out the chromosomal defect 22q11 and of course the outflow tract, the trisomies. Double outlet right ventricle. Here the outflow tracts are parallel. Look at this. The crossing is not there, and you have got this parallel outflow tract, and these DORV. Let me show you how it is. 4-chamber view, or look at this image. Interventricular septum quite all right. There is no defect which is seen at the base in the fourth ventricle, the 4-chamber view plane. But the moment you go up, there is a spreading of aorta. There is an outflow tract defect here, and the moment you go, you have got a parallel arrangement of the vessel, and you have got pulmonary artery is relatively smaller than aorta, and this is a classical case of double outlet right ventricle. There is always going to be a debate on the arrangement of TOF this variety and DORV this variety. So it's a shifting of the base, whether it is on the right ventricle or is it on the left ventricle or sitting right in the middle on the overriding right exactly on the interventricular septum or not. So you will have these kind of varieties of the things which you will be able to diagnose. TGA, this is classic, the classic arrangement of the artery, anterior aorta. You've got anterior aorta and pulmonary artery. These specimens are of the same fetus, ultrasound and autopsy images. So all autopsy images are of the same patient, so you can correlate it much better. So arch hypoplasia, you can have arch hypoplasia just like look at the sorry. Look at this arch is really hypoplastic, and you can have the small arch, large pulmonary artery, and you can have the simple thing diagnosed right there in front of your eyes. So that's the power, and these are the few things. Aberrant right subclavian artery, you can have the whole point is this is the trachea. Fourth vessel arises, fourth vessel from the arch goes behind the trachea and supplies the right arm. So there are critical aortic stenosis. You have to diagnose that, okay, ventricles are left ventricle is not contracting, and you look for the new things are non-contractile chamber. Only one contractile chamber, you will be able to appreciate non-contractile things. So there are major thing, aortic arch interruption. So the aortic arch which is not there, it is not there. They are the one duct dependent lesions, and you need to understand this duct dependency. And here probably you will have many things whenever you have got these duct dependencies. You need to. Here is the role of the 3D volume, because the 3D in the beginning, whenever I started using, I could know that, okay, this might be pulmonary artery, aorta, and they are meeting each other. But when I did not find something, I find something fishy. The shape, they are not good. But when I rotated, this image, after freezing the image, when I rotate it, because overlapping, yeah, I know that there is a discontinuation, and that you could pick it up from from the autopsy image. Today morning, somebody asked about AP window. So this is the case of aortopulmonary window, side to side opening. You will be able to pick it up, and there is a gap, and this is aortopulmonary window. This is a classic variety which you will be able to come to know. Very recent, if you really, this is before 4 days only, but this is an unusual variety of aortopulmonary window. Look at the shape is not really good. This is pulmonary artery opens at the base of the arch of the aorta. This is not really good. And look at the volumes. Here I know that it is this vessel, which pulmonary artery, which enters here. One of the pulmonary branch going supplying to the left lung, but it is opening here at the base of the vessel. So that is a different variety of AP windows which you will be able to come across. So all in all, what my point is that yes, you can do lot many things by doing good fetal echo. Now you remember that slide, similarity between a car and doing echo. Why I told you follow the rules, follow 12 rule of 12 segments in the 4 chamber, 12 outflow tract. Take some precautions, use the gazettes, and if you don't know, you will end up in disaster. So that's what I can tell you. So my recommendations are simple. It's easier than what you think. You do it. It's really easy. It's not difficult. You have to follow the rules. Use grayscale, HD flow, color, and slow flow settings. The settings are most important. And the moment you have got good setting, everything will be there in front of your eyes. Use stick. That will add value for your precision, and it will add beauty to your imaging. 12 sections at 4 chamber, 12 sections for other planes, which color or which HD flow is vital. Most of the cardiac malformations have similar features both trimester. So it's matter of size. So it's not gestation. It's matter of size. The moment you are dealing with a good, whenever you are having good machine, it's a size. So you can deal with anything. Key to learn echo is precise knowledge of cardiac embryology and anatomy. So learn, and I know you will be best your evaluation. Thank you very much for your patient hearing.
Thank you, Prashant. That was fantastic. And I loved your newer inputs from your lovely book.
Thank you.
Somebody wanted to know where to buy the book, and I know you keep feeling that it's not fair to advertise the book, but believe me, that book is quite a treasure to possess.
Thank you.
I don't know whether it's on Amazon as yet.
It is on Amazon. It is on Amazon.
Yes, and it's a fantastic book. So it's a great ready reference, all in one place, and there's no pirated edition as yet. So we'll have to buy it.
I have already shared it to you. Now your thought on Professor Chavi. What do you think about the how in India you should approach for the fetal echocardiography, or in basic machines, those you are using basic machines?
Yeah, but this is what you did properly. The machine. I don't want people to hide behind the machine, because the machines today of the basic doctors are by far better than the machine we used 15 years ago, or 20 years ago, and we did a good job. So this is why what you said, you take driving the car. So I used to say it before, but I abandoned. I was once in Saudi Arabia. I gave a talk, said, imagine when you drive a car, and the lady said, Dr. Chawi, we are not allowed to drive a car as women here in Saudi Arabia. Okay. So then this is why I compare with the cookie, because there's more similarities. But anyway, so let's say you are, or we are doing a high technology examination. And what we need first is to know what are the planes and what to see behind the planes. And you did it properly. You showed people how they can see in each plane the structures, and when you know the diseases behind them, this is the best approach. This is why I will recommend to focus 80% on getting the good image. And once you have the good image, you see that there is a gap between aorta and lung artery. You don't need to know the diagnosis, but you need to know what is the normal plane of a normal and 2D and color Doppler. And you see the new edition of the guidelines of his work. We have new schemes done by Frantic Rochal, and we added the color Doppler, so you will enjoy, I hope. Thank you for citing the book, as by the way.
Thank you very much. Your book is like a Bible. It's like for us we call it the Bhagavad Gita. Gita is a book where I think everyone will learn something from them. At any age. It's just like that. We learn any day, given day. You open one page, you will have information, 10 information which you need to understand and which everyone needs to know. That's what your book is about, fetal heart.
Yeah. You know what the way we did the book is also dedicated to people who let's say the first half of the book is more technique, that the typical technical parts from 3D and M mode. We added M mode in the new edition and color Doppler, but the main part is when you have an abnormality, like let's say an Epstein anomaly, you scan the Epstein anomaly and then you go home, you read the book and you see, oh, Epstein is also common in deletion 1p36. And then you say, oh, and then you check and you find the case that, oh, it was in the book.
Yes.
Why? Because, when we search for the book, we did all the actual literature. But if you read it without having a case, you will not remember for this anomaly, look at that and that. But if you have your case, then you will see, oh, you can calculate the area. You may see that there are some tachycardia leading to fetal death, etc. So this is why you should use it this way. And this is work of I don't know how many years we were doing this. Thank you very much, and I appreciate that when people give me a good feedback, so I'm encouraged to run the next edition of a next book. We'll see.
Wow, but this book is the edition of all time. It's like fantastic.
Thank you. No, the hard book will be the last, I think, because you cannot this was too much work, but we added 100 schemes, so it was
yes.
It was also good.
Yeah.
All right.
I will abandon you now. I wake up at 5 o'clock in the morning. Now I start waking up. So bye-bye. Thank you. Thank you, Prashant. Thank you, Ashok. Enjoy your day.
Two questions are there. What can be the differential diagnosis when CSP is present in anterior section, but frontal horn communicates in posterior section on coronal section?
So again, I may read it.
The question is,
present in anterior section, but frontal horn communicate in posterior.
Anterior part, you can see the septum, but posteriorly find that septum. So that's what.
Do you think what he means or what she means is that
it's like an intraventricular
a partial agenesis of septum pellucidum?
Yes.
I don't know. We have recently a case like this. I assume it is a torn, because the true absence by definition is the one related to the anomalies. The other one can be a torn septum, which can be related to let's say, related to some secondary events.
There are few cases like it was actually what we diagnosed. There are 6 cases now we have where it has got a unilateral septal perforations which are there. They are not equal in size. If I can show you that case, that is going to be the. Let me try to see if it's very handy. Then I will share that, because that is one of. Now we have got 6 cases like this, which is not really very usual, but we find a septal perforations by doing 3D scan. Only septal perforations. The septum was not intact, and we could see those things. I have got those things. Unhide. I will share, and I will share the screen now. So in this, these are 6 cases now. I hope it is visible.
Yes.
Yes, we see. Yeah.
So it was this. This is a volume. you have got one septum here. There is no septum, another septum here. On 2D, this was the picture. Borderline ventriculomegaly. Coronal image, you find there is something which was fishy here. Was not really. I wasn't happy on your 2D coronal also. Then when I got a 3D, I could find that there was some septal perforation which could be correlated like this. And then it was only one partial kind of defect where you had these kind of septal perforations in the midline. And then when we got it done, this was a volume which showed normal scanning of the corpus callosum, or the posterior fossa, and everything was fine. And at the end, this was a 3D volumes where anterior is not really good, anterior part. So various kind of other pictures, like there was a communication defect here on the side, and eventually out to be like I will give you straight. We got MRI. It was practically showing a similar kind of situation. And when we did the micro array and next generation, it was patch 1 mutation, and that was considered to be the mildest form of holoprosencephaly.
Okay.
So this was, I mean, they are unusual presentations of septal perforations, which we can have. Probably that's what we have 6 cases like this, but we could find some genetic malformations in 3 of them. Still 3 were normal, chromosomally normal.
But the fetus had nothing else in the brain and so on. No.
Borderline ventriculomegaly, 11 millimeter lateral ventricle. That's it.
Okay. But then it can be also the ventriculomegaly leading to to tear this.
11 millimeter contralateral ventricles was enlarged. This was reasonably normal, but 10 millimeter usually, or 11 millimeter, does not lead to toning of the interventricular.
Yeah, could be. Yeah.
So, I mean, there are
interesting. So we'll follow up. Okay.
So, thank you.
Bye-bye.
Bye-bye.
Have a good time.
Thank you.
See you next time. Bye-bye, guys.
Thank you.
Enjoy being with you.
Thank you. And now we have got next talk by Professor Ashok Khurana, who will be dealing with growth restriction. And after Ashok, we will have a talk of.
And ये बंद हो गया, ये चला गया.
कहाँ चला गया? आप तो लाइन पे.
Yeah, am I back again?
Yeah, you are there.
My apologies. Okay, I'm going to go and share my screen. And do you see my screen?
Yes.
Wonderful. And then you can see my little pointer.
Yep.
And we will discuss Doppler in obstetrics and when to deliver the growth-restricted fetus. So we will take you through these wonderful signs that tell us that there may be trouble ahead, that we need to do something. We can't afford our fetus to become hypoxic. And the true clue to all of that is to study flow, whether there's a good flow like you see from this tap, or whether there is this flow, which is not the ideal flow. And we'll try and understand flow velocity waveforms as a predictor as well as an indicator of flow. So let's start with the very first slide, and that is the fact that fetal weight is important. Fetal weight is what we use as an indicator of fetal growth. We do understand that growth is something that happens over time, but we need something to be able to tell us how well a fetus is growing, and therefore we need to do it, and we use growth as the parameter of fetal weight. Why? Because if you don't have attention paid to this and it goes unattended, then there's this huge risk of an abnormal adverse perinatal outcome in terms of hypoxia, acidosis, intraventricular hemorrhage, the necrotizing enterocolitis, and so on. There's also hypothermia and so on. You also have abnormal long-term neurodevelopmental outcomes. And then, of course, everything that leads up to atherosclerosis and metabolic syndrome, including hypertension, coronary artery disease, stroke, diabetes, and non-diabetic insulin resistance. And the other side of the problem is that it is hugely common. we attach so much importance to Down syndrome, which is 1 in 800, and yet fetal growth restriction in the world is at about 7%. In India, we have 26% of pregnancies that don't meet the mark that we have set for ourselves, which is 2.5 kilos at birth. Not that it's the most intelligent mark, but that's what we use as a reference. And therefore, we need to look more closely to what's happening, because we do understand that as the weight goes down, and particularly when it is between the 3rd and the 10th centile, perinatal mortality and perinatal morbidity will go up, up, and up. And the moment we plunge to anything less than the 3rd centile, the incidence is 20 times that of the baseline risk of perinatal morbidity and mortality, and that is completely unacceptable. Therefore, we need to know the fetal weight and do something about it. What can we be doing about it? We will learn during the course of this talk. And so I will take you to not being lost, not being confused, not being perplexed, and take you through a brief review of the current definitions of growth restriction, although that will be taken up again today, and mainly an emphasis on Doppler in delivery decisions and fetal growth restriction. We will revisit some of the conventional wisdom. We will discard some old ideas because we deserve to discard them. And we will also put Doppler in the perspective of CTG, computerized CTG, and the biophysical profile. So that is the way we're going to go about doing all of this. But first of all, the definitions. The old-fashioned definition used to be a growth-restricted fetus is one that fails to achieve its growth potential. But we don't know what the growth potential is. Does it depend on maternal height? Maybe. Does it depend on paternal height? Maybe. Does it depend on your race? Perhaps. Does it depend on many, many, many other factors? Yes. Therefore, we have to figure out what goes right. The best way to figure out what goes right is something that will shock most of you, and that is that fetuses who do the best in terms of the antepartum period, the intrapartum period, and the neonatal period are the fetuses that are between the 80th and the 90th centile. Classically speaking, therefore, and mathematically extrapolating, we will understand that it is this that is the correct weight and not the 50th that you and me have been talking about. The 50th is not far from the 80th, but we do understand that this is the best performance at its lowest when it comes to intrapartum and neonatal complications, and not too many antepartum period complications. So we're quite happy. But there is still difference of opinion and different guidelines from the UK, from Canada, from Australia, from Europe, and so on, and from all the societies. So what do? Well, we follow one of two definitions, either the Delphi consensus, which was a bunch of experts that came up with these, or data-based stuff, which came out from the fetal medicine group in Barcelona, which are the Barcelona definitions of this. And of course, just about everybody has a definition. But the first thing we need to realize is that there is a difference between a baby that is small for the period of gestation and fetal growth restriction. And the two things that we need to understand is that the growth restricted baby is the one that's likely to have a poor perinatal outcome, whereas most SGA babies will have a decent perinatal outcome. The growth restricted baby has a high risk of fetal demise. That's not so in the SGA. That the FGR baby has Doppler signs of adaptation, and the SGA baby has no signs of adaptation, and that's what really differentiates the two. Because of this, it is safer to deliver FGR babies depending on their stage. If it is mild, then 37 weeks and no more, and maybe earlier, but the SGA baby can be safely left to go. However, we have discovered in recent times that delivery can usually be safely delayed to 40 weeks only in a section of these SGA babies, because about 10 to 20% of them will, over a period of time, shift fetal growth restriction, and therefore even the SGA baby definitely needs a close surveillance. How frequently? Some people say 4, some people say 2 weeks. I just feel more comfortable in taking a 2-week stand because our babies require a lot of logistical support, which means we may not always have nurseries, we may not always have neonatologists, we may not have the most perfect nursing staff, and we could consider an in utero transfer, which means to shift the baby to be delivered in a hospital that has facilities that are appropriate to the fetal weight and an appropriate follow-up. Also, it's a choice of the patient these days. So the two things that we must realize about this is that in addition to this difference between SG and FGR, there are two distinct phenotypes of growth restriction, and one is the early placental failure and the other is a late placental failure. In the early placental failure, the fetus is most likely to be small, and in late placental failure, the fetus is not necessarily very small. In early onset growth restriction, the spectrum of Doppler alterations involves the umbilical artery, the middle cerebral artery, and the ductus venosus. The fetus in late placental failure is a fetus that is not necessarily very small, but does have cerebral blood flow redistribution with the preferential flow going to the fetal brain. But the area where we fail is this, that the early onset is someone that at that time moves from a normal reading to a low reading. On the other hand, in the late placental failures beyond 32 weeks, they move from a normal reading to a low reading, but not anything that is below the norm. And these babies are at a disadvantage also because they're bigger babies, so there are more requirements. In addition to being bigger babies, these are also babies who are used to living in the lap of luxury, and the slightest of a challenge can kill them. And the slightest of a challenge can damage them. So these are the ones that have a major problem with their management because they don't seem so bad, and yet Doppler is a warning sign for us that we need to do something better. We also understand that from a maternal point of view, the early onset growth restrictions, usually from their mothers, have a low cardiac output and high peripheral vascular resistance. And the late onset ones have a maternal cardiovascular system that is not so badly off, which means that yes, the early onset are usually the hypertensive growth restrictions, and the late onset ones are the unexplained true placental insufficiencies. There is also this huge difference where the early onset warn us and follow some rules. So we find a normal umbilical artery and then decreased forward flow in the umbilical artery, then absent flow, and then reversed flow. So there is a cascade. Also in the early onset growth restriction, over the next 4 to 6 weeks after the umbilical artery starts showing a decreased forward flow, we see an increase in the flow at the end of the cardiac cycle in the middle cerebral artery, and therefore you get this kind of a wave pattern compared to this one, which has very little forward flow at the end of the cardiac cycle. Then as hypoxia progresses, the normal ductus venosus gives way to a decreased forward flow, which is a decreased A wave height, and finally a reversed flow. And as the disease progresses, you then get cardiac dysfunction, and therefore you will have a fetal heart rate variations, their decelerations, ultimately loss of breathing, loss of movement, and loss of tone and death. But they warned you many, many weeks earlier, from here to here to here to here, that this is going to happen. So these are babies that warn us. My late onset growth restriction, which is the one that starts after 32 weeks or is detected after 32 weeks, evolve over the next few weeks, but they will not follow a simple cascade of first this and then this and then this. You can have a perfectly decent looking umbilical artery, a perfectly decent looking middle cerebral artery if you look at it subjectively, Also, the PIs may be almost normal, but when you take a ratio and you divide the middle cerebral artery PI by the umbilical artery PI, that's what we call the cerebral placental ratio, you will find that that is altered. And these babies will suddenly go into death and give you trouble, and they will give you no time to act. So that is the problem. There have been, of course, these wonderful algorithms. I won't go too much into the detail because this is not really part of management, but which has implications. And that is that when you first see a small fetus, you have to figure out whether the pregnancy has been dated correctly, and we will discuss this. You then go on to exclude structural abnormalities or signs of an aneuploidy, and that's important. People talk a lot about amniotic fluid index, but really speaking, we've dropped that. A, because it's not consistently reliable. B, because the deepest vertical pocket works as well. And C, because particularly in some of the FGRs, the amniotic fluid index does not go down for a long, long time. Therefore, it's really something that has been dropped from literature, and although it's still very useful in twins, and it's very useful for the anomalous fetus, it's not useful for decision-making and growth restriction, either for diagnosis or prognosis. Yes, in the oligoamniotic pregnancy, we will do enhanced perinatal or intranatal surveillance that during labor, we will assess them more consistently, more frequently, and try and look for abnormalities, but we will not start getting worried that, okay, on the basis of the amniotic fluid, I'm going to take a decision to deliver. There is, of course, the group that is constitutionally small, and all they need is a serial ultrasound at 2 weeks, although some people say 4 weeks. Then there is the true placental insufficiency, and you say, okay, these may have abnormal Dopplers, and they may have echogenic bowel, and then you follow them up every 2 weeks. Then there is this important group which you need to see, which actually implies that every single ultrasound scan should include a search for abnormalities in terms of structure. And therefore, even if you've had a very good anomaly scan, you will look for late onset anomalies, and you will look for missed anomalies when you spot these, because you really want to be very careful. Then, of course, there are those with an isolated structural abnormality, where again, you have to be careful that, look, you may want to do a genetic evaluation late in this pregnancy because it may be an associated genetic condition. You will then offer them, depending on the circumstances, either an NIPT, which I'm never in favor of, because all it tells you is that, yes, there is no trisomy 21, and that's not really associated with the growth restriction. But in terms of an array, and in case the array is okay, you might even offer them an exome. You will then start looking for the syndromes that are associated and have genetic markers, and use that as a second step in the genetic evaluation. And then, of course, if there is echogenic bowel, I will also look for cystic fibrosis. Not that it doesn't occur in India. We generally believe that it doesn't, but that's not true. It does. Also, I will look very carefully for signs of an intrauterine infection, which would include either a swollen or a shrunken placenta. It would be either a polyamnios or an oligoamnios. It could be calcifications, fluid collections, ventriculomegaly, and cataract. And therefore, you'd like to offer them very closely, and if necessary, even offer them screening for parvovirus, CMV, and toxoplasmosis. So that's the general approach. That means we will not ignore infections, and we will not ignore structural abnormalities, and we will not ignore genetics. You will learn from the next talk that we have Barcelona definitions, and that an SG is any baby that is less than the 10th centile on standard growth charts. Extremely important that we don't use customized growth charts when we talk Barcelona. We always use a chart for weight calculation that includes the head circumference, that includes the abdominal circumference, and includes the female length. We also make sure that we use 10th centile as a cutoff. If along with the 10th centile, you have a cerebral placental ratio less than the 5th centile, or you have a uterine artery that is greater than the 95th centile, that is growth restriction. If by itself the weight is below the 3rd centile, that by itself is growth restriction. To remind you, the cerebral placental ratio is the ratio of the MCA PI divided by the umbilical artery PI, and that's what we will calculate. This is a nice, simple, clean way of doing things. It may not be a perfect definition to choose the 10th centile. Maybe 80th is a better centile, but for now, until we have newer evidence, we will use the 10th centile as a cutoff. We also have the Delphi consensus, where the essential difference is, of course, first of all, we exclude congenital anomalies and then divide in the same way, less than 32 weeks and greater than 32 weeks. You add on the fact that you can have an umbilical artery absent flow, which defines growth restriction, in addition to a weight less than the 3rd centile. You also add on that there could be just a decrease in the abdominal circumference to less than the 3rd centile. And then, of course, if you have either the abdominal circumference and the weight at less than the 10th centile, and you have a uterine artery greater than 95th centile, or an umbilical artery PI greater than the 95th centile, that also comes under early onset growth restriction. On the other side, at the ones that are greater than 32 weeks, we still use both the abdominal circumference and the estimated fetal weight. But we use, of course, also the CPR in exactly the same way. We also use just the umbilical artery greater than the 95th centile, and we also use what is called crossing centiles, where the growth falls from a higher centile to a low centile that is separated by 50 centiles. So from 75 to 25, from 80 to 30, and so on. It's a little complicated when you use the Delphi consensus, but some people love it. What do I use personally? I use the Barcelona group definition that works well. Step number 1 in the management, confirm dates. We know we have a great Indian concept of time as a non-mathematical commodity, not like in other parts of the world. We do realize that we date our pregnancies by festivals, family events, national events, lunar events, and a variety of calendars that are not the Gregorian calendar. A lot of our patients will come in late and will not have a scan before 14 weeks. And we know that the best time really is 8 to 14 weeks. Or we might have an ultrasound scan, which is poor technique. And we know that there is very little self-audit amongst us, and therefore we must extend that, but it doesn't happen. So how do we overcome this? One, that we encourage a scan as soon as the patient comes to you, irrespective of which stage of pregnancy, week 7, week 9, week 11, just do an ultrasound scan. Then, if a patient has come to you later, you look at all the papers, you try and see any image with any scratched CRL or any scratched calculation of weeks, and you look at the image and see whether it's reliable or not, and you use it or you don't use it. And then, of course, we might need to do serial evaluation, so counseling. And the other thing that we must understand is that if we have a national policy or an insurance that pays for tests, then patients will come earlier and we will get a dating scan for everyone. So this is the way that we go ahead, and hopefully we will follow this in the future. For now, we will pray very hard and depend either on artificial intelligence in the 2nd trimester or good luck in the 3rd trimester or serial evaluation. We must remember that the crown rump length is the most reliable, and as you progress in pregnancy, you will tend to depend on multiple parameters, and there could be a 1-week difference in the 1st trimester, a 2-week difference in the 2nd trimester, and a 3-week difference in the 3rd trimester. The more parameters you use, the more accurate you're likely to be, and for twins, we will always use the larger crown rump length. You then move to the steps in the appropriate evaluation to promote a management decision, and after you've measured a parameter, you go and assign normality, you put it on a chart and compare with norms, work out the centiles and compare it with previous readings. You then estimate the fetal weight, and then you do this extremely important component, which is color Doppler. You can include a CCTG, and then there is some role of a biophysical profile, but very limited compared to what we used to think it is. And we will discuss that also as we go along. Because really speaking, what's the treatment for the growth-restricted fetus? If the mother is malnourished or incorrectly nourished, and she's got fad eating or a diet of some sort of stupid nonsense, then we say, okay, that she must be nutritionally supplemented. Otherwise, the only treatment is early delivery to prevent the massive complication that can happen if you don't deliver them early and the hypoxia becomes critical. What we need to do is to assess the risk of prematurity if we deliver too early and compare it with neurological damage or death if we postpone our decision to deliver. It's not easy, but Doppler helps us figure this out. We like the baby to remain inside for each day. That can help because the morbidity will go down by 1% and the mortality will go down by 2% compared to the expected one for the ideal baby weight. Therefore, we must try and postpone to the extent possible without damaging. This is a slide that originated with me 30 years ago, and we've been yelling from the rooftops for that ever since we discovered Doppler by telling us that the CTG is not a great indicator of 7.2, which is your critical parameter. What is our critical parameter? A fetal pH of less than 7.2, an oxygen saturation in fetal blood of less than 30%, and a base excess in fetal blood of more than 12 millimoles per liter. Otherwise, your fetus becomes hypoxic. And the options we have are a CCTG, a biophysical profile, and a color Doppler. When we look at the biophysical variables, we realize that there is such a difference from when the breathing movements disappear to when the gross body movements disappear. And this is way above 7.2, and this is way below 7.4. It is not a sharp cutoff. When we look at the NST or a CCTG, we realize that there is no sharp cutoff, and the CCTG actually starts going crazy when we're already reaching a pH of 7.3, not acceptable. Other Dopplers, not acceptable, but when we take this cerebral placental ratio, or we take the ductus venosus, then we have a sharp cutoff at 7.2, and gestational age-related changes in the CPR or the DV are useful for labeling growth restriction and for taking a decision for delivering. This is the tragedy that happens with the biophysical score. That means from the disappearance of fetal breathing movements and the appearance of fetal movements, there is this drop which is crazy from above 7.2 to way below 7.1, not acceptable. Therefore, the only place where we use biophysical score is in the scenario of decreased fetal movements in the third trimester. There you have to exclude an amnionitis, you have to exclude a premature rupture of membranes, and that the mother has not eaten. And then you start looking for cord in an unusual place, such as around the spine, or around the trunk, or around the ankle, or the foot, and so on, or even occasionally around the neck. That's a rare one. And then you say, okay, that is where I will use my biophysical score, not in routine evaluation of fetal growth restriction. When I look at CCTG, the original study in the truffle study was based on CCTG and not on CTG. When we use CTG, we pretend that it is a CCTG finding, and we try and reassure ourselves that we are on the right track. And we are not. We're not on the right track because you and me know that A, the CTG does not critically differentiate a pH from being close to or far above 7.2. It also uses a parameter that is different, which is late deceleration, which happened much later in pregnancy. Also, that 50% of babies with an abnormal CTG will have no hypoxia acidosis. What about CCTG? Finally, a nice, wonderful Indian machine available at a very reasonable cost, locally manufactured, already validated, and working beautifully, and the cost is as low as 1.25 lakhs. With that there, we must start using the CCTG much more frequently than we use currently, and we will have no excuse to say, I don't have CTG, I don't have CCTG. You cannot replace the CTG with the CCTG. That's not what the truffle trial was all about. Then, of course, like I said, we find the critical parameter, and then we realize that my delivery for the early onset, less than 32 weeks, is intelligently based on ductus venosus evaluation for assessing when to deliver in early onset growth restriction. For the late onset, my sensitivity will increase if I use the cerebral placental ratio as a critical index in late onset fetal growth restriction. Do I use a single cutoff like people like to hear of a 1.00? No, that is not true. I have to use a gestational age related cutoff in managing my pregnancy that has growth restriction. Yes, I will use certain things. I will use the uterine artery, because even if it is normal at the NT or the anomaly scan window, it will indicate to me that something is wrong with the degree of resistance in the placenta. I will use the cerebral placental ratio because just the MCA PI or the umbilical artery PI is not good enough. I will no longer use the aortic isthmus because it is difficult to do, not consistent, and a lot of us used to think that it warns us before the ductus venosus goes wrong. That is not true anymore when we've studied large and large numbers of cases. We know that yes, changes in many cases will precede those in the ductus venosus, but in many they will not. In many, the baby might be on the path to death and not have that wonderful window that we used to think it used to have, that we detect the aortic isthmus going wrong, and then we're happy that, okay, we can still wait a couple of days. That is not true. Therefore, the aortic isthmus has come and the aortic isthmus has gone. And we shouldn't be using it anymore anywhere. And of course, before we get on to ultrasound, we know that we will always say that ultrasound is safe, but we still use it as little as possible. Then we must remember what each vessel shows and why we keep making noise about doing not one vessel, but a multi-vessel Doppler. A one vessel is very popular in the United States of America, A, because I don't think they are confident about Doppler, B, there are not enough people doing reliable Doppler, and C, maybe they just don't want to do it and the insurance company is not allowing them to do it. I can't be more blunt than that. But they seem to just think that the umbilical artery is enough and that if you have a normal sized baby, you don't even need this. We've already figured out that the late onset growth restriction is very subtle in its growth restriction, and Doppler is a better indicator than the estimation of fetal weight. Also, I must realize that you could have subtle changes in the uterine artery, which talk about trophoblastic invasion, and the index I will use is the pulsatility index. The umbilical artery tells me about placental villus obliteration, both in terms of spasm of the placental vessels as well as atherosis of the placental vessels, and the index I will use is the pulsatility index. The middle cerebral artery tells me that there is no deprivation of blood flow to the brain. It in fact gets enhanced, and my middle cerebral artery PI will show this, and the ratio between the PI in the middle cerebral artery and the PI in the umbilical artery, by which I mean the cerebral placental ratio, is a great indicator of this. The aortic isthmus, out of the window. The ductus venosus talks to me about myocardial function, very critical for early onset growth restriction, but very late to appear in late onset and perhaps too late. So I will not depend on ductus venosus. Will I do the ductus venosus? I do it anyway because it's a great warning signal for how healthy the fetal heart is. And therefore I do it anyway. Is there a data justification? There isn't. When it comes to a specific personalized practice of when to deliver for the patient rather than government rules or guideline rules, then you realize that the ductus venosus can be useful, and therefore you will do it also because it's not difficult to do in the first place. Which index to use? Always the PI, always the PI, always the PI. Do I need a peak systolic velocity? Only when I'm looking for fetal anemia, not otherwise. What do these abnormalities look like on the Doppler? We have a completely normal uterine artery PI in the normal individual and disappearance of forward flow. And it goes back to looking exactly what it would have looked like at 10 or 11 weeks with a notch in early diastole and this. Do I make noises about the notch? Well, not for the diagnosis or the prognosis of uterine artery flow velocity waveforms, but when I see something like this and my earlier reading was the above reading and this is my new reading, I know I'm in trouble. With umbilical artery, I end up with reasonable flow at the end of the cycle, and then absent flow. And I double check this by adjusting my wall motion filter. And then I also look for reversed flow. In the MCAPI, I will look first for increased flow. This is normal. And here at the end of the cardiac cycle, this is increased flow. And then as we have cerebral edema, we go back to the original pattern that you see here. It almost passes off for normal, except you realize that there is this little downslope, little notch on the downslope, which tells you, this is different. It has moved from this, which has no notch on the downslope, to this, which it does have. Do we make noise about the notch? No, we don't. Do we make noise about this? If it is the first reading, you be very, very careful and repeat much sooner than you think. And if it's something that you've known before and you see it again, then you know already that you're dealing with trouble. Now, the other thing that we must carry home as a concept is that for decision making for delivery, all parameters have a gestation age-related normal range, and therefore we will not just say, okay, this is abnormal because according to my cutoff, which is a general cutoff for all weeks of pregnancy, this is normal. This is abnormal or normal. Not allowed. You must have a gestational age related finding in terms of the abnormal mathematical figure, and that we will repeat these readings as long as there's no other maternal indication for urgent delivery. We will repeat these after 6 hours and then take a decision. A frequent indication of immediate delivery is the clinical situation, a deteriorating maternal medical condition such as severe PIH, preeclampsia, uncontrollable blood sugars, etc., etc. What do I do in which stage? This is why I like the Barcelona algorithms. They have divided us into stages the degree of fetal hypoxia acidosis. If you have a weight that is less than the 3rd centile, or you have a less than 10 centile with a CPR less than the 5th centile, or a uterine artery PI less than the greater than the 95th centile, then I know I'm in trouble. I will not use the umbilical artery or the MCA individually. Excuse me. Grade 2 is when we have absent forward flow in the umbilical artery, absent end diastolic velocity, and we no longer use reversal of flow in the aortic isthmus. In low suspicion fetal acidosis, which is progressive alteration in fetal pH, we label it as stage 3 if you have reverse flow in the umbilical artery or a ductus venosus pulsatility index of greater than the 95th centile. And then if you have a ductus venosus reversal of flow or a CCTG less than 3 meters per second or frank late decelerations in the fetal heart rate on NST, then we say, okay, in this situation, we need to be really serious about delivering as soon as possible, or giving the parent an option. Would you like this fetus to be yours, or should we just let it go? That is an important option to give to your patient if you think that the situation is such that if you deliver, we will lose the baby one way or the other. The important part about these definitions is that they let you know when to do your surveillance. If you've gone past 37 weeks and you have a stage 1, you say, okay, I will induce labor. If it's less than 37 weeks and you're a stage 1, every week you call them back for a Doppler evaluation and you do a weight evaluation once in 2 weeks. For stage 2, which means absent forward flow in the umbilical artery, if you've crossed 34 weeks, the recommendation is to do a delivery by cesarean section. If it's less than 34 weeks and it still remains stage 2, then you will monitor them twice a week with Doppler and then decide what is the level of deterioration. If you've moved on to a stage 3, which means there's reverse flow in the umbilical artery or the ductus venosus is greater than the 95th centile, you would like to see them every 1 or 2 days. And if they've crossed 30 weeks and your nursery allows it, then delivery by cesarean section. If you have a high suspicion fetal acidosis, ductus venosus reverse flow or a CCTG less than 3 meter-seconds or deceleration of the fetal heart rate, you know you're in trouble. If you're beyond 26 weeks, give them the option that yes, we can manage. If your nursery is not good, give them the option of transferring to somewhere else. It's less than 26 weeks, it's a very tricky decision, and then you can really be in trouble, but leave the choice to the parents. We have an app, which makes life much easier. It's a calculator, really. I shouldn't call it an app. And this is from the old calculator. You now have a redone portal, which makes it easy. You enter gestational age, you enter the weight. The default gender that you enter is male. You don't have to know the gender. We just enter male because that's by default, it will be there. You enter umbilical artery PI, MCA PI, uterine artery PI, and you get an answer. This is a 34-weeker with late onset growth restriction, stage 1, and just follow up in 1 week and don't be in a hurry to deliver. On the other hand, if I got this weight and this Doppler at 37 weeks, my reading on the top here is now 37 plus 4. It tells me growth restriction greater than 37 weeks, deliver. Deliver by induction of labor if the cervix is favorable. Okay, do we have any other guidelines? Yes, we do. We have the ISWA guidelines. They're pretty much the same except they shift by a week. And I find it very difficult to go through a chart like this when I'm in trouble. I just prefer a simpler one. Let's look at early onset growth restriction first. And this was a beautiful piece of advice that came to us in 2021, that if you have a fetus which is growth restricted between 22 and 26 weeks of gestation, and it is less than 500 grams and you have absent flows in the umbilical artery, just follow up at 26 weeks because it's not worth delivering before 26 weeks, but you can give parents an option. If it is more than 500 grams, again, personalized management. When you move to the 26 to 32 weeks window and you have the same finding that I was talking about, then you actually start considering and watching them until they go for an absent or reversed flow. And then you do a daily CCTG, Doppler every 2 to 3 days. And depending on what you find in the ductus venosus and the CCTG, you will deliver. So if the ductus venosus is at or below the baseline and the short-term variations of the CCTG are less than 2.6, or you have spontaneous decelerations, you will deliver them irrespective of whether they're 26, 27, 28, or 29. On the other hand, if you have a ductus venosus A wave at or below the baseline, or STV less than 3, and you are now between 29 and 32 weeks, or a spontaneous deceleration, or reversed in diastolic flow in the umbilical artery, and you're more than 30 weeks, then you start considering delivery. So if it's between 29 and 30, you wait for reversal. Beyond that, you will deliver. Between 30 and 32, you will wait for ductus venosus changes or spontaneous decelerations. The follow-up at the 26 week to the 32 weekers, if you have a weight that is not yet less than the 3rd centile, is twice weekly, and less than 3rd centile with a normal umbilical artery Doppler weekly, and if it is between the 3rd and the 10th, a normal umbilical artery Doppler fortnightly. Do I always depend on this? I say no. I'm very uncomfortable about this recommendation. I would still like to follow them up weekly, but twice a week in case I have an abnormal umbilical artery, and that is how I would like to follow them up. Do I have anything for later in pregnancy? Yes, I do. We've already finished discussing the peri-viability ones, which are more or less than 500 grams. We've also pretty much finished discussing the ones that are between 26 and 30 weeks and say, okay, we will be very, very careful. And if you have an absent or a reverse ductus venosus A wave, if you have a biophysical profile of less than 6 out of 10, and you have a CCTG short-term variations of less than 3 meter-seconds, you will consider delivering them. When you go beyond 30 weeks, you will look out for reversed umbilical artery and diastolic flows, and also CCTG STV of less than 3.5 meters/second, and that will take you to 32 weeks. Between 32 weeks and up to 37, you will combine the absent flow, not the reduced flow, the absent flow, and a CCTG STV of less than 4.5 meters/seconds. Some people suggest that if you don't use this, you could try an NSD CTG, but let's face it, it doesn't work. We pretend it works in our part of the world, but actually it doesn't. And after 37 weeks, if you find an abnormal Doppler, that's an indication for delivery anyway. So this is how simple management has become over the last few years. What's no longer good? Placental grading. We threw it away 15 years ago, and the Granum grading, we realized, is not applicable. It came very early, got revised in 2009, and then got reviewed at that time to say that the ugliest of placentas might have the most beautiful of functions, and the most beautiful looking placentas might have the most horriblest of functions, and therefore it's not worth it. It has no correlation with function. Yes, a calcified placenta has a higher risk of abruption, so you will watch out for those, but not really beyond that. Cigarette smoking makes it worse. There's no association of a calcified placenta with lung maturity, as we believed earlier. And those who are on heparin and heparin analog treatments will show calcified placenta. And therefore you say, okay, these are not really important. So my decision will not be based on placental grading. The other thing we've thrown out of the window, of course, was amniotic fluid index, but there's two inclusions. One of them is a circumvallate placenta, where the membranes insert closer inside than the edge of the placenta. So the membrane goes over like this and then inserts inside. So there's a little hollow sitting there, which is very well seen on 3D. This rolled appearance tells me the circumvallate placenta. It's very much associated with fetal demise, and therefore I must then deliver by 37 weeks and not go beyond that. And of course, you sort of shift your decision from the 37 to the 36 window. The 34 one will get reduced to the 32, etc., because it is a troublesome event. What do we do with holes in the placenta? Most of them are innocuous, venous lakes, and nothing for me to be worried about. However, there is one condition called placental mesenchymal dysplasia that is associated with stillbirths. But I can't tell the difference. If these holes fill up with fluid, with venous blood, I'm happy. They may then indicate just placenta accreta, invasive placenta, or they may indicate nothing. But if they don't fill up and they are there, placenta accreta is one possibility, and you look for that. The other possibility is treat this like an FGR and do a surveillance every 2 weeks and make sure it is included there. If you find it falling from a normal to a low normal, start getting worried and start considering that you need to do something about this. So this is a newer inclusion when we assess morphology of the placenta. May I remind you that the 2013 guidelines, which were revised in 2014 from the Royal College, have clearly told us that abdominal palpation has limited accuracy for the prediction of an SG neonate and thus should not be routinely performed in this context. That serial measurements of the symphysis fundal height is recommended at each antenatal appointment from 24 weeks onwards, and this improves prediction. However, it is not infallible, and therefore we start using Doppler more and more whenever we have a clinical suspicion, whenever we have a clinical pointer, whenever we have a pointer in the patient's history, and whenever we have a doubt, and in particular for the surveillance of high-risk pregnancies and those that have shown any high-risk factor throughout this pregnancy. May I remind you that we will look for these complications, of course, at the 11 to 14-week scan by doing a uterine artery Doppler, but we will also repeat the uterine artery Doppler at 20 weeks because that will change my assessment for a hypertensive growth restriction. Remember also that I would then use color for my anomalies in anatomy delineation, but most importantly, that in the third trimester, I will do multi-vessel Doppler. Definitely the umbilical artery, the uterine artery, and the middle cerebral artery. And I like to include the ductus venosus because it gives me time to give my last dose of steroid. Yes, there's no recommendation after 34 weeks, but there is a recommendation. And the recommendation is that if you are planning to deliver urgently at 36 weeks, then it is still well worth it to give one dose of, one course of a steroid so that you can get a better outcome. And then, of course, when you're doing that delivery, you must also add magnesium sulfate for neuroprotection. So my take-home message is very simple. Color Doppler is an integral component of almost every obstetrical ultrasound scan, and growth scans are no exception. Every growth scan must be a Doppler scan. Otherwise, you're doing an incomplete job, and we have enough evidence to this. Technology is now extremely advanced and complex, and a dialogue between the practicing obstetrician and the imaging expert is necessary for optimal utilization of this technique. And thank you ever so much for your attention.
Thank you, Ashok, for your lucid talk or elaborative talk on how to organize and how to manage the fetal growth restricted babies. And now we'll have Naren's video, which we will play it now about the how to get these Dopplers done. And that's because you were there, so we have taken your lecture before, then the Naren. So now we'll have Naren's talk, and then we'll have some question and answer if at all we have got it. So over to you, Shambhu. Can you play the video?
A very good day to all the listeners here today in this fantastic ISWOG webinar. I thank Dr. Prashant and Dr. Ashok Khurana and the ISWOG executive for giving me this opportunity to be with you, all of you, discussing two very important topics, the first trimester and the fetal growth charts. So today we're going to talk on fetal growth charts. I'm a practicing OBGYN from the city of Agra at my institute, which is, you can see behind, the Ujala Cygnus Rainbow Hospital. So what we're going to talk today is on growth assessment, fetal growth assessment, the concept of fetal growth retardation, and the plotting of the growth charts. So remember, it is fetus first for everything. So fetus problems in first trimester, second trimester, growth, color Doppler, anomalies. It is fetus first for all of us. And we are the privileged, obstetricians are privileged to be looking after two lives, the mother and the fetus both. The key questions which we need to answer are, what are the risks of abnormal fetal growth patterns? What measurements we should be taking to assess the growth correctly? What are the typical ultrasound features of poor fetal growth? What are the typical ultrasound features of macrosomic fetal growth? And how is fetal growth assessed in multiple gestations? That we will try to cover in this. When we talk of normal fetal growth, it depends on two components, the genetic potential and the substrate supply, the maternal nutrition. The genetic potential is both parents, mediated through growth factors like insulin growth factors. The substrate goes through the placenta, uterine, and maternal nutrition. Then we need to clinically evaluate every pregnancy. So we measure serially, and we measure the symphyso fundal height, we measure the abdominal girth and say that everything is going. And the fundal height 1 centimeter per week up to 14 to 32 weeks. A lag in fundal height by 2 weeks, then you start suspecting growth retardation. A lag by 4 weeks, you're suspecting severe growth retardation. Now, this has got a very low sensitivity when used alone. Only 44% times you're going to be correct. So we need to date the pregnancy correctly. And dating scan is done at crown rump length, not 7, I would say 8 weeks to 10 weeks. You have an accuracy of plus minus 3 to 4 days. At 10 weeks to 14 weeks, you have a accuracy of plus minus 5 days. The margin of error in measurement of CRL is plus minus 1.2 millimeters. That is 2 standard deviation if you're measuring it. And the gestational age, as by a thumb rule, is calculated by CRL plus 6.5. And you got to have the fetus in the right position, semi-flex, little bit of liquor here, rump and crown to be identified, outside to outside measure. So that gives you the dating scan. And that is the most important scan for growth. Now, sonographic evaluation of fetal biometry is after this is the biparietal diameter. And you measure the biparietal diameter and the head circumference. And then the transverse cerebral diameter and the abdominal circumference and the femoral length and the measurement ratios of all of them. So all those are the measures, the BPD, the HC, the abdominal circumference, the femur length, measured in the correct place, as you can see in this graphic representation. The BPD, the femur, the abdominal circumference, and the femur length, and the transverse cerebral diameter. And that gives you the biometry in the second trimester. Now for BPD, you have to slide the probe correctly, so you get the correct plane. The FARX is midway, and you get the arrow sign. And the cerebellum and across the thalami, and then you see the cavum septum pellucidum here. And the arrow points posteriorly. So the biparietal diameter is measured at the thalami, cavum septum pellucidum, the sylvian fissure, and you have to get the Trishul sign as in India, or the arrow sign as we call it. And the calipers have to be placed outer to inner, outer table to inner table. And you use this if the head is too flattened, too rounded, you use the cephalic index or the head circumference for it. There are limitations. If it is flat or rounded, brachycephally rounded or dolichocephalic elongated flat, then we use the cephalic index. That is biparietal diameter divided by occipitofrontal diameter into 100. And in breech also it may be difficult. So there will be problems in breech, ruptured membrane, twins, and then you do the cephalic index, 78. So BPD errors may be observer error, oblique section, not in the BPD section. And head parameter, then the second is the head parameter. You measure at the same place as the BPD. Towards the end of the pregnancy, it is the best indicator for gestational age, unaffected by the head size. So it is not affected in growth retardation until very late stage. That you have to keep in mind. The BPD and HC landmarks, we've already told you, CSP, cavum septum pellucidum, FARX and thalami, and the arrow sign. Then we come down into the abdomen and we get the abdominal circumference, because now we want the soft tissue measurement so that we can calculate the weight and go and do the growth patterns and do the fetal growth retardation diagnosis. So again, the AC is measured in the correct plane, and this is the correct plane where you see the stomach bubble, you see the spine, and you see a J-shaped umbilical. If you see the full umbilical vessel, then that means your section is oblique. So that is not the right section. So of course the liver parenchyma, and that is the umbilical vein entering into the liver. So that's what, and fetal vertebra and stomach bubble. These are the signs to see for abdominal. Then the femur length. Femur length, get it as straight as possible. Avoid the epiphysis. Only measure the diaphysis end to end, and the distal femoral epiphysis, you must remember, appears at 35 weeks, 36 weeks. It measures all that. So if you go to the pelvis and rotate the probe by 90 degrees, and you will get the femur length. So very, very accurate. Measure both the femurs. Based on all these, the ratios can be calculated. HCAC ratio, HCAC, femur length AC ratio, femur length AC ratio over about 23 is considered abnormal. HCAC ratio above 2 standard deviation is predictive of growth retardation. So these ratios can be used for fetal growth retardation diagnosis and treatment. Then we need to do the fetal weight estimation. That is done automatically by the machines now using the Shepherd's formula and smallest mean differences. It is not applicable, the formula, if the weight is less than 2 kgs. So it is over that we are interested. So you do the BPD, the abdominal circumference, the femur length, and the machine will calculate the fetal weight according to Hadlock, Campbell, Shepherd's, or Merz formula. That is what the Hadlock is the most reliable formula for more than 3 kgs with the least errors. So the normal fetal growth, we told you, depends on genetics and the nutrition and the substrate supply, and this growth will be now charted on the charts. These fetal growth charts are available free of cost on Google. You just type fetal growth chart. It will give you a chart, and then you take a printout and keep charting on it. Or it is also available in practically all the machines, and it comes out as a report. So it automatically, the machine will chart. And you see if it is the growth chart, if it follows the red line in the center, it is normal growth. Falls down, it is less. If it falls up, it is macrosomial. So Intergrowth 21st project study showed that these growth charts were very, very important. And the WHO study shows the WHO fetal growth charts for estimated fetal weight and biometry show This is a little bit variation in different parts of the world. So we need to have growth charts for all the ethnic and all the countries also. And that's what. So no international agreement exists on which growth chart is the best. So we have started looking at our own. And we have 2 centers in India who have given their growth charts, maybe more, but these are the published by Paras Center in Ahmedabad, Dr. Prashant Acharya, and Mediscan from Chennai by Dr. Suresh. So these are the Indian biometry growth charts of the trends, and at every week, and thousands of cases, and this is now being published as the Indian biometry and published in 2018. And clinically relevant centiles have been marked here. The 95th, the 50th, the 5th, and the 3rd centile or the less centile. Similarly for HC, and similarly for AC, and similarly for femur length. So these are the Indian charts in 2018 given by Ahmedabad, Dr. Prashant Acharya. And similarly for everything, the fetal weight, estimated fetal weight also. So these have been published, and we are starting using this, and they were published as in this journal, is in the Ultrasound OBGYN journal, the white journal. So you start looking at these charts and you start defining the growth retardation for Indian population as vis-a-vis compared to the European population. The term 40 weeks birth weight of fetus in India is 3 for normal primaries, having an average weight of 52-60 kg with an average height of 152. While for the European, the normal is 3.4 kg. So Indian babies are a little bit smaller in growth, and that is what we need to keep in mind when we are doing the fetal growth retardation studies in India. Then every fetus has a potential to grow, and failure to attain this potential is growth retardation. This growth retardation may be early onset, late onset, which may be symmetric, asymmetric in early, and symmetric, late, asymmetric, both in the early. Early insults are more likely to lead symmetric rather than asymmetric growth retardation. And the most important cause here is the chromosomal genetic or the vascular. So let's see what are the guidelines. And I thank Dr. Suresh of Mediscan for helping us make these guidelines. So guidelines number 1 is that you assign a gestational age by accurate measurement of crown rump length before 13 weeks of gestation, 8 to 13 weeks of gestation. Understand that there is a variability of 4 or 5 days. Then do the serial scans for growth. So accurate technique for measurement of CRL is very important. Here we've shown you people measuring it at all different places, and these are all wrong. So you have to get the right way. So your first trimester biometry is very important. And you compare your first trimester gestational age by ultrasound with LMP. If the difference is less than 1 week, we will assign the EDD according to the LMP and not according to ultrasound. If the difference is more than 1 week, then we reassign the expected date of delivery. Because the error is 5 to 7 days. So up to 7 days, we take LMP as the EDD. Because the variability is 5 to 7 days. Okay. Now, once you have assigned a EDD, you're not going to change the EDD and not going to blindly depend on the repeated machine generated data. You cannot have 4 or 5 EDDs. 1 EDD in the first. And this is a case study how we have assigned the expected date of delivery because there was a discrepancy of more than 1 week. The warning is do not change the dates in subsequent scans. What to do in the second trimester? The patient has not come to you in the first. The second trimester, head circumference is the best. You will change the EDD by LMP only if the difference is 8%. And we'll follow what is called as the rule of 8. Do not change the EDD after you give it here also in subsequent scan. So 13 to 25 dating is inaccurate. And if it has to be done, it is done by the head circumference and the rule of 8 or a difference of 10. Here is how you do it. 14 to 20 weeks, LMP gestational age, ultrasound gestation. Difference 7 to 10 days, LMP date continues. Difference more than 10 days, you have to correct the EDD and reassign by ultrasound. So dating beyond 26 weeks is preferably avoided. And if the patient presents late, you cannot date the pregnancy. You just have to do the serial scans to look at the growth. So same parameters can still be used, but there is going to be very high inaccuracy of dating after 26 weeks. So guideline number 2 is after fixing a gestational age in first or second trimester, do not change this date in subsequent scans and do not use machine-generated data blindly. For the second trimester, we also use the rule of 8%. So see, by LMP, the date is 155. By the ultrasound at 20 weeks, the date is coming at 142. So the actual difference is 13 days. Now the expected margin of difference we told you is 8%. So 8% of 142 days is 11. So there is a actual difference of 13, but the expected difference is 11. So actual difference more than expected difference, then we change the date. So actual difference is here is more, so you will change the EDD by 2 days here. Okay, so that makes it very simple. So this will help us in diagnosing growth retardation. When you put all of this in growth charts in serial, one ultrasound scan will give you gestation. Serial scan will give you growth. You cannot predict growth retardation by one scan. It has to be done after 2 or 3 weeks and plotted on a chart so it gives you a visual effect. See the blue line. The blue line is normal growth. The black line started at the low centile, even falling more and even falling more. So this is asymmetrical growth retardation, what you're seeing here. And that can be done by these. So the guideline number 3 is for diagnosis of growth retardation, use abdominal circumference and expected fetal weight. And you will get an accuracy of 85% by using weight and 98% if you use abdominal circumference. So that is the predictive value. Now fetal weight is most accurate method is Hadlock or Warsaw's, and you put it on the growth chart, again the 10th centile or the 3rd centile, and this will give you whether the growth is asymmetric or symmetric. Another feature is the fetal environment. So if there is oligohydramnios and it is persisting, that also will tell us that this fetus is growth retarded. But the sensitivity is only 24% if you depend only on an AFI less than 5. But it is specific for growth retardation. It's 98% specific. So let's see some growth charts. Diagnosis and dating of growth. First scan done at 20 weeks here. That was your gestation. Perfect. That second scan done after 3 weeks, still falling in middle. Perfect. The third scan done at 30 weeks is gone up the center and touching the upper line. So it is, baby is growing better and maybe it may cross the upper line centile and become macrosomic also. So this will tell you how the fetus is growing. So first dating scan and then you do the growth scan. So this baby is growing well and nothing to worry here. So your guideline number 4 for growth retardation is you must plot all fetuses with growth chart and have a visual effect, and the plotting is done 2 to 3 weeks. Growth restricted babies will not be parallel to the normal curve. The normal curve here is the blue one and the black one is the other. So it was parallel here and then it is dipping more. So this is a growth restricted asymmetric baby. And then you can do it for everything, for CRL, for BPD, for HC, for abdominal circumference, for weight by the other method, transcerebellar diameter, and you chart all the growths and uncorrected growths and then come out with that this fetus is growing well or this fetus is growing. So charts have to be maintained, especially for head circumference, abdominal circumference, femoral length, and fetal weight to give you the correct. Growth restricted babies will be not parallel to this chart. Let's look at this baby. The first dating scan is yellow mark. The second dating scan is the second yellow mark, then the third yellow mark, and the fourth yellow mark. So light blue. So this baby is here. It's not parallel, and it is catching up to the lower centile. The other one is going even more down, and this is growth retardation. So based on this, you will classify growth retardation as small for gestation or large for gestation. Small for gestation are low growth potential and or IUGR, and large for gestation is high growth potential or macrosomia. Look at the parents. Small parents will have small babies, big parents will have big babies, genetic potential and substrate potential. And you will mark them again. And this is a SGA, or the small for gestation babies. We're growing now. This is a growth retarded baby because it started normally and then it dipped from the lower centile, lower line, red line. So the visual effect is telling us this is growth retarded. So intrinsically small babies, low growth potential babies, and 40% will be growth retarded. That is the classification for small for gestation baby. 20% normal small parents, 40% low growth potential, and 40% growth retarded. So constitutionally small babies may be normal and they are left alone if their color Doppler is normal. If it is small, then you have to identify the etiology if it is growth retarded. Etiology could be fetal, which is known to us by karyotype or by anomaly scan. Etiology could be maternal by doing a maternal scan for chronic diseases, chronic heart disease, kidney disease, diabetes, infection scan, all that. And the etiology could be placenta, where the nutrients are not going, and this is diagnosed by color Doppler, looking at the uterine artery and the placental perfusion. This will tell us the pattern of fetal growth retardation and their outcomes. So anomalies, survivors, neonatal deaths, gestational age of the baby, respiratory distress syndrome, preterm, symmetric, asymmetric, or for gestation, all can have poorer outcomes if these abnormalities, if these are there, anomalies are there, or the problems. And that is how we, again, by putting them on growth charts, we can make them out. Again, this shows that when you've done a first trimester screen, biochemical screen by PAPE and the HCG and the inhibin and the quadruple markers, how that will predict that which baby is going to go towards growth retarding. Because these are placental markers, and if the placental markers are out of mom, then they are likely to have a poorer placental flow and will lead to asymmetrical growth. Or if they have chromosomal anomaly, they'll have symmetrical growth retardation. So if there is an abnormal marker, then the management strategies are counseling, fetal activity, symptoms of preterm labor, preeclampsia, assessment again in the second, third trimester, and potential diagnosis of placental abnormalities, especially accreta and placenta previa, and all has to be done if these markers are, the placental markers are abnormal. So you will look for chromosomal anomalies, triploides 18, 13, 21, trisomies 18, 13, 21, monosomies, Turner's and Klinefelters, deletions, ring chromosome, uniparental disomies, confined placental mosaicism, all that. And the others, when we do the 20-week scan, we look for gross structural anomalies, fetal infections, genetic syndromes. So growth delay may be the dominant feature in all these. And 20% of these will be growth retarding. So these are there. For triploides, it is early asymmetrical. For trisomy 18, early asymmetrical. For trisomy 13, mild growth retardation. For Turner's, mild growth retardation. For trisomy 21 Down syndrome, the growth may be normal and it may be late growth retardation or late IUGR. So that is how we try to figure them out, what is going wrong. And to figure this out, anatomic scan, uterine artery Dopplers, toxoplasmosis, antibodies, studies, karyotype, and the other things have to be done. In placental dysfunction, you need to study the biometry, and you need to study the compensatory mechanism, and you need to study the environmental mechanism. So we do the biometry by measuring, we do the compensatory mechanism by color Doppler, we predict the hypoxia by Doppler, and we look at the environment by doing a AFI and a CTG or a complete biophysical profile. So ladies and gentlemen, to define gestational age is a single point estimation by LMP or biometry, and growth is a multiple point estimation. Gestational age tells you how old the baby is, growth tells you how the baby is growing. And based on this, the IUGR or the growth retardation is defined as fetal weight below the 10th centile or 2 standard deviation, or the abdominal circumference less than 2 standard deviation for that mean gestational age is fetal growth retardation. And that is how we define them when we put the plan. And this has a big impact on prenatal mortality, morbidity, stillbirths, preterm chances of intrapartum asphyxia, and landing up into NICUs. And again, when you run into them, try to find out what is causing this: fetal, placental, maternal. Fetal will be chromosomal anomalies, malformations, multiples. Placental will be abnormal invasion, abruption, filamentous cord, accreta, chorioangioma. Maternal will be genetic, constitutional, nutrition, starving, hypoxia, vascular, renal disease, antiphospholipid syndrome, environment and drugs, and infections. So we need to assess them, assess and balance and make a diagnosis of it. So ultrasound evaluation of fetal growth retardation will be, again, to summarize, give a correct age, assess the size, do serial monitoring, plot it on a graph to get a visual, do amniotic fluid assessment. If there is a color Doppler, do color Doppler, refer it to color Doppler, and do a complete biophysical profile to try to deliver the fetus safely. So early dating, adjust disparity, do not change the EDD with subsequent ultrasound, follow up with visual impression on the growth charts, and do a color Doppler where required. If Doppler is available, it may identify fetuses with fetal growth retardation who come late, so late fetal. When Doppler is studies normal, the diagnosis of FGR is doubtful. It may be constitutionally small, normal fetus, and small fetus with normal Dopplers are left unmonitored. I thank you very much. We have brought all this material in our step-by-step series, which has now been translated into Spanish and Chinese also. And we have a textbook on ultrasound and obstetrics gynecology for Indian Foxy, and that we would love if you can go through this. Thank you once again, ISWAG. Thank you once again, Dr. Prashant Acharya, Dr. Ashok Khurana, Professor Ravi Choi, for involving me in this very, very interesting webinar academic series for India and for the world. Thank you very much.
Thank you. Thank you, Naren. Excellent talk. And now Naren is live also. Any questions to everyone, which we can always take it across. And meanwhile, there is one demo session. So I will show how the things should be done. Technically, I'm going to share my screen and put a slide just like this, so that we all can have how to do the Dopplers, especially when you are dealing with your fetal growth restriction, presentation, or evaluation. I hope my screen is visible.
Yes, it's visible, doctor.
Okay, so we will start with the uterine artery Doppler. When you are dealing with uterine artery Doppler, you have to look for the crossing of the vessels, which you can see. Just hold on. I'll just mute the. So a crossing, whenever you identify a crossing of uterine over the iliacs, that's the point for interrogation on this side or this side. Put your gate has to be 2 millimeter. And then when you run your Doppler, you will find that at the 28 week, this is a 28 plus 3 week. This is what exactly Ashok was telling you, that if you find a high resistance flow along with a pre-diastolic notch at almost, this is a third trimester, and look at a PI value. This is 2.68. What we created a thumb rule that a first trimester mean uterine PI has to be below 2.5. Second trimester has to be 1.75. And the third trimester has to be below 1. If you have got PI above this, that means you are talking about that there is some issue with the placentation. So 1.75 and 2.5. So now from left side, I have gone to the right side. Again, the same situation, crossing over 2 millimeter gate. Just look for the value of your PI value, and 2.68 was there, and this was 1.05. So 2.6 and 1, that is practically 3.68, 3.75 divided by 2 is practically 1.35, which is way above the normal value. So it suggests that your placentation or the placenta receives less blood. So look for
the umbilical cord, look for the free loop of the cord, identify the umbilical artery, and have a tracing. Again, just have a look at this 2 millimeter gate. Filter has to be 60 hertz, and then once you start taking a measurement, you know that there is a good flow in the diastole, but I am not happy with the amount quantum of the flow which is moving forward. In the diastole, it is much lesser flow. You've got PI value of 1.87, which is way above normal range. So from that, just go to the base of the skull, and to identify the base of the skull, that you will find this process, which is, because it is bony, it will appear much bright echogenic. And at the same time, you switch on your color, and then you will have to have a power Doppler. I mean, you have to gate on, and you take your Doppler measurement. Look, one thing which I have done is, if you can see this yellow line, that yellow line, I have corrected the angle. Because why I have corrected angle? Because I'm also interested in looking at a peak systolic velocity, which is also important marker for looking for early growth restriction changes. So from there, again, what I will demarcate is a PI value, which is 1 point. I'll go back again and look at a PI value. This is 1.80, 1.46, 1.46, and look at the umbilical artery PI. The umbilical artery PI is 1.87. So which is the CPR value is already altered. So 1.84 and 1.46. That means you are dealing with a fetus which has got an altered CPR. But this being less than 32 weeks, for me, the importance of these middle cerebral artery Doppler is much lesser, because it's an early growth restriction where my decision making is going to be on umbilical artery and ductus venosus. Moving further from there, I will also show you how to take the aortic isthmus Doppler, whether you use it or no, don't use it. It's a different argument, but I'm going to show you the technique. So this is, go to the 3-vessel view, 3-vessel trachea view. From here, this is the aortic isthmus, and from here the pulmonary artery comes. So I'll just go through at this juncture. This is the aortic isthmus, and when I interrogate that vessel, it gives me an idea, okay, there is a still forward flow. So the cerebral vasodilatation, it is there, but it is not to that great extent. That's the information which you will get it. The ductus venosus, get a sagittal view, and look for the aliasing. Look for the aliasing. This is the base of the heart, and that this is where you will find your ductus venosus is. And then just interrogate that vessel, and you will have a typical classical M wave kind of pattern, and you can measure the PI value. It should be less than 0.8. Anything below 0.8 is reasonably okay. When it rises to 1, start suspecting that there is some kind of fetal hypoxia as far as your complete diagnosis is concerned. This is what I have written here. I started doing at 9 hours 41 minutes and 43 seconds, and finished all Doppler at 9 hours 43 minutes 43 seconds. So it's practically 2 minutes. It's easy. It's not difficult, provided you know. I'll start the video once again. I'll now have a look at all the Dopplers simultaneously, and then Naren and Ashok, we will take the discussion further forward for growth restricted, because growth restrictions diagnosis and management is still everyone needs to come to the same page, and because still we are struggling to make people understand how you should organize the manage the fetal growth restricted babies. The uterine artery Doppler, yes, it is important for the 3rd trimester also. Both uterines are done. Then free loop of umbilical cord. Yes, I have identified the free loop. Look for the aortic umbilical artery pulsation. Put your gate. It is not necessary to invert, but still I always prefer to have the similar kind of the signature of all arteries or the vessels in the same direction. After measuring umbilical artery, just middle cerebral artery, again putting and also look at the angle correction which I am making. Yes, now I have corrected the angle. So I will just correct the angle, take a measurement, Also looking for the peak systolic 43 at 28 week, which is quite normal. PI value, CPR altered, 4-chamber going up to 3-vessel view, and then 3-vessel trachea view, and interrogate the aortic isthmus portion. Look at the forward flow. If it is forward, I'm not worried. If it is reverse, yes, definitely I'm worried. And then look for the ductus venosus, and that is where we look for the possible changes in the ductus venosus and look whether there is a failure or not. Does this baby require urgent delivery without steroids? Even if you have got 4 hours before you plan a surgery, please give a shot of steroid so that it can prevent at least intraventricular hemorrhage, and it will also help in necrotizing enterocolitis. A magnesium sulfate and 1 shot of steroids will definitely help now in reducing this complication. So this was your live demo about this, and I think we will what we are going to discuss is what to do further now. Naren, your comments, and Ashok, your comments.
So this is what wonderful demonstration of color Doppler, as it is said, 2 extra minutes of this thing, and the values come automatically, and the machine gives you the PI automatically. Higher the PI, worse the value. That is. And if you just want to have a visual look at the waves, you look at the diastole and the systole. If the diastole is lesser than 30% of the systole, that again tells you it's a problem case. Except in middle cerebral, where it is, if it is more, that is a problem. So it's quite simple, and that will make us decide on the treatment, how much pregnancy you can carry forward, and when to deliver and how to deliver. So Doppler will pick up early growth retardation, compensatory mechanism setting in, fetal hypoxia, fetal hypoxemia also a little bit hypoxia, and don't let it go to acidosis. If the ductus venosus becomes absent diastolic or reversed, then the baby's already gone into acidosis. And even if you deliver this fetus, it is going to land up into necrotizing enterocolitis. And if you feed the fetus early, it comes out crying, it dies after 70 hours. So why? Because the gut has been without the blood, and early feeding is not advocated in such fetuses. So again, your good neonatologist, a good NICU care is what is needed. So very well done. You plot a growth chart, has growth charts. If the machine does not have, go to Google, type growth chart, and you get a printout. And just on that printout, you can just put all the growth charts and look at and make a diagnosis of growth restriction, growth retardation, and how the growth is. So that's my comment. Prashant, fantastic webinar right through. I was connected. I'm on a highway. That is why it is going off and on, off. So
I know. Ashok, your comment.
Well, fantastic. I want to remind the audience that yes, a Doppler multivessel, as you can see by someone who has experience, is no more than 120 seconds. But don't be in a hurry to do it until the conditions are ideal. That just like in your case, we waited until the breathing had stopped, and we waited until the movements had stopped, and then it was an easy job. But if they keep struggling in a moving fetus, it makes no sense. So they must wait for that ideal condition. And then it's something that is so useful that there's no question of working without a multivessel Doppler. Fantastic. And it's really been put together so beautifully because we managed to discuss every aspect of growth restriction. We've done brilliant fetal anatomy today, and I know that people will be very happy with this program. Thank you for putting it together, Prashant.
Thank you, Ashok. I hope.
One more comment, Prashant. One more comment.
Please.
People tend to change the EDD by every subsequent ultrasound report they get. So that again, they don't have to, because ultrasound generated EDD cannot be used. How can an EDD change? Once you've given an expected date of delivery on the first scan and the later scans, and then how can you have 4 EDDs? The BPD is showing 1st November, abdominal circum, and the clinics will just print that report. They should scratch it and print an average and then plot the graph. That is why growth retardation is very important.
True.
Very, very correct. Very correct. I hope our team is a great team, and I think people must have loved the program throughout the day. Since morning, we are discussing early pregnancy, first trimester aneuploidy, first trimester anatomy scanning, how to carry out second trimester, phenomenal lecture by Ashok. Then again going back to the fetal echocardiography, fetal neurosonogram, then again growth restriction, growth management. So we have tried to cover in one day. We have tried to given you a lot of scientific stuff, pure scientific stuff by internationally renowned faculties today. So again, thank you very much, Ashok. Thank you very much, Naren. Ravi, you are not online, but still thank you, Ravi. And again, I should thank Mankind Pharma team to support, and Shambhu to crystallize everything, and Ashutosh for putting up the program from a Mankind. Thank you very much. Thank you everyone for support. And any words from you, Ashutosh?
So I would like to thank all the experts.
I hope this is just the beginning. I hope this is just the beginning, and we'll have a whole series of such webinars.
Sure, sir. Looking forward for your guidance and support on all the programs. So I would like to place a formal vote of thanks. So before we conclude today's marathon webinar on obstetrics and gynecology ultrasound, the recent advances into 2023, it's a privilege and great joy for me to extend vote of thanks for all those who have contributed in one way or the another. I would like to have special thanks to Dr. Prashant Acharya to putting up all the effort on our behalf and basically making it possible in such a renowned banner. And I also sincerely thank all the attendees who have logged in throughout the day. And I could not put up all the questions because there are more than 200 as of now, and they are pouring in. So I would compile everything and then post it to Dr. Prashant Acharya for a comprehensive answer, so that, and there are a lot of queries about your books and everything, resources. So maybe we can shoot a detailed mail regarding Dr. Ashok Khurana's inputs and Dr. Naren Malhotra's books, so that they can get in leisure time to see to it. Thank you very much for your time, sir, and patience to answering all the queries. Thank you very much, sir. Looking forward for your such programs.
I expect that you put questions to all three of us, so that everyone will chip in to give the answers. Ashok, Naren, and to me also. All three, please copy to all three, and so we can take it forward that way.
Okay, sir. So I will mark a mail to commonly to all of you and then have answers, comprehensive answers.
Thank you.
Thank you very much, sir.
Thank you again, Ashok and Naren. Thank you very much for joining.
Thank you. Thanks very much.
Bye-bye.
Thank you. Have a great day.
Thank you.
Thank you.
Bye-bye.
The day is